and opening remarks.
Good morning. Thank you, Dr. Chavla, Dr. Anant Kumar, Dr. Rajiv TP, and all the faculty, esteemed faculty, including Dr. Mallikarjun. I welcome all of you. This is the continuing education in adversary. And adversary, we all know, we are facing, we are fighting. And in this COVID-19 times, we are getting used to certain new lifestyles, a new way of communication also. And maybe this is changing the entire education and the delivery of education and skills in the time to come. So in this continuing education in adversary arranged by USI ISU initiative, it is the first ever webinar exam. We should thank Dr. Surya Prakash and Arun Chavla for a lot of hard work which they have done. And with these cases and also selection of the residents, where we have massive response, we are not able to accommodate all the residents of final year, and we have selected randomly and also on the basis of at what stage of examination and the course they are, whether they have in DNB or MCH, according the instructions are there. All the residents are expected to be alert in all the cases and also in their session. We have divided the sessions into 3 sessions and 2 hours each, and after that 3 to 4 cases in each session, and question answers and feedback. So the format looks very impressive. Let us see that how we go with this and how we complete. But I am more than hopeful that with this eminent faculty, with this new norm to conduct the education, we are also in our institutions started the e-assignments and e-assessments, and accordingly we are giving the residents the attendance also, e-attendance, which will help them in their forthcoming exams, final exams. When they are not short of attendance, we are in touch with Medical Council of India and also respective universities and also national board also, that these all e-classes, e-assessments, they should be counted. So with this novel effort, first ever web based exam by Urological Society of India, and meticulous working and planning, which has wish you all the best, wish all the students very best. Take maximum advantage of this novel effort which has been undertaken in the tenure of Dr. Anant Kumar, and also which will follow with the Dr. Mallikarjun also. And our scientific programs in charge, Dr. Rajiv TP, Arun Chavla, my co-chairman with in the Indian School of Urology. It is all their efforts, and Dr. Surya Prakash, I hand over back to you, back to faculty for the further deliberations and further conduct of the program.
Thank you, sir. Thank you very much. Thank you for your kind words. May I request Dr. Anant Kumar, President, Urology Society of India, for his presidential address.
Good morning to everybody. Dr. Sood, ISU Chairman, Dr. T.P. Rajiv, Secretary, and Dr. Arun Chavla, Board of Co-Chairman of ISU, and all the faculty members, and especially those people who have worked very hard, Surya Prakash and Arun Chavla, for making this dream come true. As already said that we are in a very bad time, and it's a new experience for everybody. to learn. Everybody is attending various seminars, webinars, and seeing various videos, presenting various, uh, submitting various papers, and so a lot of academic activities are going on. And this is very good online platform, and we are learning. So let's see how this platform goes. And I'm very hopeful the way I have seen the program and cases and everything. Cases are very well selected, very common cases which are asked in the exam, and faculty is all very experienced. And very, very, I'm very confident that this kind of activities will give lot of experience to our students how to face the real exam which will happen whenever this situation will improve. So so I, and it is also good that there are a lot of students have applied. Only few could be accommodated, but other can see it. So that's very good, and they can learn it. And the one important thing is that RUPP has sent the guidelines for all the examiners. After the discussion, they should tell what should be the optimal response, how should you improve your communication skill, how should you give correct response. So all these purposes and that's the whole purpose. So this is the first one. Let's thank all the people who have worked very hard to make it possible, as well as let's hope that it will be very useful for all our students. With that, I would like to inaugurate this online platform for the learning the how to pass the exam. And so this uh, is now open for the, this webinar exam is open now.
Thank you, sir. Thank you. We'll have a formal opening after secretarial address. Please stay online. Now it's over to our young and dynamic Honorary Secretary USI, Dr. Rajiv TP, for his kind words.
Good morning, President, Urological Society of India, Chairman, ISU Dr. Rajiv, Co-Chairman, ISU Dr. Arun Chawla, and my esteemed panel of faculties. This program, in fact, Dr. Surya Prakash sent me a request way back in the end of April 2019, and I promised to incorporate in the calendar of events for 2020. And it was one of the main event which was incorporated in the earlier calendar for 2020. But unfortunately, because of the unprecedented so we had a discussion between the ISU chairman, co-chairman, and we decided to incorporate in as a virtual online exam. This is the first virtual online practical examination ever in the history of Urological Society of India. And I am glad to say there was overwhelming response from the residents. We had kept it open only for the second year and third year residents. In fact, there was a total registration of 178 residents, of which 123 were from the third year and 55 from the second year. And we have grouped them, and ultimately even the third year residents we cannot accommodate fully. We were able to going to accommodate only 45 in the first line, and we have kept 15 as reserve, and there is again 63 left in the final year. But I would tell those people who have been kept aside, please don't be dejected. I assure you that I will have one more such a virtual practical online exam in the month of August. And this will be especially for those who have been left out. Others are also able to participate, so that they will be given a chance once more before they go into the university exams, which will be scheduled later part of September or so. So we have here well experienced CH. So you will be facing the questions, and I will request all the examiners to give marking or grading to the candidates and send across back so that we can give them their assessment of their performance in the this virtual online exam. With these things, I wish everyone all the best. And this is a program, a dream program. From the outcome, we will know how we are able to conduct an online exam. It is our first experience in such a thing. I hope all the faculties will do their level best to make it a grand success. With this, I hand over my thing to Arun Chawla for the further proceedings.
Yeah. Thank you, sir. Thank you for your kind and encouraging words. Over to you, Navneet, for a brief invocation ceremony, and following which I'll request President Dr. Anand Kumar, Secretary Dr. Rajiv TP, Chair Dr. Rajiv Sood, and President-elect Dr. Mallikarjun to declare it open after invocation. Navneet, over to you to play the invocation. Voice is not there, Navneet.
Virtual lamp lighting.
No, Navneet has to unmute himself. No, Navneet is muted. Now he is unmute.
Voice is not there.
It's okay, sir. God bless all of us.
Yeah, thank you, Navneet. We have to bear the problem of running a video on Zoom, but with the blessing of God, we'll start. May I request the President, Secretary,
Open.
I declare this online online practical examination open.
All the best to the faculty and the participants in this online exam.
I declare it open, the first web-based examination by a new novel effort, Urological Society of India.
Thank you very much. Thank you, Dr. Anand Kumar. Thank you, Dr. Rajiv TP. Thank you, Dr. Mallikarjun. Thank you, Dr. Rajiv Sood. And thanks all the faculties for being there for this inaugural ceremony. We are already 7 or 8 minutes late. I think we'll conclude this opening ceremony. The formal vote of thanks will be after the end of this whole webinar by Dr. Surya Prakash. So if you allow me, we can break open for the first section. Is it okay, sir?
Yes, sir. Go ahead, please.
We conclude with the thanks from the bottom of heart to all the faculty and all the office bearers of USI and ISU. Thank you.
Thank you.
May I request the examiners for the first session to keep their video and mic on. Dr. Shravan, Dr. Murthy, Dr. Keshav Murthy, and Dr. Hemant Pathak.
Yeah.
Okay.
Note the names of the candidate also, sir. Candidate for the first.
Dr. Surya Prakash.
Yeah, please call out the candidate for the first case.
Yeah, they are already logged in.
Yeah.
Navneet. Navneet.
Yes, sir.
Yeah. Are the first three candidates there ready?
They are all ready, sir. They have to just put on their videos.
Okay.
Sir,
They are unmuted as well.
are you able to see the PPT slide?
Yes,
Dr.
Surya Prakash.
Abhishek Johari, please put your video on.
Yeah.
Dr. Abhishek Johari, correct. So
We-
everybody can hear to.
All the three candidates are there for the first case. Navneet?
Yes, sir, they are present. Dr. Abhishek Johari, Dr. Akshay Kriplani, and Dr. Abhishek Shah. They are all there with their video and mics on.
And then over to examiner, sir. Surya Prakash?
Yes, yes, sir.
Examiners are already there. You can start with the
So good morning to all.
first case presentation. Yeah.
We have 2 long cases and 3 short cases in this session. First, we'll start with the long case. Dr. Seshamon, my colleague, will present the case.
And the time.
Questions, and maybe the examiners also can ask what else you want in the history. In that way, we have made the slides of case history. Now we'll start the case. Dr. Seshamon will present the case.
Sir, he is a 66-year-old male patient, Mr. SR. Is a retired government employee from presented with the chief complaint of frequent urination, nocturia, and urgency since 1 month. Patient was apparently asymptomatic. Then he developed nocturia 3 to 4 times, daytime frequency 8 to 10 times, urgency and occasional urgency incontinence since 1 month. There is no history of
who is the candidate?
Sir.
Yes,
sir. Yes, sir.
Who is the one? Abhishek?
Yes, sir. Yes, sir.
So Abhishek, what do you think about this? 66 years old man coming with mainly lower urinary tract symptoms.
So it's a 66-year-old man presenting with irritative lower urinary tract symptoms.
Of duration?
Of duration just 1 month, sir. So I would like to ask.
Is it, you think you can believe it in 1 month? Is it
Sir,
a
I would
short
like
duration, you think?
Yeah. Suddenly, previously, non-bothersome LUTS may be there.
However, it appears whatever they are given, it appears to be a short duration of 1 month.
Yeah, sure.
With the severe irritative symptoms, is it not? So
Yes, sir.
what do you think about at the age of 66? What are the conditions that come to your mind?
So, any urinary tract infection, bladder stone, or any obstructive bladder symptoms.
Why should they get a bladder infection or a bladder stone at this age? What are the reasons?
What is more common?
Yeah.
So most common with short history will be urinary tract infection, which is complicated with an underlying bladder outlet obstruction.
Yeah. So you have to think of at this age bladder obstruction due to?
Yeah, due to prostatic enlargement.
Yes.
Benign
prostate
or malignant.
Right.
Yeah.
What else apart from the prostate? Anything else?
So
not very common, but usually we see this condition, urethral stricture, at a younger age, around 50, 55, like that. Okay.
Yes.
Abhishek, your take on urinary tract infection. emergency. Does not come first.
Okay, sir.
Yes.
So this is Akshay, sir. Can I interrupt?
So what are these? Are prostate pathology, you think? Common
So
things?
commonly benign enlargement of prostate,
BPH,
or there may be prostatitis or malignancy.
Prostatitis. What is this? Prostatitis.
So any inflammation in infection in the prostatic gland.
No, you said it is BPH. Agreed. Next, what is the other things at this age possible?
So specifically only prostatic pathology would be, next
So what
would be
is the
some
pathology, prostatic. One you said benign hypertrophy.
yes sir, or
Benign
malignancy or any
Prostate
inflammation in the prostate, prostatic malignancy or any inflammation in the prostate.
See, inflammation in the prostate of 1 month duration, usually it will be long drawn process at this age. What you are talking about, prostatitis and all that, they are seen at earlier age. And they got a distinctive symptoms apart from this. Okay, right. What is this? No history of voiding symptoms, voiding lets. I think what is the
there are no history of previous voiding lets?
previous? Yeah, it is 1 month duration, short duration.
Short duration.
Yes. No history of prematuria, dysuria, dysuria, fever, pain abdomen.
Fever, pain abdomen. There is no history of loss of appetite, loss of weight. There is no history of backache, bony pains, cough with hemoptysis.
Why are you asking this history for backache and bone pains, all those things?
Sir, we would like to rule out any symptoms of metastasis if already are present.
So these are some of the metastatic disease of the prostate. You are asking backache and bone pains and all those things. Okay.
Examiners, please note that we have 3 students for this case. You can keep on rotating the question to the other 2 candidates, just to keep them busy.
Let's go ahead. What else you want now?
Other than
at this stage, history is okay, or are you satisfied?
Sir, can I answer, sir?
Yeah.
This is Akshay, sir.
Anything you want to know the history?
Sir, hello.
Abhishek?
Yes, sir. So, any past, other than this, any family history of
Family history of what?
prostatic malignancy?
Any
surgeries in the past?
Yeah, in the past.
Any endourological procedure, to be very more specific?
Yeah. Yes. Okay.
And any history of other comorbidities, diabetes, hypertension?
I think
or,
it's diabetic. Okay.
The patient is a diabetic.
Next slide, you can see that.
4 years, sir.
Diabetic, hypertension.
4 years. No other comorbidities. No previous genitourinary surgeries.
No previous surgeries.
Father is died of renal malignancy at the age of 15 years. No history of allergy to any medication. Personal history: patient is a vegetarian. Sleep is disturbed because of nocturia. Bowel habits are regular. Non-alcoholic. And patient is not a smoker.
Okay. Next, anything else?
No. No, sir.
Anything else you want? Any specific? Okay. Go to the next slide.
An general physical examination. Patient is conscious and cooperative. No pallor, no icterus, no generalized edema, no pedal edema. Vitals are normal. ECOG 1. BMI is 22 kg per meter square.
Yes. So what do you want to see in the physical exam? Is it? What are the important things you look for?
So pallor, pedal edema, those would be more specific for such patients.
Yes.
And his ECOG status and BMI, sir.
Okay. What else? The abdomen.
So abdomen,
external.
yes, sir. Abdomen examination, we would like to see any lower abdominal distension, or if bladder is palpable.
Yeah, for bladder distension. Okay.
Bladder distension. Any other external genitalia, we would like to rule out any the condition of the prepuce or the meatus.
Yes.
Any sign, any epidermolysis.
Meatus, you have to check.
Yeah, meatus.
Because these symptoms can be, meatal stenosis can produce these symptoms.
Yes,
okay.
So if the urethra is supple or not, any BXO changes, any discoloration changes are there. If any epidermolysis or symptoms are there. Other than that, on PR examination, I would further
On to PR, yes,
yes,
his performance status is 1. Okay,
yes,
satisfied.
For abdomen and
Yes,
external genitalia, there is nothing significant, as already discussed. So, distal
So
rectal
when you do a rectal examination,
Can I answer, sir?
Yes. One of you can answer. Abhishek.
So this is Dr. Akshay, sir.
Yeah, tell me, when you are doing a PR, what are the things you look for?
PR examination, sir, on a prostatic examination, first to start with the PR examination.
You do PR usually?
Sorry, sir?
What is the position of the patient when you do it?
Yes, sir. So the position can be a straight supine position in a lithotomy or a left lateral position. Sorry, sir?
In what position routinely you do the rectal examination?
Yes, sir.
Prostate?
So routinely we do it in a left lateral position, sir, with the examiner on the right side, with the examination with the right index finger.
Which is
so
a better
the examination,
position, you think? See, routinely we do in a dorsal position so that you can sweep your finger across the prostate. Of course, in knee elbow position or bending position, that is different, which is cumbersome. But in a dorsal position, you can feel the prostate.
Yes,
all
sir.
the borders, sulci, consistency, or you can sweep your finger from one end to other end so that you will not miss any nodules, anything. That is a better position.
Okay, sir.
Okay, next.
Yes.
What are the things you look?
So the specific to prostate, the prostate size, the consistency, if we can go above the prostate, the median sulcus, if there are hard any nodules palpable, if the nodules are palpable in which quadrant, on one half or both half, if the rectal mucosa is free or not.
Yes.
Tenderness is an examination of the prostate
Lateral
or any
sulci is
body.
very important, is it not? Not only the morphology in the median sulcus, lateral sulci also is very important.
Yes, sir. Yes, sir.
Yes. Okay, ask for the rectal examination findings in this case.
Intertone is normal, sir. Rectum is empty. Grade 2 prostate, no tenderness. Left lateral lobe nodule is there with apical induration. The median sulcus is felt.
You need any information? Some more we want to ask some more information. They did not mention the consistency of the left lobe. There is a nodule, they said.
Yes, sir.
What is the consistency?
Yes, sir. The rectal mucosa, if not
mucosa is free.
Yes, sir.
Mucosa free.
You can feel the nodule. There is hard inconsistency.
Hard. Okay. Okay.
So what do you think?
So there is a left. So one lobe has a hard nodule. carcinoma proliferation.
Next. Okay, prostate cancer because of rectal findings, you think?
Yes, sir.
So that is the only positive finding to say that a
So far,
possibility
yes, sir.
of prostate cancer will be entertained, is it not? Okay.
Yes, sir.
What are the other differentials for finding a hard nodule in the prostate?
Chronic prostatitis, sir. If the patient had a previous, if any history of previous BCG insertion in the bladder is injection, it can lead to hard prostate.
Oh, it is not chronic prostatitis.
Granulomatous prostatitis.
Yeah, granulomatous. You have to tell granulomatous. Yes. Tuberculosis. Prostatic caliculi.
Yes.
It is not. All these things. Okay.
Yes, sir.
Next, go fast.
This is the end of history, sir. History and examination.
So what else? Once you know that the prostatomegaly and a suspicion of a hard nodule, thinking of a prostatic cancer, what are the next things you look for? Or,
Sir, I would like to proceed with the diagnostic next investigation
yes,
of as an extension of my examination for an ultrasound and bladder thickness and the bladder morphology, bladder volume, the functional bladder capacity, the prostate size, prostate echo texture, and with the PVR, sir.
yeah, plain X-ray of the KUB, what for?
Plain X-ray, sir.
KUB, oh, KUB of the ultrasound you said.
Ultrasound, yes, sir.
Right. Any ultrasound findings, please? Ultrasound.
My voice is not going.
Have you done ultrasound? Yeah, you can see that. Essentially, I think both kidneys are normal, bladder well distended, and as you asked for a PVR, it is only 18 cc. And prostate is around
43 cc prostate is there.
yeah, about 50 to 60 grams.
Prostate, and there is small left inguinal head is also there.
Yeah, there is a 4 mm calculus.
Renal calculus is also
Which
there.
is insignificant, though it's not worried. So,
Abhishek, you're happy with this report?
Yes, sir.
Are you happy
Sir?
with this report?
Sir, if the echo texture of prostate and PVR has been, echo texture of prostate would have been mentioned, it would have been better, sir. If it is homogeneous or any
Volume. If they don't give you the pre-void volume, you will not know what is well-distended bladder. They could mention the volume.
post-void they mentioned 18 cc.
That's the post-void residue. The pre-void volume also should be mentioned in the
But
ultrasound.
anyway, they said well distended, take it about 300-400 ml. That. So the echo texture also, there's a routine ultrasound, abdominal ultrasound. Usually they do not mention about the echo texture. You really want it, you have to ask for it. And for that, they go for a truss, is it not? For echo
Yes.
texture, any nodule, all those things. Hyperechoic. What is the finding of a prostatic cancer nodule on ultrasound?
Yes, sir.
It is usually
What is the
hypoechoic, sir.
character of a ultrasound character of a prostatic nodule, cancer nodule?
It's usually hypoechoic nodule, sir, on ultrasound.
What is that? Hypoechoic.
Hypoechoic.
Yes. It can be also sometimes, yeah, commonly it is hypoechoic, and it can be hyperechoic also.
In around 30% cases.
Yes. Okay, with this, what else you want?
So next, I would like to proceed with a
ESA value.
routine examination.
Huh? Routine test. Anything you want to ask specific in the blood tests?
Serum PSA level in the blood test.
If it's a nodule there, large nodule, you want to look at the PSA levels definitely. So urine, you can look at it, essentially normal.
Yes, sir.
Dr. Murthy, kind request to involve the third candidate also. You have 3 candidates.
I am not able to. Can you hear me, sir?
Kriplani.
Yes, sir.
Hello? Who is Kriplani?
Sir, I am Akshay, sir. I'm here, sir.
Okay.
Third candidate is where? Where's the third candidate?
So I am here only, sir.
Yeah.
Please tell your name.
So Abhishek Johari.
Arun, if they do this case, the next candidate can do. Like that.
No, sir. One case for 3 candidates.
3 candidates. Okay.
Yes.
Okay. The next
you have to keep rotating.
So urine examination essentially normal. We did not find any. Okay.
Sir. Urinary tract infection. No hematuria, no UTI, sir.
Yeah, go next.
So CBP hemoglobin is 12 grams, serum creatinine is 0.7, RBF is 126.
Yes. So this is very clinching. It's an important point. So what is your comment on this? With a nodule there, hard nodule, and a PSA 100.
So with PSA more than 100, I think it is a metastatic CA prostate.
Why do you say so?
Because PSA more than 100. So because PSA more than 100 and the digital rectal finding, I can find a hard nodule in the one lobe.
So why do you say it is metastatic?
Because
you have not done any test to tell whether it's metastatic or not. Because PSA can
more than 20 will. PSA more than 20 is more towards the metastasis of the disease. Sir.
Yeah,
usually more than 20.
15, 20. More than that.
PSA more than 20 is more towards the metastasis.
Yeah.
But I think you should just commit on telling that the PSA is more than 100. It's likely to be carcinoma of prostate. You could evaluate and then mention that it is metastatic. Based on a serum PSA report, it's not correct to tell that it is metastatic CA prostate. Although over 20, they say that there are bone mets, bone scan indication, all those things are there. But it's always better to tell that it's likely that it's CA prostate, and I will investigate.
With prostate cancer, you do come across such situations, is it not? So most likely metastatic. Usually if it is more than 15 to 20, we expect metastasis, but there are exceptions for this. You find high PSA without any metastasis. Fine.
Dr. Murthy.
So what do you do now?
Dr. Murthy, we have very less time left for this case. We can progress little further because we have to discuss investigation and management.
What do you do now with this? You having diagnosed the cancer.
Yes, sir. So with this, we would proceed with a trust-guided prostatic biopsy, sir, specific for the systematic biopsy, sir.
Yeah, we can do MRI. What for you do MPMRI?
Sir, for that the local staging will also
staging also can be done by ordinary CT scan if you want to stage the disease. See, this is already a hard nodule with 100 PSA in a 66-year-old man. Think of common things, say prostatic cancer. Why do you want MPMRI? It is not a normal prostate. Okay, no need. If you want to stage the disease, you can do always a CT scan. Fine. So what do you do next, Kriplani? You want a biopsy?
Sir, I would.
A trust-guided
Yes,
biopsy you wanted. 12 core, is it?
Yes, sir.
Yeah.
12 core, yes, sir.
Yes. Sometimes, when the prostate entire thing is involved, even 6 or 8 cores may be affecting cancer. In this case, I think the cancer volume is very high. Okay, show us the histopathology.
Plus biopsy was done. 6 cores on the right side, 7 cores on the left side, sir. On the right side, Gleason score is 5 plus 4, 9, ISUP 5, no PNI, 5 by 6 cores are positive, 90% cores are positive. On the left side, 7 cores, Gleason 5 plus 4, 9, ISUP 9, 7 by 7 are positive, 90% of the cores are positive.
What is your impression on this? No doubt is a prostatic cancer, but what about the Gleason score and also the positivity or the percentage of scores? So what is your impression?
So since the Gleason score is 9 and the ISUP is 5, this patient is sort of I'm assuming it's adenocarcinoma prostate, sir. So this patient becomes a high risk
High grade
prostate,
cancer and high volume also it appears.
high volume.
Because 90% of the cores are positive.
Yes, sir.
Okay. So what do you do next?
I want to do the bone scan.
Yes, sir.
Yeah,
I start with a metastatic workup, sir.
Yes.
With the bone scan first, followed by a CECT.
You want to take a KUB, X-ray KUB. What do you find in a plain X-ray KUB?
Prostatic calcification can be seen, sir.
Osteoblastic bony mats.
Can you pick up on a plain X-ray KUB?
Yes, sir.
Mainly the axial skeleton you can find in the pelvis, all these things. So X-ray KUB is there?
No, not there, sir. We have done with bone scan, sir.
Bone scan. What is the isotope used in the bone scan?
Technetium 99 MDP, sir.
What is that?
Methyl diphosphonate.
Yeah, methyl, MDP. Fine, you read this.
There is significant uptake in the axial skeleton, sir. The vertebral level, I'm a little difficult to appreciate in the picture, sir.
So you think it is metastasis positive?
Yes, sir.
Bone metastasis.
Bone metastasis is positive, sir.
Yeah. Next, you want anything?
Next, I would want a CECT abdomen pelvis with a CECT thorax to see for visceral mets.
Yeah. So you want to stage further, visceral metastasis, or what are the lymph node status, any obstruction to the kidney. Okay, have you done the CACT?
CT is not done, sir. Chest X-ray was done. It was normal, sir.
Yeah. You can always do a CACT and stage the disease. You want the lymph node status and visceral metastasis, all these things you can see. So that you can, in the follow-up, we can prognosticate always.
Dr. Akshay, what is super scan?
So in case of extensive metastasis in axial and appendicular skeleton, the radio tracer is taken up by the metastasis and there is no excretion seen from the kidney. That scan is called a super scan.
So it indicates extensive bony metastasis.
Examiners, Dr.
What is the
Examiners,
treatment you offer?
sorry to interrupt. Please note that we have 5 minutes left for this case.
Tell me quickly, what is the treatment you offer for this patient?
Since this is a high risk, high volume metastatic CA prostate, I would, and patient ECOG is good, performance status is good, and no cardiovascular
Combination therapy. See, what is the combined or total androgen blockade? What are the treatments you offer? Now it is become a standard of care.
Yes, sir. So upfront abiraterone acetate is also an option, sir. Also a treatment now which can be offered to such a patient as per the Stampede and the Latitude trial. Upfront abiraterone acetate with prednisolone has shown a benefit in overall survival and the disease-specific survival, sir. So docetaxel with androgen different therapy or an abiraterone acetate with prednisolone with ADT are both the treatment arms, sir. Anyone which can be offered to.
Which patient?
Patients with high
patients who have visceral metastasis are the ones
Visceral
who do
metastasis.
well if you start with
or more than
docetaxel.
yes, sir. Or more than 3 bone meds.
And good performance status, sir.
Yes.
So what are the complications of this androgen deprivation therapy? See, one of these patients are followed up, for a long time. They
Yes,
come
sir.
with, yeah, what is that? Tell me.
Osteoporosis.
Yeah. What are the
So they come with
complications?
osteoporosis. Yes. Oh. They come with osteoporosis, hot flushes,
yeah,
increased cardiovascular risk.
Cardiovascular risk. Yes.
Tell me a few indications of, tell me a few indications for Digarilex, that is antagonists.
In case of an impending spinal fracture, sir, or
Okay.
impending bony pathological
Spinal
fracture.
cord compression. Spinal cord compression. Yes.
Yes, sir.
Immediate.
Yes. And some people also say now the cardiovascular risk is less. So if a patient is already having some risk factors, better to choose an
Antagonist.
Antagonist. How do you manage the hot flushes? This is another common side effects which often the yes. Yeah.
Tamoxifen.
I gave him the medicinal, sir. Medicinal acetate. Medicinal acetate.
What do
Estrogen supplement.
Acetate, progesterone. Venlafaxine.
Estrogen supplement.
So Arun, I think we are completed.
No,
and,
you can with the help of other examiner you can summarize and then we go for the next case in 1 minute.
Yeah. See, here is a
the common type of questions which the candidate will face if this type of scenario comes.
So 15 minutes questions.
No, sir.
No.
In 1 minute you summarize and we move to the next case.
Fine. Any questions from the candidates?
No, sir. No question. You just summarize in a capsule what are the common questions which examiner are fond of asking.
Here is a 66-year-old man coming with mainly, predominantly lower urinary tract symptoms associated with some comorbidities like diabetes and hypertension. And rectal examination showed a hard nodular prostate around 70 grams. And the metastatic workup has shown he has got multiple bone metastasis. This is the one. And the treatment which we discussed is mainly after confirming the biopsy, translated biopsy. Surgical castration or medical castration. Along with ADT, we are also thought of a combined androgen blockade in the form of abiraterone or docetaxel, which can be improved overall survival. That is what we discussed.
Yeah, thank you. Navneet, can you invite the group? Abhishek, Akshay, and Abhishek Shah, you can unmute and video off. Navneet, invite the other 3 candidates now for the second case.
Thank you, sir.
Amit, Ankit, and Ankur. Are you online?
Yes, sir.
Yes,
Okay.
sir. Who are the next candidates? Names?
The next candidates, Amit, Ankit, and Ankur. They are already there. Surya Prakash, can you start with the second case?
Yes, sir. 1 minute.
Dr. Chawla.
Yes, sir.
Yes, I have some message to give because I have been watching.
Yes,
and observing the things conduct. So I will say, if it is a right, that confuses the examinees as well as the examiner. Right. So that is the sanctity of the examination get lost. So this practical mock exam is to make the candidate practice what actually examiner want to know. Right. So there should not be any proxy.
Like
Secondly, that's I wanted to tell the audience or the residents rather, I will say, the resident, the examiner motto remains whether they can diagnose, they know the basic, they have got the basic knowledge of urology, and then can they apply their basic knowledge in practice? That only the knowledge is not enough. They have to know appropriate application of the knowledge. So that again, examiner will like to assess in the situation when there's proxy, because candidate also attention get diverted. I think if I am getting the message on the screen, the same will be applicable for examinees also, right? So I think that's not good. So I suggest nobody should put any suggestion on this one, because this is not for knowledge sake only. This is for practicing the examinees for the examination. So let there be actual scenario of exam should prevail in this, again, in this session. So that's my humble request. Okay. Right? Because again, here we are not teaching, we are taking exam. I am very much aware of our duty as an examiner. Maybe because that candidate can go and practice, they can ask their teachers also, maybe. So I think I am clear. If anybody, any other examiner has a different viewpoint, please tell us. Because I've been watching and keeping quiet. You know how difficult it is for discussing to keep quiet.
SK, the time is very short. That's why
yes.
we're also.
So that's what I'm telling you, sir. 20 minutes.
We are giving the questions,
yes,
and
see the. So I will not reply to the questions. I will just reveal what are the questions one can again put before the examinees, and the candidate will note it down. If he doesn't reply, we'll go and read, or we'll sort it out later on. Otherwise, we'll extend the session further. So that's I'm afraid. So if the time allotted is only 30 minutes and then 15 minutes each. If there are 5 cases, then I have just calculated the timing. So let us stick to that, and now we should proceed now. Doctor, now ultimately it is the decision of Dr. Arun.
So the task is easier for the examiners to put the questions.
Okay, over to Surya Prakash.
Sir, we are ready with the second case, sir.
Yes, please go ahead quickly.
Yes, sir. So here is a 21-year male patient, Mr. BR. He is presented with history of road traffic accident, head-to-on collision, hit by a water tanker while he was driving a two-wheeler. Patient multiple injuries. He could not pass urine after the accident and was in urinary detention. Police Sir.
Yeah. Go ahead.
The time of arrival to the hospital, he had fractured pelvis with degloving injury to the right hip and thigh. Patient was in hypotension with hemoglobin of 9 gram per dl. Primary dressing was done for the external injuries, and there was penile swelling.
So who is taking Amit?
Yes, sir.
So what do you think is this patient? Suppose this patient, you are in the emergency room and this patient has come to you. How do you manage? What do you think has happened to him?
I would first stabilize the patient. This is a patient of road traffic accident.
Okay.
With multiple injuries. So I would stabilize the patient I do ABC, airway, breathing, and circulation. I will check everything, and after stabilizing, I would order investigations pertaining to the I would also examine the patient.
Yes.
After
What would you look for in the examination?
the examination, sir, I would look for general examination as well as systemic
Apart from
examination.
his apart from his vitals, leave out apart from his vitals. They have told him all those.
Yeah, I would look for in the abdomen. I would look for is there any lump palpable, bladder palpable or not.
Okay.
I would look for pelvic pelvic injuries, and other limb injuries.
Yes.
I would look for blood at the meatus.
Yes.
I would also look for other signs like hematoma or other injuries in the perineum or other swelling of the other genital organs.
Hmm. So this patient had inability. Somebody has tried catheterization and they've done an SPC. So what do you think was the injury to him?
This would be a pelvic fracture injury, which is of course urethral injury. So the catheter could not be
So
passed.
what would you do if a patient comes to you with fracture pelvis like this and blood at the meatus to your ER? What would be your way of managing? Leave alone somebody has tried. And he's stable. He is stable. You have resuscitated him. He is stable now, and you can investigate him. So what would you do if he comes to your emergency room?
If he's stable, then I would proceed with retrograde ureterogram. If catheter is
Or
not
would you do a retrograde ureterogram prior to catheterization? What is your
if there are
protocol
signs
in your institute, or what are you doing?
there are signs of significant injury, blood at the meatus, lot of swelling, then probably I would like to proceed with, if patient is stable, then I would like to proceed with RGU first.
Yes.
And then if the urethra is, there is no injury as such, then I will proceed. Otherwise, I will put a
So why do you want to do this retrograde ureterogram? Why do you want to do this retrograde ureterogram?
Because of the chances of pelvic fracture urethral injury, I would like to rule out urethra.
So you want to rule out urethral injury. How much percentage of pelvic fractures will have urethral injuries?
10% pelvic fractures have urethral injuries.
10%. So how do you classify urethral injuries on retrograde ureterogram?
See, before that, what kind of retrograde ureterogram is this? Emergency?
Sir, I will do dynamic.
What is that?
I will do dynamic retrograde ureterogram.
Okay, dynamic only, but what do you call this? There is a specific name for this. Incremental
dynamic incremental ureterogram.
Yeah, why do you do this? In a small aliquots, 5 ml, you start injecting slowly. And the moment you see there's some extra, you'll stop it. Otherwise, if you do a 20 ml bolus, it will be of the contrast. So you have to give it in increments so that you can stage better.
So how do you classify these urethral injuries on retrograde ureterogram?
The injuries are classified by Colapinto and McCallum. They classified it into 3 types, which were stretch injury. Initially, they classified as 3 types. Then later 2 types were more added to that by Goldman. So it was type 1 was stretch injury. Type 2 was injury in which the membrane, and in type 3 there was the collection was above and below the urogenital diaphragm. Yes.
Yes.
And then later they also classified as bladder neck injury and as type 5 and anterior urethral injury as type. Bladder neck as type 4 and anterior neck as type 5.
That is modified the Goldman, is it not?
Yeah, yeah.
The 4 and 5. Okay.
So when you find a patient has got a pelvic fracture, there are so many classifications, but what is important for you to find out whether you require to do something for the pelvic fracture or you don't require to do anything for the pelvic fracture?
So tile classification is there.
What all these classifications, I know
Yes.
there are so many, but what is important to find out in that pelvic fracture on an X-ray? If you see this X-ray, you will tell what is important for you, whether the patient has got a stable pelvic fracture or an
Yeah.
unstable
So
pelvic fracture.
when do you
So
expect?
how do you
orthopedic
find out?
Yes. So I think Dr. Krismurthy want to know whether when we will like to see that orthopedician will like to intervene or not.
Correct.
So what is your assessment?
So if it is unstable pelvic fracture, both rotationally and vertically unstable fracture, then I would like to involve orthopedician first.
Yes. You should look at the sacroiliac joints. If there is a sacroiliac joint involvement also along with the pubic fractures, then if there is instability, you should ask the orthopedician to fix the fractures.
But how do you assess that? When the X-ray has not been done, before that, how can you express? You can make a guess whether there is a displacement or not.
No, I gave him the
In
suggestions
this
that
case.
not
So
in this
examine
case.
Amit, Ankit, and Ankur. By clinical examination, can you make out that there is some displacement as has happened in this case? By examination,
by
can you
DRE examination.
can
Yes, sir.
examination of the feet level of the feet, level of both the feet can let you know that there may be some instability. The one limb may be shorter or the limb may be longer. Right? Can you make it out by clinical examination? So that's essential. Okay.
So, Ankur.
Yes, sir.
Please.
This patient, they were not able to catheterize. So what is the form of diversion you would do? Suppose the orthopedician wants to intervene. What is the type of diversion you would want to do? If the orthopedician does not want to intervene, he says only bed rest. What is the type of intervention you want?
Yes.
I would like to divert suprapubic cystostomy. Then approximately 5 centimeters above the upper bottom symphysis. Because if you do 5 centimeters above the pubic symphysis, the plants.
No, I'm not able to hear. There's a lot of echoing.
Right.
Hello.
Hello.
Yeah, there is some interruption.
Yeah, tell.
Hello.
Hello, sir.
Yes.
Sir, we will do it. I will do the diversion with the help of suprapubic cystostomy. That would be 5 centimeters above the pubic symphysis.
Suppose the orthopedician wants to put a plate. He does not want you to do suprapubic diversion because the fear of infection of the nailing, which he is going to do.
In that case, we can proceed further with the blood test extended.
No, there is a lot of echoing. I don't know why. You're using both your mobile and laptop.
No, sir, I am only using because so I am using mobile.
Hello.
Sir.
Hello.
Sir.
Go on, go on.
Please carry on, please.
Carry on.
Dr. Keshav, carry on, please.
Give them the retrograde.
CT was done, sir, at the time.
No,
As there was left sacral joint dislocation, the sacral SA joint fixation was done.
Hello.
Yes, go on, go on.
Patient was
Sir,
an orthopedic
sir, just a small request. Any of the participant has logged in at 2 places, sir. It is echoing at every place.
Hello.
Yeah, carry on, sir. Carry on.
No, there's still echo. Navneet, I think somebody has logged in from 2 places.
Navneet, mute. Them and then unmute.
Navneet, mute everybody for a second.
Yes, sir.
Yeah. Is it better now?
There is still echoing.
But everybody's voice is echoing. I think Surya will move forward.
Yeah, yes.
Can you come to the current situation now?
Yeah, Ankur. Dr. Ankur. Hello.
Yes, sir. We'll present the examination findings.
Yeah. No, sorry, we just will go to the investigation.
Yeah. This is a complete unit
Complete
examination.
examination.
There's nothing much in
WBC plenty and hemoglobin is 13, creatinine is 0.7. Ultrasound abdomen, and floating interleucos in the bladder with mucosal irregularity.
Yeah.
Phone hai unmute here.
Yeah. One of you, whoever takes Ankit, Amit, or
Yes, sir.
somebody to read this MCO
Now the voice is better, sir. No echoing.
Go back to the first set of this
Yes.
RGUs. Yeah. Amit, what would you look for in the? This is probably 2-3 months later after that patient has been stabilized. He was on an SPC. They took some time to stabilize because he had orthopedic injuries, and they are doing a delayed investigation. This is, I think, after 3-4 months.
After 4 months, sir.
Yeah, after 4 months, these are the investigation of the same patient. You can comment on this. One of you, Ankit.
Yes, sir.
Please read this.
So this is a first picture is the plain scout film that show there is a fracture of the left side inferior pubic rami, and with no evidence of any calculus in the bladder. And there's and the second film shows the mixture MCU normal surface normal regular surface of the bladder with bladder neck is open and the dye excreting into the posterior urethra with no evidence of any diverticulum in the bladder and no evidence of any vesicouretic reflex on bilateral sides, sir.
The capacity of the bladder is adequate. There are
Yes,
no irregularities. The bladder neck appears to be open. The contrast is coming to the posterior urethra. Okay.
Yes.
Next.
So this is
Yes.
So
You
this is
you keep on talking till we interrupt you.
so this is the maturating film that shows the open bladder neck is opened during the maturation, and there is a dye in the posterior urethra with cutoff at the posterior with dye present in the posterior urethra level. Posterior urethra. With no evidence of bilateral psychoretic reflex.
Next.
So this is a retrograde urethrogram film that shows normal, regular, and the caliber of the penile urethra and the bulbar urethra with the cutoff at the BM junction, the bulbomembranous urethra junction, with no evidence of any extra.
What is the membranous? See, the bulb is distorted. There is no bulb of the bulbar urethra there. Is it
Whole bulb, but there is an impression of
lower level. The injury is at what is the injury at what level? Looking at this MCU and RUG.
So bulbomembranous junction, sir.
Yeah, the bulb, proximal bulb is
proximal bulb.
Yes, along with the membranous, probably the junction. It extended into the proximal bulb.
So, what is this called as now? What are these injuries?
This is a pelvic fracture urethra injury.
Okay.
PFUI, sir.
Okay. So how do you manage this patient? What are all the other things which you want to know from the patient before you want to manage, operate on this patient?
So the patient erection status, whether the patient has a penile erection or not, and other thing, they.
And also, sir, the patient can be, whether the patient can lie in a squatting position.
Correct.
Yes.
So the patient can withstand the exaggerated lithotomy position.
Exaggerated lithotomy position.
Are directions properly? Status would be, what would be status?
Penile stitching can be done in which we
Penile
can
Doppler ultrasonography.
velocity of both nasal arteries as well as cavernosal artery.
Color Doppler.
Yes, sir. Color Doppler of penis to see both the dorsal arteries as well as cavernosal artery. Peak systolic velocity will be seen. If it is more than 25 centimeter per second, then it would be considered as normal.
When do you want to do pudendal arteriographies before you want to operate? Which are these patients whom you want to select to do pudendal arteriographies if you want to select them to do prior to urethroplasty?
Sir, in any patient who is giving history of erectile dysfunction post injury and in which penile Doppler study is suggestive of arterial insufficiency, then we should do arteriogram, and there should be an anastomosis should be made between the inferior epigastric artery and the dorsal artery of penis.
So how do you manage this patient now? Ankur,
According
Dr. Ankur.
to findings, I can see that in the RGU there is normal caliper penile urethra as well as the bulb of the bulbar urethra, and in the MCUG finding the bladder neck is patent, it is opening, and the contrast is seeing to the filling advice about the perineal urethroplasty, and depending on the ease of the surgery, this subsequent steps can be taken while during the surgery. We can complete the surgery either with the end-to-end anastomosis, or the patient may require progressive perineal urethroplasty, but this thing can be assessed at the time of surgery.
So yes, yeah. How
So you would have to plan it as a progressive perineal urethroplasty only, because you would not know unless you go inside. You will not know at what stage you will require to. So you plan as progressive perineal urethroplasty only. What are the components of this?
So progressive perineal urethroplasty, it includes bulbar urethral mobilization, crural separation, inferior pubectomy, and if required, then corporal rerouting. So these are the 4 steps which will add on the bridge defect. After
So
applying
how much
all the
each? What is the maximum amount of
approximately
mobilization defect which you can mobilize?
is the total distance which can be bridged, and 2 centimeters with each step.
Okay. What is the extent of mobilization which is permitted urethral distally?
Bulbar mobilization is done up till the penoscrotal junction.
Okay. So can one of you describe how you do a progressive perineal urethroplasty?
After taking the continent, restricture and infection and prolonged catheterization, we will take the patient for surgery. Patient will be placed in extended lithotomy position with hip lying approximately 1 to 2 inch ahead of the edge of the table. After painting and draping, a midline vertical incision will be kept in the perineum. We will cut the skin, subcutaneous tissue, and fascia.
Okay, so now I would like to interrupt you. Would you like to do endoscopic assessment before making incision or not?
So that endoscopic assessment we can do either on the day of surgery
No,
or
you
1 day.
can do what you will do. That is the question. What will you do?
Yes, sir. I will do endoscopic assessment on the day of surgery before placing the patient in position.
No, what endoscopic assessment? Ureteroscopy or nephroscopy or ureteroscopy, cystoscopy? Please let us know that.
Yes, sir. Through the SPC tract, I will pass a flexible cystoscope if available or a rigid cystoscope, and I will see for the bladder capacity, any diverticulum, any calcification.
So now you tell me whether you do flexible or you do rigid cystoscopy through the SPC tract. Because we are taking your practical examination. I'm sure you may not have used flexible ureteroscope, flexible cystoscope or SPC tract, because most of us we don't do for economical reasons. So how do you do assessment?
Sir,
to start with, do you use flexible cystoscope?
I will start scope.
Right. Okay. And then what you will look for?
I will look for the capacity of the bladder, any calcification or calculi, and I will see for the bladder neck opening. And I will see whether with the help of scope I can see the
proceed. Okay, proceed further. So now you have made the patient lithotomy, exaggerated lithotomy position, table of the edge. You have made a midline incision. Then what?
After that, I will mobilize the bulbar urethra till the.
So suddenly the bulbar. See, now you have made incision in the skin. What comes next? And then how do you do that? We want to see whether you have approach to the bulb. How do you approach to the bulb? So that will tell us the practical knowledge of the candidate. You have made incision in the skin, then midline incision in the perineum. Yes. Next, what? What do you see?
Yes, sir. I will cut the Colles fascia. Then bulbospongious muscle will be visible, which will be dissected in the midline, and that will reveal the bulbar urethra. That bulbar urethra will be mobilized circumferentially till the penoscrotal junction, and then we will pass a catheter per urethral to see the distal extent of the stricture. At that particular position, we will cut the urethra. We will transect the urethra.
Right. Okay. So what do you see there? The tip of the catheter, and then you dissect the urethra. What is there? What happens?
So
at that time?
There will be
is likely to happen.
They will be bleeding from the cut margins, which will tell me the integrity of the retrograde blood flow.
Yes. So again, suddenly you saw something has been there. There was spill on your. Then, if you are having glass, then on the face or maybe on your glass. So some blood has come on your face, and there was a spot from somewhere. What from where? What it?
Sir, this blood flow will be basically from the retrograde blood flow, which is coming from the.
No, you didn't
Not
follow me.
retrograde.
I just wanted to know your practical knowledge. That's why I'm emphasizing. We want to know the practical knowledge of the candidate. He has assisted. If he has watched, then he will certainly tell what is there. It usually happens when you transect the bulb from the perineal membrane. There may be some sputter. From where does it come from?
So that is bulbar artery, which.
Okay, right.
So how do you control that? So the practical tip is that you should avoid taking ligatures there. You should take a fine tip hemostat and then secure those bleeding, rather than taking a bite there, is because you could take the nose along with that bite. You should take a fine tip of those bulbar arteries.
Yes, what
Then,
next?
to know the proximal extent, I will pass a groove dilator from the SPC tract, and I will ensure that the hay groove dilator is passing in the midline and keeping my finger in the rectum. I will this hay groove dilator will be passed.
Why will you keep your finger in the rectum?
So that will help in guiding me the correct passage. Otherwise, sometimes with little bit of force, we can produce a false passage.
No, you should not be doing that.
You ask you will put your finger, or you ask your assistant to put the finger in the rectum. Why do you want to contaminate the field, man?
So you should put a hay groove staff only if you are regularly doing it, or you can use the rigid cystoscope itself.
Yeah, if you guide the tip anteriorly towards the symphysis pubis, you are unlikely to go into the rectum.
Some people use even the rigid cystoscope itself, so that under vision they could come through the prostatic urethra. So you can do either of these. Go ahead.
So then, once the tip of the hay groove dilator is palpated from the proximal extent, or the light is visible of the light, the cystoscope is visible, then I will make a cut over that proximal tract. Once the proximal tract is delineated, then I will do cystoscopy from the proximal tract to see whether I am in the correct tract. I will see the landmarks like verumontanum and the bladder neck.
Okay.
And I will also pass a dilator of 28 French or 30 French. It should be easily passed.
What
is important? What is important after you cut and you get the scope or the hay groove staff out? What are you going to do after that? Because that decides your surgery, the success of the surgery.
It is not just enough you cut over the hay groove tip and open the urethra. What else you do?
There'll be a lot of fibrosis. You have to excise all those fibrotic tissue till you reach the tissue where it is supple and you find the normal epithelium there. Till that time, you should be doing the excision of the fibrotic tissue. You will find callus. All these things should be excised, and the proximal tissue should be supple. You should dissect till that. So sometimes you may not be able to achieve this through the perineum route itself, and you might require to do corporal pleural separation. You may have required to do inferior pubectomy. You have to do all this in order to achieve this. You have to achieve the proximal extent, which should be supple, and you should be able to anastomose that tension. So to achieve that, you will have to do some maneuvers which you told in the start.
Examiners, please note, we have 4 minutes left. Please.
Yes.
Yeah.
Time one has to take care. Yes. Right.
Okay. Yeah. Carry on, Ankur.
Then after making a widely patent mucosa to mucosa anastomosis after spatulating the ends, I will keep a silicone catheter to per urethral and which will be blocked, and the other catheter which is lying in the SPC, that will be opened, and a drain will be kept. Now post-operatively, patient on the 4th post-operative day, patient on the third or fourth post-operative day, depending upon the drain output, his drain will be removed, and then the patient will be discharged for home. I will call the patient after 2 weeks for assessing the wound, and I will remove the sutures. And after 6 weeks of surgery, then I will remove the perurethral catheter and block the SPC. I will ask the patient to pass urine. If he is passing urine normally, then I will once again ascertain the integrity of the anastomosis with the help of MCUG. I will put dye in the bladder through the SPC tract and will do MCUG. If it is normal, then SPC will be blocked and patient will be sent home again. Next, after 1 week, patient will be called if he is passing urine normally, and after checking the urine flow on the uroflowmetry.
Ankur, right. See, you have removed the catheter. Patient has not voided. What are the causes?
We have done a anastomosis with the false passage, or there may be some underlying abnormality of the bladder. The bladder may be underactive.
And you are not adequately removed the callus. That is most important.
Yes, sir, yes.
Don't remove the fibrosis there. The erythral compression continue to be there.
Yes.
Right. After erythroplasty, you have not been able to pass the catheter perurethral intraoperative. Now you have done an anastomosis of the urethra, and then you are trying to pass the silicone catheter perurethral, but you have not been able to pass it. What you will do?
Sir, ideally the catheter should be passed once we have done the anastomosis at 6 places. So once we take steps at 3 places, then the catheter should be placed, and then rest of the 3 around we trying to pass the catheter, then there is possibility that some of the material has obstructed the lumen of the
No, what
urethra.
we will do? Actually, we don't want any explanation because time is short.
Sir, I will do cystoscopy perurethral, and I can directly assess what is the problem in the continuity of the passage.
Okay, right. So somebody
So
can
how do you
summarize.
follow up these patients?
Sir, in follow-up, my main concern is about I will ask the patient about whether he is having erections properly. Second thing, what is this urine flow? Because there are chances that this patient might develop re-stricture. So at the baseline, at the 6 weeks, when the patient will come for the follow-up, I will get a uroflowmetry done and will document the baseline peak flow rate. In subsequent follow-ups, every 3rd month, I will call the patient. I will just asking whether his urine flow is same or not. If he is having doubt about the reduced flow rate, then I will get uroflowmetry done.
Okay, now when you left the patient on SPC, after removing perurethral catheter, you kept the SPC clamp. Patient came to you with increased frequency and urgency. He says, sir, overnight he has to get up 5 or 6 times in a day. And you called him after 1 week for removal catheter. He came because he was in a very miserable situation, and he came to you after 2 days following discharge, following MCUG. He is having increased frequency, very severe, and then severe urgency, and again urge incontinence. What it could be due to?
I will first, I will decrease the volume of the bladder bulb. Probably that bulb of the catheter might be calling some mechanical.
Can it be due to UTI?
Yes. Yes, sir.
Okay. So I think we can summarize now.
Hello.
Which patient is at risk of incontinence?
Any patient who is having associated bladder neck injury with the posterior urethral distraction defect.
How will you predict that and counsel the patient preoperatively?
So preoperatively, this patient, when we do RGU and MCUG, we will see whether on the static film whether the bladder neck is competent. Second, when on table we are doing, then also we can see whether the bladder neck is opening normally or not. And generally, after the surgery, most of these patients are continent.
Okay. To summarize, these are patients whom you see in the emergency room who come with road traffic accidents And when you're suspecting the pelvic fracture urethral injuries, as told earlier, there are people who try to catheterize and one attempt general catheterization, but there are institutions which do regular retrograde ureterogram before doing a catheterization. So you classify the urethral injuries, and we didn't discuss, there are thoughts of primary delayed realignment, endoscopic realignments which can be done, and what is delayed management. We discussed only the delayed management in this. So the questions would be asked regarding primary delayed management or the endoscopic realignments which can be done. So there will be questions pertaining to that. There will be questions of classification of pelvic fractures. How do you manage them? All regarding those things. And how do you do the retrograde ureterogram, and how do you interpret all these retrograde ureterogram and MCUs? And the rest of the things which we asked is the procedure itself, to know about the practical aspects of the urethroplasty.
That's right. That's right.
Shall we move to the next case, sir?
Yeah. Suri, you can move to the next case.
Yeah, thank you, sir.
And Dr. Chawla, I think every case is of 15 minutes duration, or maybe around 20 minutes.
20 minutes. It's 20 minutes, sir.
Right. So all of us
I'm
will
sharing.
keep,
I'm sharing the screen now.
The next 3 are short cases. Each case is for only 20 minutes duration.
Okay, Sir Prakash.
Okay.
Oh, where is our?
This is a 1 month old male child came with.
We are not seeing. We're not seeing.
Yeah,
the
who
slides.
are the candidates? Who are the candidates?
Yes, sir.
Name. Who are the 3 candidates?
So the candidates are Dr. Parthraj Jadeja, Dr. Renish Patel, and Dr. Anu Ramesh.
Jadeja.
2 are reserved and 1 is the regular.
Now, what is Jadeja? Then what else, Navneet?
Sir, Dr. Renish Patel, Dr. Parthraj Jadeja, and Dr. Anu Ramesh.
Yes, sir.
Anu Ramesh. Okay.
Are they unmuted?
Are you able to see the screen, sir?
No,
Examiner, please.
No, not that yet.
We are not seeing the slides. We are only seeing the 3. This thing.
Navneet, are the candidates unmuted?
Parthraj, yes, sir.
Yeah, hello.
Yes, sir.
Actually, इसको छिपा के रखना चाहिए था डॉक्टर अरुण from exam.
Hello?
Because, yes.
Can you see the screen?
No,
नहीं
no,
अभी
no.
तक नहीं आया है शेयर
But we are not able to see the slide.
No.
We have already stopped. We have stopped.
Sure.
We are not able to see.
1 minute, sir. 1 minute. I'm sharing now. Is it is it okay now?
No.
No, sir, you are showing the diagnosis.
I think this should not have been shown.
Can you see now?
No, no.
Yes, slides are not appearing around.
Yeah, there is some problem with the screen sharing. I'm trying to figure it out.
Mr. Navneet can help you in doing that.
Sir, perhaps we are sharing the screen, we have to share the PowerPoint.
Yeah. I am sharing the PowerPoint. I am on. Is it okay? No?
Second. So you open the PowerPoint, keep it on the desk.
No, PowerPoint is already open. Yeah, I'm doing that.
Just came and went off.
Okay, 1 minute.
Sir, please stop sharing first, and then you can reshare the PowerPoint slides.
Okay. Okay, fine.
Yeah.
Is it coming?
Perfect. Make it full screen.
Coming?
Yes.
Okay, fine.
Full screen.
Yeah. Come.
Yeah, go ahead. Who is presenting?
So good morning. I am Dr. Sitaram from KMC, sir.
Yes, start.
This is 1 month-old male child came with chief complaint of poor urinary stream and crying while passing urine since birth, with decreased urine output since 1 day, fever which is low grade intermittent since 2 days, and tail is also having vomiting after meal since.
Okay, with this history, what is your
Any one of you can take.
Hello. 1 month-old baby with this presentation? What is your working diagnosis?
Hello.
Hello.
Yes.
Hello.
Yeah.
So possibility of a posterior urethral valve, sir.
Okay.
Directly.
And any other
Why do you
unit?
say that it is post-urethral valves?
Sir, I'd like to know a little more about the antenatal history, sir, of this patient.
What do you want on antenatal history? What are you interested in?
So presence of any oligohydramnios which might have been there, sir, and any scans which were taken which showed any other significant findings, sir.
What findings are you interested in?
Sir,
If your differential is posturethral valves,
yes, sir.
Then what are the findings which would be the pinpointers for you to towards posturethral valves?
So one is
I don't have this ultrasound.
oligohydramnios may be present, sir.
That will be severe cases.
Yes, sir.
Is it always? It always
in all cases, sir.
there?
No, it is
it's seen in all oligohydramnios, yes, sir.
It is not necessary in all cases.
Okay.
What are the other findings?
Thickened bladder wall and dilated posterior urethra.
What about the kidneys?
Kidneys, due to back pressure changes, there will be antenatal hydronephrosis also.
How do you diagnose? There's suspicion of posturethral valves on an antenatal ultrasound.
So usually there'll be the keyhole sign may be present, sir. That is where you're seeing with the dilated and dilated posterior urethra, thickened bladder wall, sir.
Keyhole sign is postulated.
What is the liquor formed from?
So the liquor initially is the before first 16 weeks it's due to the placenta. After 16 weeks it's the fetal urine, sir.
So what happens when you keep scanning the bladder? What is the finding you are interested in? Okay, I don't know.
Yes,
You
sir.
can do the antenatal ultrasound finding.
So I would like to inability to see dilated upper tract. There can be echogenic kidneys. There can be urinoma or urinary ascites. We may sometimes find on antenatal scans.
We have findings on antenatal ultrasound. I think it was probably normal. We don't know.
Okay, sir.
Okay, so now with this, how will you proceed now?
Yes.
So this was the presentation. How will you proceed?
Yes, sir. There is no history.
Yeah, Dr. Sitaram, your slide is not seen.
No, we can see it.
1 second.
Yeah.
Yes, sir. We are seeing it, sir. Yes, sir. Next.
3.4 kg cried at birth. Antenatal ultrasound report not available. So
Examination
findings, sir.
Yeah. Overall normal.
Normal.
Okay, sir.
Overall normal. So we'd like to progress to the systemic examination in the form of peripheral examination, specifically the palpable bladder or flank masses, and the genitalia, so physiological phimosis, meatus if it is seen, and condition of testis. Yes, sir, it is already there. Yes, sir, it is seen.
Yeah.
It seems to be normal. Yes, sir.
What investigations you want?
Why child is having
Urine.
nausea and vomiting?
Okay. Fine.
Recurrent fever.
What investigations? What investigations will you order?
Yes.
Ultrasound. So urine sorry, sir. Renal function test we can order, sir, for the patient.
Yeah. So complete blood count, urine routine.
Yes, sir. Urine routine, complete blood count, and urine cultures.
Yeah, serum creatinine.
What do you have to be corrected?
ABG.
So we have the renal function test, sir.
Yeah. Go through it.
Sir, urea was 98 milligram per deciliter. Serum creat was high, sir, 6.37.
6.37. See the creatinine value.
Yes, sir.
Yes, sir.
1 month old child, creatinine 6.37.
Okay.
Very elevated.
Okay.
Yeah.
Fine.
Yes.
Could you go back?
We are getting confused. So we will be sending the urine culture at the time
Cultures?
while we are taking this urine microscopic examination sample. And I will add to this ultrasound of the KUB region.
Sir, culture reports, sir.
Culture is shown, sir. Sir, urine culture is showing gram negative bacillus aeruginosa. Colony count was 75,000.
Next
Ultrasound?
Yes.
But the question is, how to explain pseudomonas aeruginosa in this child? Can you explain something might have happened? That's why there is Pseudomonas. Is it a primary bacteria for UTI? Or there has been something might have been done which led. Proceed further. Now, question is out. Yeah. Now keep in mind to explain further later on. Now, this moment, the question is that what do you see here in ultrasound? You have asked for.
The upper films are the kidney.
So there is a dilated bladder on both the sides.
Read the ultrasound.
Yes.
Coordinate among yourself. Who is going to speak and who will keep mum?
Jadeja can do this.
Yes.
Dr. Jadeja interpret this ultrasound.
Very nice.
Come on, don't waste your time.
Sir,
I got unmuted. I got muted,
You
sir.
need to be unmuted.
Yes, sir. Sir, Parthraj Jadeja here, sir.
Yes.
This is the ultrasound picture of the KUB region, which is showing the both kidneys showing a moderate hydronephrosis with echogenic parenchyma in both the sides. The bladder is showing a big outline.
Posterior
bladder and posterior urethral
dilated.
So what will be your plan of treatment now? Keep talking.
Yes, sir. This patient will require the plan will to put a perurethral catheter to drain the bladder and the upper tract while maintaining the hemodynamic stability to prevent the dehydration, to correct the electrolyte abnormality, and see the urine of
culture
the creatinine.
sensitivity also needs to be corrected.
Along with that, I will be starting antibiotics. Yes, I will be starting the empirical antibiotic at the time of admission, which may need change after the report of the culture, sir.
So what you have used the term empirical antibiotic, which I couldn't understand. What do you mean by that? The patient has got Pseudomonas.
At the time of
sensitivity
admission,
report is
sir,
available.
Okay, sir. No, sir, I was talking about at the time of admission, sir. It will not be there. If it is there, then I will be starting with the antibiotic which is sensitive for this organism is sensitive for. Yes.
What form of catheter will you use for this child?
Yeah.
Infant feeding tube.
It will be yes. I'll be catheterize this patient with an 8 French feeding tube, sir.
Why don't you use Foley's catheter?
So catheter will be there will be a bulb inflected that will lead to further spasm, and which may hamper our subsequent correction of the upper. The purpose here is to reduce the intravesical pressure, sir.
What are the problems you anticipate when you catheterize this child with feeding tube?
Sir, at the membranous urethra, we may try gently at that particular
No,
point.
he's asking very pertinent. See, read the mind of the examiner.
So he's got a
asking
dilated
when
posterior urethra. So because of that, it may coil within that instead of going completely into the bladder. So.
Okay, very good.
Okay.
So now just listen to my question. You have stabilized the child, given antibiotic, you have collected the acid base. Now what will you do?
We will see the trend of the fall, the correction of the serum creatinine, the correction of the electrolytes. We will see the daily outputs, clinical improvement of the child, and we'll repeat the ultrasound of the KUB to see the resolution of the upper tract changes.
How many days?
Sir, it will be for the initial. It will be say, 6 to 12 hourly repeated evaluation in the form of clinical examination.
Okay, now,
Yes,
Sir, after correct.
wait. Wait up with ultrasound. Child is stable now. Okay, child is febrile. Okay, 2 days have passed since you have catheterized. Now, what will you do?
Yes, sir. I would like to see the evaluations, sir. Repeated parameters, serum creatinine, the electrolyte, and
Creatinine is 3 now, 3.
3. Okay. And sir, electrolyte were altered, sir.
They were all normal now.
They are all normal. Creatinine is 3. And yes, sir.
What do you want to plan next now?
So my next plan is to get a micturating system to urethrogram, sir.
Okay. Answers are coming on the screen.
These are some teething problem, no problem.
This is the micturating cysto urethrogram film, which is showing the both films are probably voiding films, sir. And one is the anteroposterior and the other is a lateral film, which is showing trabeculated bladder outline with diverticular formation with bladder neck hypertrophy, dilated posterior urethra, and probably normal anterior urethra, sir.
Will be normal in a patient with child with PU valves. How many children have? How many? What is the percentage of children with reflux in PU valves?
Yes, sir. It should be around 40 to 50% of the children will be having some form of reflux, sir. Almost
So
50%.
here the child probably
Not
has
seeing any reflux.
We don't know on the one side. Streak of contrast probably is going up. That's okay. Yeah. So now what do you want to do now? You have confirmed your diagnosis. Urethra is dilated. 1 month old child. Child is stable now. 3 days are over of catheterization.
To go, yes, sir. So next step for posterior urethral valve fulguration. Along with it, the patient may require alpha blocker in the postoperative periods.
So which 1 month old child, which scope would you prefer?
So it will be a pediatric resectoscope, 9 French, pediatric resectoscope is available, sir.
Okay. 9 French is a very big scope.
See, 1 month child, 1 month child.
6 French, 6.5, 7 are all available. That would be your preference. Secondly, resectoscopes are nowadays not preferred. Okay. We will show you the pictures. I think we can show them the screen, what it looks like. Next slide. So, how do the valves look like on endoscopy? Any idea?
We have displayed the image, sir, in intraoperative image.
So this is the type 1 posterior urethral valve, sir. Here there are thick leaflets which are originating from the posterior urethra and moving downwards towards the membranous urethra, sir. There are 2 leaflets, sir, which is merging in the midline at 6 o'clock.
So where do you fulgurate the valve?
Sir, so fulguration will be done at the...
Tanvi was talking something.
Yes, sir.
Sir, it's done in 4, 8, and 12 positions, sir.
Okay. What are the different ways of doing it?
So, using cold knife, sir.
That is one.
Then laser, sir. Bougie can be done. Sorry, it's a ball electrode can be done.
Okay. Bugby electrode.
Buggy electrode can be done, sir.
Big electrodes. Buggy.
You have fulgurated. What will you do?
So
on table, on the during surgery, after the endoscopy is over.
Yes, sir. After yes, sir. Yes, sir. So after fulguration, sir, obviously we will be seeing the complete bladder picture, and at the end of fulguration, sir, we will give a suprapubic pressure, and we will see if the residual valve is fanning down, and I will confirm there is no residual valve. Same thing. And one is
during endoscopy,
yes,
you keep your endoscope to diagnose the valves.
Sorry, sir.
So could you repeat the question, sir?
Yeah, during endoscopy, how do you diagnose valves? Where do you keep your endoscope? At what level will you see the valve?
So, in the endoscopy, sir, first
it's seen during withdrawal of the endoscope, sir.
Yes.
It's not during the insertion. So as we're withdrawing the endoscope, we'll be seeing it, and if we're not able to see it, we'll give slight suprapubic pressure, sir. It's usually present either distal or slightly proximal to the verumontanus.
Now you have fulgurated the valves, kept a feeding tube. When will you remove the feeding tube?
So we'll remove the feeding tube after 48 hours of fulguration, sir.
How will you follow up the child?
If the patient is asymptomatic, so my follow-up will be one will be the immediate follow-up after removal of the feeding tube, how the child is voiding and whether he's keeping any residual urine or not. I will be getting repeat serum creatinine after 24 hours of removing the feeding tube to see it is not rising. And this patient will require alpha blockers in the post-operative post-fulguration periods, and follow-up will be in the form of weekly, 2 weekly and 1 month follow-up. That will be again a clinical examination, visible stream examination, and serum creatinine to see the trend whether it is falling or not, and checking post-void residual urine, sir.
Very good. We will show you the reports, I think, of the post-op. Next slide.
Yes, sir.
So these were the reports on follow-up. Can you read them?
Yes, sir. Serum creatinine is serum sodium is 131, potassium is 5.4, sir.
Okay. Now, what are the prognostic factors in children with post-urethral valves?
So the prognostic factors, we can divide them into clinical, biochemical, and the imaging factors. The clinical will be the lack of growth, that is this stunted growth.
And foremost, wait. What is Nadir serum creatinine?
So
the lowest
we cannot
value
comment
which
upon
we
the Nadir
get, sir.
creatinine at this moment, sir.
So no.
No, not that. He's asking for the prognostic factors in a PUV.
Sir,
Nadir creatinine at age 1.
Sir, at the age of 1 year, creatinine of more than 1 is suggestive of very high chances of future end-stage renal disease. 0.8, sorry, sir. Yes.
0.8, sir.
At the age
Washer
of 1 year.
criteria.
If the VCUG had shown reflux, grade 4, grade 5 reflux, how will you manage that reflux?
Yes, sir. So it will be posterior urethral fulguration with postoperative alpha blocker and antibiotic prophylaxis for at least next 3 months. We'll follow the patient as same. If the child stays asymptomatic, repeat VCUG at the after 3 months of the fulguration, sir, to see the correction of the reflux, the downgrading of the reflux.
When do you contemplate doing supravesical diversions in cases of PU?
Yes, sir. For patients like this, after placing the feeding tube, the patient is not getting improved clinically. Creatinine is not coming down. or patient is still having repeated fever episodes after placing the feeding tube. So in those patients, we may need to consider vesical or supravesical diversions.
Examiners, please note 3 minutes left.
Yeah, so I think we will summarize this now.
Yes,
Yes, sir.
I think the candidates have answered most of the questions very well. So this child, if you see, had bilateral gross hydronephrosis and creatinine was 6, but the cortical tissue was very good on ultrasound, the renal cortical tissue. And that is why after fulguration and after treatment of urinary infection, the creatinine settled very well. Follow-up is what the way you have mentioned, with urine routine microscopic, serum creatinine every 3 monthly, and then follow up with the uroflowmetry. Some centers do a follow-up VCUG or a follow-up cystoscopy. Every unit has a different protocol. The most important part is the uroflowmetry and assessment of post-void residue. If these two things are okay, most of them follow up with renal parameters and urine routine microscopy. But all children with PU valves need lifelong follow-up. As they grow, the nadir creatinine is going to decide the outcome of this child. Okay, I think we'll go to the next case.
Thank you, sir.
Thank you, sir.
Okay. Can you see the second case slide?
No. No. Same
Okay.
problem again.
1 minute. 1 minute. Can you see that?
Yes.
Can you see,
Yes,
sir?
Yes,
sir.
Now
Yes,
it is there. Yes.
Okay.
Yeah. So who are the candidates?
Sir, I'm Dr. Arvind, sir.
I'm
Doctor
Dr. Anurag.
Arvind.
Dr.
And I am
What
Dr.
other?
Arshad, sir.
Dr.
Dr.
Arshad,
Arshad.
And Anurag Garg.
Dr. Anurag. There are 3 people here. Right. Okay.
Yes, sir. I'll be presenting the case. This is Dr. Ravi from KMC Manipal. This is a 53-year-old female presented with left flank pain since 2 years. It was intermittent, dull aching, and type of pain. No other positive history in the sense, no history of fever, vomiting, no history of hematuria, LUTs, lethuria, no past history of diabetes, hypertension, no prior urological interventions.
Yeah. So this is the point. Yeah. So now the patient, you have got the history, patient is with you. So now how will proceed for this case? Anything else you would like to know? Or yeah. What next? Because all these cases for the exam going is by choices, and the examiner's duty remains, yes, the knowledge, basic knowledge of the candidate related to those cases, practical exam. Practical knowledge of the candidate, whether he or she can be able to manage these cases safely or not. So now, yes, this is the history. You must have something in your mind, maybe 1, 2, or 3 things, and then you will proceed further. So tell me how we'll proceed further.
Sir, any past history
Sir, for the
this
at this
patient is
point,
symptomatic for last 2 years.
Yes, sir. So at this point, we'll consider the differential diagnosis of renal stone disease. It can be PUG obstruction also.
No, actually, that's not the question. Is the examiner is not asking you what you think of. The examiner question is, he will make up his mind whether you are having those things in your mind or not. So now, until the examiner, because I know the time is limited, 15 to 20 minutes. So they will like to assess the candidate as per their wishes. and every aspect of the case, given case, the examiner will like to assess. So just I thought, okay, this is the symptom. You know, a lady is 53 years old, and you know the symptoms. Now you tell what next. We'll assess whether you know anything about the things or not. That I will derive the interpretation. You tell how to proceed for this case now. This case has come to you in North Clinic.
From this, my possibilities are.
I'm not asking that. See, this patient I'm watching. This patient is in front of you in your clinic.
Yes, sir.
I just want to see what you are going to do. Go on uttering. How will proceed to manage this case, and I will make assessment of yours.
Okay, sir.
I'm not asking. Tell me the diagnosis. Have I ever asked you? No. That's I'm seeing the pattern, but my pattern is different. I just want to tell you, please manage this case.
Okay, sir. I would like to evaluate the patient. First of all, I would like to do a routine examination. I would like to do a urine routine examination.
So now you would not like to ask anything from this patient?
Yes, sir. Sir, any past history of any stone disease?
Yeah.
No past history of stone disease or prior urological interventions.
Any history of any any history of any recurrent UTI?
No.
So any past history of tuberculosis?
There is no past history of tuberculosis.
You can assume that what is
Yes,
not
so now,
is normal.
See now, if she says tuberculosis or what? Ovarian, uterine tuberculosis or something? Or pulmonary tuberculosis or tuberculosis as a whole? So no history of tuberculosis. Okay.
So
I would like to know the history of any weight loss or loss of appetite.
There is no history of loss of appetite or weight.
Anurag, you can.
So ask the leading question which you want to see, you were thinking of, but that's not there. So to negate the things and ask something which will substantiate your diagnosis, whatever you are thinking in your mind. So the questions should be relevant, either to negate possibility or to confirm, or I will say to proceed further to explore something, to know something suggestive of diagnosis. So, okay, anything else? What next?
So would like to examine the patient examination finding.
So now I will ask you, she's 53-year-old female. You presume that she is in menopause, probably, but I don't know. Is she in menopause or she is pregnant or she is having again menstruation on? She might have married just 2 years ago. How do you know that? So this is called clinician, not big thing, right? So it's better to know about the menstrual history. You agree?
Yes, sir. Yes, sir.
Yes. Okay. Right. So just in nutshell, just I wanted to tell you, when the female is of 53 years, we don't know whether she is in menopause or not. She has undergone hysterectomy. She said no, no surgery. Okay. Now what next? ये पहले मत दिखाइए ना, उनको बोलने दीजिए. Simple question. Because my duty as examiner is, are you able to manage a given case successfully with good safety, without again any damage to the patient? So just one given case has been given. This case has been given to you. I'm assessing you. So this is in your clinic. Now you have taken the history. What next?
Sir, I'd like to examine the patient.
Okay. So what you would like to know in the examination? General physical ones. Okay. Anything else?
Physical examination is normal. The per abdomen is soft, non-tender, no flank tenderness.
Okay. Anything else you would like to examine?
Local examination, sir.
What local means? Which local? Abdomen? Abdomen pain, she is complaining of abdominal pain.
Yes, sir.
Okay. So you want to know genital, private parts, examination of genitalia. For what
Yes,
purpose?
Sir, to see if there is an abnormality in the form of any cystocele or or an obstructive, or an obstruction, sir.
Okay. Obstruction. Okay. What anything else?
Any prolapse?
You told prolapse one.
Yes, sir.
Anything
Yes,
else?
sir.
So simple question, simple case, right?
Sorry, sir.
Would you like to see for cards? No, cervix means you will like to see cervix.
Yes, sir.
Maybe causing obstruction to the ureter, causing pain.
For vaginal examination.
Okay, so I am assessing
Yes,
now your knowledge. So did you thought that were differential diagnosis or not? So that I'm making out. Okay, when you are examining the patient. Okay. What next? You have done PV examination, you saw vagina, you saw the cervix for any malignancy. What next?
Sir, I would like to investigate the patient, sir.
Yeah, so what you will do?
Urine routine examination, renal function tests, electrolytes.
Electrolytes. Anything else?
Then I would like to go for imaging, sir. I like to do a basic ultrasound KUB, sir.
Ultrasound. Okay, so in examination you didn't find any lump. So now we would like to do screening with ultrasound. What is it there inside the abdomen? Okay, ultrasound. Yeah.
Sir, there is hydronephrosis, sir, and the pelvis is hugely dilated, and also the calces are also dilated. The parenchyma appears to be preserved.
Okay, so grossly dilated pelvic system.
Yes, sir.
Anything else you would like to know? If the film is not showing, you can ask. We
Yes,
can
sir,
provide you the data.
Sir, I would like to see. Sir, I would like to and also contralateral kidney, and yes, sir, and about the PVR, the bladder wall thickness.
And
status of
ureter is not
kidney
visible,
is
so I would also like to know the status of the ureter.
Right. Yeah. What next? So ureter is not dilated, parenchymal thickness is 5 mm, and bladder is normal. Contralateral kidney is normal. Is it correct?
Yes, sir.
Listen. Okay. Okay. Right. What next?
Sir, I would like to go with CT urography next, sir.
CT urography. Okay, CT urography. So what you would like to know in CT urography?
The level of obstruction and about the
But
status
to
of the
know
ureter.
the level of obstruction. Okay.
The status of the ureter.
What do you think the level of obstruction to be in this case?
So this is probably because of a huge obstruction. The bladder is normal, but the ureter has not been visualized in the ultrasound. So we'd like to see the status of the ureter also in the CT image.
Okay. So we like to see.
Yes, sir.
And in CT, what do we like to see?
So we would like to see the parenchyma more.
Okay. Okay.
CC or any ureteric lesion that is present, any calculus, ureter can be better visualized.
Okay.
And
so
I would
where do you
like to know
think in this
mass
case?
that is,
Yeah.
that is compressing the
Extrinsic
ureter,
compression.
compression.
Any extrinsic compression. Any crossing vessels.
So what film you will ask the radiologist to do? Are you going to see the crossing vessel as such, or you will ask specifically for that in this case? Because you are going to look for the site of obstruction. You are going to look for stone anywhere in the urinary tract, because I could hear you. And then you want to know the parenchymal thickness objectively assessed by CT scan better. Yes.
Yes, sir. Yes,
and you told that you would like to see crossing vessel also.
Yes, sir.
Right. Vein or artery?
Yeah, we have
crossing arteries. Both, sir. Both.
We have done a IVU series.
Yes. So you asked for IVU CT urography. So how can you see crossing vessel in this? If the CT scan, you have asked for IVU cystography then. IVU, CT urography. This is the IVU. They have got IVU done. How much is the cost of CT urography? How much is the cost of IVU in your clinic, in your hospital?
CT urography will cost 7,000 rupees, sir, and IV will cost 1,000 rupees, sir.
Okay. 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 The IVU, and what is the finding? Can you tell us? What do you observe?
Sir, I'd like to see the static film first, sir. Sir, in the sir, sir, this is an IVU series, and in this the right kidney appears to be normal, and there is no radiopaque shadow or any stones, and the soft tissue appears to be normal, and there is and on the left side there is gross hydronephrosis. Other image, please. There is gross hydronephrosis and the ureter.
This is the 6-hour delay film. This is the 1-hour delay film in this.
The drainage of the left side ureter is not seen, sir.
Okay.
Post-word film.
These are the series that we have got. 5 minute, 10 minute, 1 hour delay, and 6
and
hours.
then 6 hours.
Okay,
6 hours दिखा दीजिए इनको. So what is your an impression about this radiological investigation?
Sir, this is a PUG obstruction, sir, and also the left side it is not draining, sir.
So not draining. How kidney is surviving?
Sir,
how do you interpret that
image.
it's not draining? You are not seeing the ureter, right?
Yes, sir. Yes, sir. Yes,
but
sir.
you can't say whether it's draining or not. But it's draining, maybe with obstruction. Otherwise, how the kidney will survive with this complete obstruction?
Okay, sir.
Would expect how long does the kidney take to get non-functional if there's a complete obstruction? Do you know? Okay. Now, so this is the case of PUJ on left side. What next?
Sir, I would like to sir, I would like to know the functional status. I would like to do a DTP renogram, sir.
Pardon?
I would like to have a DTP renogram, sir.
DTPA?
Diuretic renogram.
Diuretic renogram. See, now I'm not uttering anything. You are telling
Diuretic
diuretic.
renogram, sir.
Is there a term
Diuretic, sir. Diuretic, sir.
Diuretic. Okay, sorry. So my mistake. Yes, diuretic renogram. So why diuretic renogram?
Sir, because there is gross hydronephrosis.
Yes, that's so the obstruction is there then.
Yes, sir.
Yes.
Know the functional status, the exact function of the kidney, so that we can prognosticate the patient further, tell him better about what is the functioning of his kidney, and it will also help us in the follow-up, sir.
Okay. Okay.
And sir, and this is an EC scan. In this, the curve it is an obstructed type 2 curve, sir, and also the split function is this 30% function. And
32 and 67.
Yes, sir.
Yes, I think some of the
67.
examiner can take it.
Left side
And
function is 32%. Right side is 67%.
Type 2 obstructed curve.
So yes. So what is your inference from this diuretic renogram?
Sir, it is a case of PUG obstruction, sir, and there is decrease in function on the left side, sir.
Yes. Right.
Yes, sir.
Obstructed, not obstructed.
Sir, it's an obstructed type, sir. It is type 2 curve, sir. It is an obstructed kidney, sir.
Okay. If it is not obstructed, or they
Yes, sir.
say this is not obstructed,
Yes, sir.
what it could be due to? You feel this is obstructed or not? In this case, diuretic renogram is equivocal. How much is the percentage of function?
32% left side, 68% right side.
Okay.
I didn't get the question, sir.
Yes. So function you have told.
Yes,
yeah.
sir. Yes,
Yes.
sir.
And then you told that there is obstruction, equivocal obstruction.
No, sir. There is obstruction, sir. It is a type 2 curve,
Right.
sir.
Yes. If it is equivocal.
Yes, sir.
Yeah. Obstruction is not clear. It's,
yes, sir.
Yeah. Equivocal. Fine.
Yes, sir. Yes, sir. Yes. It may be intermittent obstruction, sir.
So how the diuretic renogram, whether you have got this or not, will be helpful to you in this case. Okay, scan, you want to know the kidney function, fine.
Yes,
so
sir.
what is your comment? If I say diuretic renogram may not be much helpful in this case. What is your comment?
It's
The
a grossly
scan will be
dilated.
helpful for function assessment. A split and function we can have assessment. But whether obstructed, not obstructed, would you like to know in this or no?
Yes, sir.
Your decision depend on that. If you are telling yes, you will like to get it done. Why? I will say if you don't get it done, then why?
Sir,
Suppose
I
if
will,
it yes,
I will
then
get
why?
it done for
Then why? How can
follow
you-
up, sir.
Okay.
Follow up, I need to know the value, sir.
Okay. Okay. You want to have baseline, and subsidiaries may substantiate your clinical diagnosis. That obstruction is documented on computer as well. Okay.
Yes, sir.
Yes. So what next?
Sir, this patient will require a pyeloplasty, sir.
Right. So
And before doing a pyeloplasty, I would like I like to do a urine culture. I like to do a coagulation profile, and I like to do a routine workup, sir.
Because you say the kidney function is how split renal function?
32% and 68%.
Yeah, so she will ask you, doctor, it has come down, and she's worried. If the following surgery, will it improve?
Sir,
No, sir.
Because
I will have to
before surgery,
counsel
she
the
will ask
patient.
you.
Sir, it will not sir,
It
sir,
will not
if it is a pediatric case, then
No,
there is
this case,
40%.
she is asking you.
In this
She is
case, it won't
53-year-old
improve, sir.
female.
Yes, sir.
She's
But it won't
asking you,
deteriorate
doctor,
further,
tell
sir.
me.
Yes, sir.
Pardon?
Sir, it not deteriorate further, sir. I'm doing surgery to preserve the kidney, so that the function won't deteriorate further, sir.
Right. So now, what type of pyeloplasty you will like to do?
Sir, this is a hugely dilated pelvis. I would like to do a dismembered pyeloplasty, sir.
Okay. So now the question is whether there is a concomitant the UVG obstruction also. How
Yes,
to
sir.
say that yes or no?
I would like to do an intraoperative RGP, sir.
No, just now. See, now that is one of the pertinent point will be there in your mind before
Yes, sir, yes,
taking
sir.
the patient for surgery.
Yes, sir.
I like to do an
What
RG.
percentage? Yes. What percentage you like to again likely to have UVG obstruction and PUG obstruction both? Roughly, statistics. So if you have got that one in mind, maybe that you are missing one of the case out of 100. So how to say that yes? How you can reply to me when I say, oh, you have not ruled out UVG obstruction in this case? How will reply? How will counter it?
Sir, I will do an intraoperative assessment. I will do an RGP and see if the I will see
No,
if
so
the
in
urethra is
every case
patent.
now that is the question. So in
Yes, sir.
every case, are you going to do RGP just to rule out ureterovesical junction obstruction?
So, sir, if the if the urethra is not visualized And if it is a like if it is like if you are not able to visualize the ureter in the like in the drain study, then there is a then we are uncertain about the status of the ureter. In such cases,
if there is a usage of suction
yes,
in
sir.
intravenous urogram, what you are likely to see?
The ureter will also be dilated, sir.
There will be some build-up of contrast in the
Yes,
ureter
sir.
lower ureters, right?
Yes, sir.
And ultrasound, ureter likely to remain dilated.
Yes, sir.
Right, so you have got two documents to say that patient not likely to have usage of suction. Okay,
yes,
now
yes,
proceed. So now, whether you like to do again RGP or not, that remains the question. You have to analyze that. Okay, so now which pyeloplasty now?
Sir, sir, I would like to do a modified Anderson. Sir, I would like to do a modified Anderson 9 dismembered pyeloplasty, sir.
Okay.
Yes, sir.
How? Tell me the technique. Yes, how will do it, and tell us the steps.
Sir,
because you are a urologist, you are a surgeon.
Yes, sir. It can be done by an open approach or a laparoscopic approach.
No. Now see, the patient is confused now. So you are telling options to the patient. You can do because charges are different, or just you are telling the theory. The options are there. I'm asking you how will do it. You. Patient
yes,
is yours. Just I want to see how will do it. So are you confused still that what you are deciding to do for this patient? Patient tells you, yeah, whatever is good, doctor, please do it. So what will your reply to the patient? What you are going to do, doctor? Doctor, you take my decision on my behalf. You have told every pros and cons to the patient of all the surgical options available for pyeloplasty. And then patient says, doctor, you decide for me. So now what you have decided?
Sir, I would like
Eminence, please note we have 4 minutes left.
Yes, I think it's going to be in next 2 minutes. Yes.
Sir, I would like to do a laparoscopic pyeloplasty, sir.
Okay, so tell me the steps. Yes, you have put the ports.
Yes, sir.
Yes,
I will,
now what next?
Sir, I will dissect the pelvis and on both anterior and posterior side, and I would like to see the PUJ and to see if there is any crossing vessel. And
so you will see how you see the PUJ after just you have put your port,
yes,
camera port and other port, accessory ports.
Yes, sir.
Then how do you make out? This is the pelvis, this is
sir, I will find the ureter and I will trace upwards, and I'll also
how you find out ureter? I want to see that. I want to know that. How you are making the ureter obvious to you now? This is around 70 kg, 70 kg. The weight of the patient is 70 kg. You don't know that? So maybe if this is 70 kg weight, the patient is 70 kg, and now you are doing surgery on her. Now how will make out the ureter? You want to see the ureter?
Yes, sir.
How? You have done laparoscopy. Now port is there, camera port and accessory port in. Then what next?
Sir, I would like to, sir, I can give elastics and to make the pelvis dilated, and also, sir, I will dissect over this psoas muscle, sir. I will see the.
So psoas muscle is seen directly. If you put laparoscope, psoas is visible. Direct
no,
vision.
Sir, I will go. Sir, I will dissect the colon. Sir, can be either a transperitoneal or retroperitoneal surgery, sir.
You are thinking of whether transmesocolon or by reflecting. Right, you have decided to go by reflecting the colon. Is it suitable for a transmesocolon? This case,
left side is actually suitable for.
Better will be better.
Left side is actually like if it is
the left side.
Yes, sir.
Left side.
Yes, sir.
It's left side. Yes.
Sir, if it is a young thin patient, then it is suitable, sir. But this is a 70 kg woman, so it will be transfer.
So you have decided to mobilize the colon. What next? So how to mobilize the colon, and then what next? So you left colon, you will mobilize.
Yes, sir.
Yes. Okay. What next?
I will enter the retroperitoneum, sir, and I will identify the ureter then, and I will trace upward, sir, and I will dissect the
The gonadal vein, you saw the gonadal vein somewhere when we are tracing for the ureter.
Yes, sir.
Where was it located? Where did you
Sir,
see the gonadal vein on the left side in this lady? Because when we are looking for ureter, what was obvious was the very vein, a dilated vein.
Yes, sir.
Female, gonadal vein.
Yes, sir.
Yes. And where was it? Where did you find that? Because see, that's why I'm telling you, the practical knowledge of the candidate I'm assisting has been vigilant when he was assisting or he was doing it.
Sir, it will be parallel to the ureter, sir, usually.
Pardon? No,
Yes,
no.
sir, it will be
Where?
Sir, it will be usually parallel to the ureter, sir, initially.
Parallel to ureter on the left side. Lower pujae or near the mid ureter. Where do you see the vein to be parallel?
Examiners, please wind up the case quickly.
Yes, right. Okay, so now we have done pyeloplasty. So what we will do now? So you have seen the ureter, and now you are going to ask the pujae. Then you found you have dissected the pelvis. Then what next?
Sir, I will see if there is any crossing vessel, sir.
Okay. Okay. Fortunately, there was none. Okay.
Then, sir, this is a hugely dilated pelvis. I would like to, sir, I like to decompress the pelvis, sir, and also the lower pole. I will, the lower pole of the kidney will also be dissected, sir.
Okay. Okay. What next?
Sir, then I will. Then I will put stay sutures, sir, in the pelvis, and also at the six segments, sir.
So you have decided for doing dismembered pyeloplasty under some time. So
Yes,
where you will make initial incision on the pelvis and the ureter.
Sir, the sir, I will sir, and also this pelvis I have to reduce the pelvis, sir, because it is a hugely dilated pelvis, sir.
Okay, so medially you have gone, yes, to lateral to the ureter, you have made an incision of the pelvis, or maybe you made incision up one, and then you made a flap of the pelvis, and you dismembered the ureter, right? What next?
Sir.
What next?
Sir, I would like to spatulate the ureter, sir, laterally, sir.
Okay, then next.
Sir, then I like to
okay, so now
do
you
anastomosis,
have asked the stunt. Which stunt you will like to pass it?
Sir?
Which side of uretic stunt you will pass?
5
now
French
you are
or
doing,
6 French,
you have done posterior anastomosis.
Yes, sir.
Again, uretopelvic anastomosis, posterior one is completed.
Yes,
you passed the stent,
yes, sir.
right? 6 French, 4.8 French or something.
5 French or 6 French, sir.
Okay, right. So have you ever seen 5 French uretic as a stent?
Yes, sir.
Okay, right.
We regularly use 5 French, sir.
Okay. Okay, so now you have passed it, and then you have closed the suture. Any drain?
Yes, sir.
Drain is put in. Now patient is second post of day. There was no drain output. Drain removed. What next? Patient is taking now normal diet in the ward.
Yes, sir.
And the drain you have removed. What next?
Sir, for Hollis is also there, sir.
Okay, so for how long? So you tell me what next.
Sir, I would like to I would like to remove the Hollis first, sir, and I would like to
when.
Sir,
No, I have
after
told you
40
second day drain no output, drain remove. What next?
Sir, if the drain is already removed, then I like to remove the Hollis after 7 days, sir, because this 10 is already there. There is
Okay,
chance for reflex.
Right, you have removed the Hollis. Then next what? Patient is asymptomatic.
Yes, sir.
Yes.
Then I will discharge the patient after 5 days, and I will ask. Then I will do the suture removal after 10 days, and I will like to reassess him after 6 weeks. I will call him back, and I will examine the patient and
yes. So you will you don't know. Yeah. Now when the patient, whether the stunt is in, have you ever confirmed it? So we don't know the position of the stunt. Secondly, when you remove the stunt, do you get urine culture done?
not routinely, sir.
Yeah. Because if the patient not symptomatic, otherwise, okay, the next day patient can be fever.
Yes,
once you remove the stent, patient can be fever.
Then we have to do a urine culture, sir.
Pardon?
We like to do a urine culture, sir.
Okay. No, just you have removed the stent because
we are running
okay. What
quite
now? See, now the patient is okay, fine. Patient has been doing well. She came to. When do you call the patient up? After
sir, I
how
like
long?
to DTP
Now
after.
you remove the stent after 6 weeks.
Yes,
Patient
sir.
did well. Then what
Yes,
next?
Sir, I like to sir, I would like to repeat a DTP scan, sir. After sir, after 3 months, sir. After 3 months of this.
So what you will
surgery,
look
sir.
for? What
So
you
I
will
will
ask for?
look for the sir, in the DTP I will see for the function and also the
Okay, so
drainage.
time
Sir,
is
the
over.
drainage
Thank you very much.
improves.
Thank you all. Thank you all. Thank you very much, Dr. Arun.
Yes, sir.
Right. So now, what I just want to give the message here is, right? Hello, am I audible too?
Yes, yes.
Yes, right. So what I would like to tell, in that case, now the examiner may not be asking what are the different diagnosis like this. That is the discretion of the examiner, and whether you are able to manage a given case or not. And there may be many ways of examining a candidate. I think whatever question I've asked, I think nothing is ridiculous. Everything pertains to the practical knowledge of the candidate. So certainly examiner will like to assess now whether this is due to stone, fuse obstruction, or due to renal mass, renal ultrasound, or the cyst, or renal mass. Causes of the pain can be many. So that's a message I would like to give. Thank you very much. Okay, room to you now.
Thank you, sir. Thank you all the candidates. May we have the next set of candidates, the 3 candidates for the last case of this session. Navneet.
Yes.
Are we ready, Navneet?
Yes, sir, we are ready.
All 3
the
candidates are there.
Dr. Ashish Tyagi, and Dr. B. Shravan Kumar.
Ashish Tyagi and
Dr. B. Shravan Kumar.
And third one?
Dr. Ashish G.
Okay, fine. Over to the examiners and the presenter for the last case. May request you to keep this discussion within 20 minutes because we are already running late. Over to you.
That's right. Yeah. That's good to moderate the time.
Presentation, sir.
Yes.
Is the presentation visible, sir? Okay. 60-year-old male patient. He came with the chief complaints: painless, non-healing wound and growth over the penis since 3 months. He had history of circumcision before 3 months. The wound was not healing. He had severe LUT symptoms and associated with itching and occasional pus and blood discharge from the wound as well. The growth was initially small in size but rapidly increased to attain the present size and appearance. No any other significant symptom. No any premorbid conditions. He was a chronic smoker and alcoholic as well. Well built, well nourished. BMI was 29. On physical per abdominal examination was normal. These are the gross specimen pictures of the patient.
Yeah. So this
on
is
local
a
examination, the proliferative growth was present over the penile skin circumferentially. The meatus was not seen clearly, and the growth was present over the coronal sulcus as well. And bilateral groins were normal. Palpable lymph nodes were seen in both the groin region. The penis, the penile region, penis shaft free of induration was around 2.5 centimeters.
Over to you, sir.
Yes. Okay.
Yes, sir.
What is it?
Sir, it
and how to proceed?
Yes, sir. 66-year-old gentleman coming
No,
with
no, I
the
don't want you to repeat.
yes, sir. Sir, first differential diagnosis I like to keep as a malignancy,
Yes, sir.
CFP, sir. And second, it can be the condyloma acuminata.
Okay, so the ulceration.
And
can there be ulceration in condyloma acuminata? So much.
So it's mostly the
Anything else?
it's mostly the proliferative growth, sir.
Okay.
Along
Anything
with
else? Anything
sir,
else?
as the ulcerative lesion, we can keep chlamydia or LGV just as a differential diagnosis for ulcerative lesion.
Okay, so
But
how we proceed to manage this case now? Yes. Yes.
So coming to sir, I would like to know about the examination we have already done. It looks like the proliferative growth in the penis. Investigation.
Please
Sir.
don't
Sir,
repeat the findings. Everything has been given to you. Come straight to the question asked. And examiner is requested to rotating the question to other candidates.
Sir, investigation.
I think some other examiner can take it because my battery is low. I'm just charging it. Yes. Dr. Arun?
Yes.
You can ask some other examiner to take it.
No problem, sir. Anybody can take it. We'll move fast little.
Right. Yes. Now, because this battery is down, so I just I'm charging it. Yeah. Okay.
Given to you. Please go ahead. Please go ahead. Have a look.
Next. Sir, edge biopsy I'd like to do in this patient.
Dr. Keshav?
Yeah.
Yeah. Please go ahead now. Biopsy has been given to you.
Yeah. Go through this biopsy report. It shows it's a initial moderately differentiated squamous cell carcinoma. What else would you want to know in this biopsy?
Sir, in a lymphovascular invasion, grade B.
Yes. Other than that?
And if it is possible for depth, although it will be very difficult for the wedge biopsy to comment on the depth.
So you want to know about the lymphovascular invasion, which is not given in this. So it's a moderately differentiated squamous cell carcinoma. You've not got the other details. So how do you go ahead?
Sir, moderately differentiated carcinoma, approximately 3 centimeter or 4 centimeter present on glance with the 2.5 centimeter sum. I would like to plan for partial splenectomy.
So what are your criteria when you decide upon telling the patient that I would plan a partial splenectomy or a total splenectomy? What are the criteria which you take into account?
First of all, we have to see the we have to do the grading. We have to see the grade for the patient as well as the T stage. If it is more than
how does the grade? Suppose it's
or
high, so the grade does
as well
not
as
affect.
Yes, sir.
It's not based on the grade. It's something else. Hello.
Go ahead, sir.
Yeah.
Sir,
Go ahead.
Invasion of corpora, invasion of urethra, and other structure surrounding.
Please note, this is the growth biopsy. This is not a splenectomy specimen. What he is asking is,
this biopsy is a biopsy, not a splenectomy specimen. So,
yes, sir.
Hello, sir. Good morning, sir.
Yes.
There's some problem in network, sir. I am online right now.
Okay. Navneet can see that.
you are on. Your video is on. Please go ahead. Dr. Keshav, Dr. Ravan, Dr. Murthy, please go ahead.
We are getting echoing again. Hello.
No, it's fine.
Hello.
Yeah, go ahead, sir.
Who is Ashish? Ashish, you're taking this?
Yes, sir.
Yes, sir.
Yeah. I asked you a question on how do you decide upon partial splenectomy or total splenectomy in a given patient. It's not based on the grade.
Yes.
Hello.
Yes, sir. Partial and total are different. It is based on the stump. Adequate stump should be available for voiding of the urine. At least 2 centimeters stump should be there.
So in this case, what do you expect? What do you think?
Sir, we have a 2.5 centimeter stump available from the growth, but margin we have to take depending on the grade. Usually margin taken are in low grade we take 3 mm, then moderate we take 5 mm, and highest grade we take 1 centimeter as per latest guideline. So if margin is available, we can go for partial splenectomy.
Okay. So
So
you're
how do
planning
you
a partial
decide the
splenectomy
margin?
on this patient.
Sir, pardon me, sir?
You're planning a partial splenectomy on this patient.
Yes, sir.
The most important thing is that the patient should be able to void holding his penis. That amount of stump should be available.
Yes, sir.
Yeah. Is partial splenectomy done in this case?
Yes, sir.
This is a histopathology.
Yeah.
We are actually in the histopathology. Percutaneous was involved.
So Arun,
Yes,
Dr.
sir.
Arun. No.
Yes.
Who is there? Dr. Tyagi.
Yes, sir.
Yeah. The partial splenectomy specimen is given to you.
Sir, it's
The
a
Oxy report.
T3 specimen, and lymph nodes were not given. So we have, since lymph nodes are not calculable, we should do bilateral modified dissection after approximately 4 weeks of the surgery till the wound heals. It's an N0, sir.
What is the difference between modified and regular inguinal lymph node dissection?
Sir, pardon me?
What is the difference between modified and regular inguinal lymph node dissection?
Sir, in modified there is a smaller incision and there is a saphenous vein is preserved and flap is thick. There is no transposition of sartorius.
Okay.
And distal or lateral limit is femoral artery, sir.
Correct. So you want to do a modified bilateral. What would you do if you find nodes to be positive in modified bilateral? You set a frozen section in the modified bilateral.
So modified bilateral we are doing for N0. We would like also for the frozen section. Then another side we are doing the superficial along with the frozen section. If frozen comes to be positive, then we like to do later the deep and pelvis one also.
Okay. What can you tell me about the procedure of the inguinal lymph node dissection?
Yes, sir. Sir, inguinal lymph node dissection for modified, we after taking
Not
the
modified,
consent and
regular.
Regular, yes, sir.
Yeah.
Sir, in regular, first of all, we have to explain the patient about the complication like seroma and wound and flap necrosis and DVT and embolism to the patient. After doing that, patient is placed in spinal anesthesia in frog leg position. Incision, we have to mark an pubic tubercle. We have to take 15 centimeter vertical line and 20 centimeter vertical line from ASIS. And this line is joined superficially by inguinal ligament, lower both are joining. So this is our area where we have to do the dissection. So incision is given approximate, incision can be lasius incision, it can be if we are doing bilateral, it can be the midline vertical. And after the incision, we are taking our flap of carpus.
Bilateral vertical, how can you do? Inguinal
Sir, midline, vertical.
That is for pelvic.
Yes, sir.
That is what you are describing. through a bilateral inguinal dissection vertical midline. How can you do? Okay, go ahead.
Yes, sir. So inguinal incision is taken, and it is scarpa is taken along with your skin to keep a thick flap, and our proximal, our superficial and inferior limits of dissection are those as we have mentioned. Mostly it is superficially we are taking up to the external oblique aponeurosis, and inferiorly up to the fossa ovalis. Lateral limit is our medial limit is erector longus, and lateral limit is our femoral artery. And after doing the superficial lymph node dissection, we open the tensor fascia lata, and we clear the deep lymph nodes, femoral artery and vessels, lymphatics present over the anterior surface are cleared.
And then you do what?
And we put the drain and no sir, in sir, radical we are doing, yes sir.
Yeah, that's
Sartorial
what I asked.
transposition is done, yes sir.
Yeah.
Sir, it is detached from the ASIS, and it is still to the inguinal ligament, sir.
Okay. Shravan Kumar. Shravan, what is the difference between total pinectomy and radical pinectomy?
Total pinectomy, the penis is transected, and radical pinectomy, penis is totally shaved off from the pubic rim.
What?
Hello.
Hello. Sir, echo is not from my end. The participants have opened more than one
Participants are
connection.
talking,
Na?
agree. Some participants may be doing something which is interfering everybody. I think all participants are requested to kindly please take care. The procedures should not get interfered, should not get disturbed. Please take care. Be responsible. Thank you.
Hello.
Hello, sir.
Hello. Hello.
Hello.
Is somebody mobile is ringing?
No, you are also. I'll do that.
Hello.
Yeah. Please go ahead, sir.
Now, Ashish and Dr. Tyagi and Dr. Shravan Kumar. Yes. Are you there? Can you listen?
Yes,
Can
sir.
you hear us?
Yes, sir. Yes, sir. Yes, sir.
Reply to the query of Professor Krishnamurthy's query.
Sir, in total pinectomy, the penis is transected at the level of at the base of the penis, at the level of the pubic symphysis, whereas in radical pinectomy, the crura are totally shaved off from the pubic rami, sir.
So when do you do total pinectomy? When do you do radical pinectomy?
Involvement is there, then then radical pinectomy is indicated.
Urethra.
If the tumor is involving the urethra, along with if the penile stump is less than 2 centimeters after resecting the tumor with adequate margin, then we need to go for radical pinectomy.
No.
No.
Thank you to say because.
See, it depends on the corporal involvement. What is the level of the corporal involvement? If you are not able to get the clear margin in a total pinectomy and there is corporal involvement, you will have to go down and take it off from the ischial tuberosities.
Yes, sir.
Ashish.
Yes, sir.
What are the other than open? Is there any other modes by which you can do lymph node dissection?
Yes, sir. Sorry, sir.
Other than open lymph node dissection, are there any other ways of doing lymph node dissection?
Sir, yes, sir. There is a laparoscopic and robotic procedure that is called, sir, Whale, sir. Video endoscopic inguinal lymph node dissection, sir.
Okay. What are the advantages in this?
Sir, by doing the minimal skin incision, there is a pain reduction, early mobilization, and minimal hospital stay, and less bleeding, sir.
Then Tyagi, how do you manage patients who have undergone partial penectomy and there are no lymph nodes palpable at the time of examination and by investigation also? There are no lymph nodes. It's only lymph node status is N0. Partial penectomy T1. How do you manage these lymph nodes? How do you manage this patient?
Sir, N0 with if it is more depends on T stage and presence of LVI. If it is
T1
T1,
LVI not present.
yes, sir. Sir, if it is T1 LVI is absent, and sir, if it is sir, we can do the surveillance. Sir.
Yeah. Surveillance, how
Yes,
frequently?
sir. Sir, surveillance is done for it's a initial 1 to 2 years. It is 3 months. Then year 3 to 5, it is at 6 months. It is done by regular R examination or self-examination of the patient. And minimum duration is 5 years.
Okay. Suppose you have a patient who had lymph nodes when you are doing partial penectomy, and those lymph nodes were hard bilaterally. Would you do simultaneous lymph node dissection, or would you wait and then do a lymph node dissection?
So simultaneous can be done, it is said, if the wound is not much infected, not pus is present, or there is not much necrotic area, we can do simultaneous in partial penectomy along with the lymph node dissection. But if the wound is feel to be dirty or the wound to be get infected, we can plan it later, approximately after 2 to 4 weeks.
Dr. Keshav, can you wind up now? We are running short of time.
Okay. Okay, Arun. We will. This was a patient who had a penile lesion, which was where partial penectomy showed PT3. We were in CAPNs. It is basically how much of total penectomy or partial penectomy which you have to do. The management of the lymph nodes is important. It depends on each of those things, and they will ask you how do you do modified, how do you do radical lymphadenectomies, when do you do pelvic lymph node dissection along with inguinal lymph node dissections. So these are the things which need to be covered in CAPNs.
Okay, thank you very much, sir. Thank you. We thank the candidates and we thank all the faculty for this session. We have little activity from our time limits, but we'll try to cover at the next 2 sessions. Thank you all the faculty, Dr. Pivilan Murthy, Dr. Shravan, Dr. Hemant Pathak. Thank you very much. Navneet?
That's good. Okay, Arun.
Navneet, are you ready? Navneet?
We are ready with the case 6 participants. We have Dr. Hello. Participants are Dr. Banu Teja Reddy, Dr. Bhargava, and Dr. Biswanu.
May I request now the next set of examiners, Dr. Anand, Dr. R.B. Sabnis, Dr. Anish Srivastava, please to have the video on and mic on. Candidates are requested to keep their phone off or not to plug in or log in through 2 systems, through mobile and also the laptop, because it is causing echo disturbance to those who are already watching this program. This program is meant for you. Please cooperate. Don't log in too many appliances. Surya Prakash, are you ready with the case?
Yes, sir.
Over to the examiner, sir, and the presenter.
Who are the candidates? What are their names?
Sir, Banu Teja Reddy.
Okay.
Sir.
Actually, what their photographs should be moved to the topmost so that we know when we are talking to them.
No, that cannot be done in Zoom. Once they speak, it may come forward, but that cannot be done in Zoom.
Achha, so when he will speak, he will come.
Yeah, he will come forward.
Okay.
So how many? 3 students? No, Bhanu,
Yeah,
Bhargav, and Venkat.
Yes, 3 students, and you have to remember that you have 5 cases.
Yeah. Okay. So,
Yeah.
so you keep telling us the time.
Okay.
2 long cases and 3 short cases.
Yes, yes.
Okay.
30 minutes for long case, 20 minutes for short case.
All right.
Okay. Over to you, sir. Surya,
Please go ahead and present the case.
presenter, are you ready for the case?
Yes, sir.
Yes.
Here is a 70 years old male patient, Mr. Vaya. He is a retired government employee, resident of Hyderabad, presented with history of hematuria since 1 month.
Go ahead. Go ahead.
Patient has an history of painless grass, complete hematuria with clots 3 to 4 episodes since 1 month. There is no history of similar episodes in the past. So there is
Yeah, I think this is a very straightforward case. You complete the various other things.
Okay, sir. There is no history of floods, dysuria, no history of pain, abdomen, fever, recurrent UTI, no history of retention of urine, no history of lithuria, no history of previous urethral instrumentation. Patient has no history of bleeding disorders, no history of loss of appetite, loss of weight, no history of cough, Vesuvian, other systemic metastatic symptoms. The past history patient doesn't have similar complaints. Patient is a diabetic, hypertensive with a known CAD patient. There is no history of COPD and tuberculosis. Personal history is a non-smoker, non-alcoholic, consumes mixed diet, bowel habits are normal. No family history of significant malignancy or other internal disease in the family. Treatment of this patient and medication for diabetes and hypertension. Patient and anticoagulants, aspirin, clopidogrel. There is no advantage.
Tell us the examination also.
Okay, sir. The moderately built and moderately nourished. Performance status is ECOG 1/5. Vitals are normal. No pallor. The abdomen is soft, non-tender, no organomegaly, no palpable bladder. External genital normal. DRE grade 1, non-tender prostate. There is no hard nodule.
All right. So, okay. So, Bhanu, you tell me what differential diagnosis you will put in this case in the order of priority.
Order of priority, I would like to first put bladder cancer as my first diagnosis, sir. Bladder then followed by upper tract malignancy.
See, when you are answering in exam, you have to be very clear. What mean by upper tract malignancy? Yes, bladder malignancy, renal pelvis malignancy, upper ureteric malignancy, RCC, like that. Upper tract malignancy is you are inviting one more question which does not give you any marks.
Okay, sir. I would like to consider RCC and renal TCC.
Okay, what else?
It could be urothelial malignancy.
Okay, what else? What else? Yes, Bhargav, you want to add anything?
It can be a benign prostatic hypertrophy, CA prostate.
And why you want to consider CA prostate in this case as a differential diagnosis? Anything which whatever you say, you have to justify. So just that with this presentation, how you put
70-year-old
CA
male
prostate as a diagnosis.
And with hematuria, CA prostate can be one of the differential diagnoses. Sir.
So can CA prostate present as the gross penless hematuria?
It can present as hematuria, sir.
What are the things which you will see first? You see, you have to say in the order of priority. On examination, everything is normal, DRE grade 1 prostate. So are you going to keep CA prostate as a diagnosis, as a differential diagnosis in the order of priority?
No, sir. No. Anything above 60 years with hematuria, first diagnosis should be a bladder cell carcinoma.
No, he has already told
carcinoma
whatever
bladder.
you want to add, anything you add. Otherwise, we'll go to the next candidate.
Can be a benign prostatic hypertrophy.
He has already told that.
One more diagnosis.
It can be, or it can be a vascular malformation of the kidney with bleeding.
Vascular malformation.
Or like AV malformation.
Anything before that? Anything before that? Okay, Venkat, you are in the picture. Venkat, what do you think?
Sir, I am Dr. Biswan, sir.
Who? Vishwas?
Biswan, sir. Sir,
Vishwan,
yes, sir. As the patient is on blood thinner, that might be the cause, one of the cause.
Very good. That's a very nice thing. Okay, what else?
Yes.
One of the.
Yes, GTP can occur in any age and it can present as hematuria. What else? In order of priority, you can also keep a stone diagnosis because stone also cause hematuria and sometimes they may not have any symptoms of flank pain and things like that. Okay.
Yes, sir.
All right. So anything else you want to know from examination? What
Any
is
previous history of trauma?
Yes, so very important that history of trauma is very important. Why they will come with recurrent episodes of hematuria and trauma?
Pseudoaneurysm or AV fistula formation, sir.
Okay, Vishwanu, you tell me how a patient of a trauma can present as intermittent gross hematuria. In what ways it can present?
Sir, if there is a trauma, there may be a pseudoaneurysm which may cause intermittent bleeding. Sir.
Okay, so trauma causing vascular malformation and causing intermittent hematuria. That is one. Okay, anything else?
Any fistula formation between vessel and the GU system.
Yeah, so that's okay. That is the same. Vascular malformation includes everything. Anything else? Any trauma in the incidental trauma in the yeah. Like for example, a PUJ obstruction or any other if there is a mild trauma, then also it can cause hematuria and which can be intermittent. Acute trauma also it can have intermittent hematuria. Other things which you have to keep in mind. Dr. Anand Kumar wants to add anything.
Yeah, actually we are asking painless hematuria. So painless hematuria is that most of the thing will be only lower tract malignancy, because upper tract malignancy invariably have some degree of drama of the upper degree of clot colic. So basically tuberculosis, EPH and the bladder malignancy, these are the most common causes of painless hematuria in this age group. So rather with that we can move, and that anticoagulant patient is an antiplatelet. So we can move further now.
I would also like to know about the history of clots, sir.
No clots.
Okay.
Okay, how will you proceed now?
With a routine urine culture sensitive CBC, RFT and LFT, and coagulation profile of the patient.
No, show the investigation.
I will also add, sir, PSA to the investigation, sir.
No, one by one. Now what is this urine showing?
RPC is 50 to 60 per high power field disease, sir.
Okay. Okay.
5
WBCs.
There's no anemia. There's no anemia in the patient, sir. Patient is 13.3. Normal.
13.
Yeah. So everything is appears normal, sir.
Hemoglobin is 13, sir. Serum creatinine is 0.7.
0.7. Okay.
Normal, sir. Everything is normal.
What next you want?
So next is urine urine cytology and PSA, sir.
Urine cytology. Okay. Urine cytology, is it done?
Yes, sir. Culture no bacterial growth, cytology done. 3 samples, negative for malignant cells.
Okay.
Next is USC, PSA and USC KUB, sir.
Serum
Are
PSA with
you happy with the cytology that it is negative? What does it mean?
Sir,
Cytology has a sensitivity of only about 40%, sir, but specificity is very about 80%, sir. So 3 samples are taken, sir.
What are the different ways to increase the yield of positive cytology? Are there any methods so that you can have the
Sir, post-void, freshly collected midstream urine should be collected, sir, first of all. This is the best sample to collect. Next
Sir,
is
first
barbican
void,
specimen can be collected, or bladder wash can be given, and a bladder wash can be collected. So that will increase the yield of the cytology, sir.
No, we are not asking bladder wash. We are only urine cytology. So it is right that freshly collected voided sample. What else? Why they have written 3 samples?
3 samples. The first sample
What about 4th and 5th
sample
and
becomes
6th
the
and 10
sample.
samples?
No, sir. The sensitivity doesn't increase after. The sensitivity increases, but not recommended after 3 samples. Not that much increase
Right,
that
okay.
is recommended.
So what next you want?
Sir, this urine cytology.
Sir, next is PS and USC KUB.
Yeah, somebody is asking.
So this urine cytology, according to the Paris classification, it is not given. So I will add. It should have been given in Paris according to Paris classification.
No, that's okay. It is negative, so that's enough.
This is what they have mentioned.
What next you want?
Serum PSA and ultrasound KUB, sir.
Serum PSA and ultrasound. Okay.
Serum PSA is 1.2, sir.
So I did not see the coagulation profile. Once we can see the coagulation profile, I think it's
Coagulation profile is within normal range.
okay. So next is USC KUB.
You want ultrasound KUB?
Yes, sir.
Okay, ultrasound KUB.
Bladder. There's a hypoechoic lesion occupying the left lateral base of the bladder, sir. Extending, it's a sessile growth about 3 to 4 centimeter, hyperechoic lesion occupying the base of the bladder, more towards the left side, and extending towards the left lateral wall a little bit. The kidney, there's no hydronephrosis seen, sir, when I saw.
CCT KUB. Why you want CCT now?
Because the tumor size is a single sessile greater than 3 centimeter, it appears, sir. So it's better to see whether any nodes are present or muscle invasiveness. How is the kidney status? The other bladder wall thickening. What is the status of the other any growth is present?
Okay, so Bismano, you tell me what are the indications of doing CCT when you see the growth in the urinary bladder?
Sir, the growth, sessile growth, size more than 3 centimeters, sir. And if necrosis or calcification present, sir, and
P205.
What else?
Bladder wall thickening, any other growth, kidney status, ureter
multiple
status.
growth, sir, multiple growth, hydronephrosis.
To know the lymph nodes, sir, lymph nodes and metastasis.
No, lymph node metastasis, ultrasound KUB, how will you see lymph
If
nodes?
there is hydronephrosis, sir, if there is hydronephrosis, also we will do CCT.
Yes, that is an indication for CCT. All right. So these are all, you must remember that what are the indications of CCT when you see on ultrasound the growth in the bladder. Okay, Dr. Anish. Want to ask anything?
See,
Kumar, you want to ask
they
anything?
did reply, but their reply was not in a very coherent order. Like when somebody has a painless total hematuria in elderly patient, the investigation should be after the urine examination and culture. The most and kidney function most comes to the straight way to the imaging. That is up to you and whether you have asked ultrasound or CT scan. But one of the imaging is important. The imaging will give most of the information. After the imaging, other things may come like cytology and other things. Like, so that is the one of the important thing they should remember rather than coming, not going in a proper way. So that is my advice, and then we can.
Correct. Okay, so now I want to ask who else is there? Bhargav. Tell me, what is your reason for asking CECT in this case? Indication you have said, all right. So what is the purpose of asking for CECT in this case? Ultrasound
First is to know the anatomical origin of the, where is the bleeding from, so whether it's from bladder, kidney or ureter. Next is to recognize whether it's, if you do cystoscopy, whether we can dissect the full tumor or not, or whether full resection of the tumor is needed or not.
No.
Then also to visualize.
I think your answers are wrong.
Are you going to do that with the CECT app? I'm asking hydronephrosis.
Yes,
and
sir.
this is about 3.5 centimeter tumor, so I have accept that indication is okay. But what are the reasons of doing CECT?
It's a perivesical invasion, adjoining organ invasion.
Okay,
Whether
so
there
you
is
want to know the T stage of the tumor.
yes, sir. T stage and also end stage of the tumor, CECT will give us an idea, sir. Whether nodal involvement, pelvic node gets an 8 mm or not.
Okay, what else?
There is a very simple,
and also
very simple question. Can CT scan will give you the stage of the T stage of the tumor?
It can give.
It doesn't
Perivesical extension can
accurate staging. So like it doesn't differentiate between T3 and T4 can be made up with CT scans.
Why CT scan cannot tell you about T2 and T3? Why?
Microscopic invasion.
Because the muscle.
So the muscle. Hello.
The sensitivity for identification muscle invasion T2 stage is less, sir, but T3 and T4 can be identified. Sir.
Why CT scan cannot tell you between T2 and T3? That's the question is. If you know the answer, tell me. Otherwise, you can move. Hounsfield unit and of the tumor and muscles are more or less same. That's why it cannot differentiate. Yes, it can differentiate T4, but not T1. That's why it is not part of the staging. Yes. So that should be the answer, other than we are moving around unnecessarily giving some irrelevant answers.
Any other reason of doing CT scan?
Lymph nodal invasion, sir.
Lymph node, he has said. Dr. Anand Kumar also pointed out so many things. That is also noted.
Kidney HU and hydronephrosis of the kidney is
that's not
present
there
or
on
not.
the sonography. No, there is no hydronephrosis.
Synchronous malignancy elsewhere is present or not.
Okay.
Nodal status.
Elsewhere means where?
The upper tract of the urinary system.
Yeah,
sir.
sometimes you can find out some space occupying lesion in the upper tract, in the calyx or pelvis or something, which cannot be detected on the ultrasonography. Okay. And also you want to see the function of the both kidneys.
The kidneys also, sir.
All right. Okay. So CECT, is it done?
Yes, sir.
Please show the CECT of the abdomen. Okay, please look carefully, the CECT. Okay, go ahead, next plates. Okay, these are the plates. I think better to show the report.
There are two tumors, sir. One is on the right, one is on the left.
Just read the report quickly.
Enhancing lobulated mass seen involved the left, there is no evidence of significant ureteric dilatation. Mild retraction of the bladder wall is seen at the site of the lesion with no evidence of fat standing or infiltration into the surrounding structures.
Okay.
Lymph nodes?
No evidence of lymph node enlargement.
No
lymph nodes, no liver, everything is normal.
Yes, sir, normal. Everything else is normal.
Okay, good. All right. So Bhanu Teja, now tell me what next steps you will take.
Sir, next I would like to counsel the patient, sir, and send him for a pre-anesthetic checkup, sir, and plan for a TRBT, sir.
Okay. So he's on anticoagulant, double anticoagulant.
Yes, sir. So I would like to stop the clopidogrel, sir, 1 week before the surgery.
Hello.
Hello, sir. You can hear me?
He's on anticoagulant. So what will you do?
Sir, his coagulation profile is normal, sir. So
Yes.
stop the clopidogrel 1 week before the surgery.
Okay.
And then,
The right answer. You should consult the cardiologist.
The cardiologist.
Stopping the clopidogrel is advisable or not. Whether it can be, suppose he has got a very bad heart.
He needs.
See, there are certain that I think that's a very right point that you cannot irrationally stop it, because there are situations
should,
where you cannot stop the clopidogrel.
So we should find whether the patient should be shifted to Loma.
You have to follow the regime that which way you want to shift. You want to start the fragment, and then 1 day prior you change to heparin, 6 hours prior you stop. So all those things have to be checked. So when patient is on dual anticoagulants, this is the answer which is expected out of you. Not that just stop it for 6 days and then you go ahead. All right, okay. So now everything is fine. Cardiologists have seen it has been stopped. Anesthetist fitness is obtained. So what next you want to do?
The cystoscopic examination and anesthesia, sir. We should. I would prefer GA with muscle relaxant or spinal with obturator block on the left side, sir.
Okay, so you want to do spinal with obturator block. Okay.
Or GA with muscle relaxant, sir. Depends on the anesthetic fitness of the patient.
No, he is fit. So do you have any preference for anesthesia, or it is whatever anesthetist they feel all right?
There is no much difference, sir. Both are equally good, sir.
So you should go ahead and tell that, okay, I want to do a cystoscopy with bimanual examination under anesthesia, whichever anesthesia you prefer. Now you can qualify that if it is done under spinal, or if it is. So you mean to say if it is a GA, the obturator block is not required? Is that correct?
No, sir. It is. There is controversy, sir. Some people say we need obturator block. Some people say with muscle relaxant it's enough, sir.
No, some people say has no meaning in answer as I answer in exam. Yeah, obturator block should be given. All right. Okay. So Venkat, you agree with that?
So Vishwanu,
you agree with that?
Yes, sir. I agree with that. Sir.
So even if it is GA, obturator block is required.
GA muscle relaxant will be enough, sir.
Which muscle relaxant?
Choline, sir. Succinyl choline.
Choline. With choline can you do obturator? You prevent the obturator block. Remember, this obturator block is the local stimulation of the obturator nerve. If you give anesthesia with central relaxant, the local arc is not going to, reflex arc is not going to get blocked. So don't be under the wrong impression that when the GA is given, there are different types of relaxations they give. If it is a centrally acting, the reflex arc is still persistent because it is a local stimulation. If it is a peripheral acting muscle relaxant, then yes, it can be blocked. Otherwise, in spinal anesthesia and in general anesthesia, if it is a central acting, obturator block can be given, it is necessary. Okay, in case if you want to prevent the obturator jerk. So that is a concept which you need to know, which you have to tell in exam. Not that
can I
say that. Yeah, Anish, you want to say anything?
Yeah, because they are going around the muscle relaxant, which is an umbrella term. I would like giving GA under the deep planes, and generally they use norcuron, right? And with that, in a tumor which is positioned on the posterolateral wall, which is the area where the obturator nerve also is, most adjacent to this, still the chances are 5 to 10%, even with a good muscle relaxant. And now supplementing that, that in case you get the obturator spasm, at that time you have to give scoline, right? Because the mechanism of action is different. It's a non-depolarizer, and obturator nerve will get blocked using scoline. The mechanism of action starts in 45 seconds and lasts up to 7 to 10 minutes. In that time, you can do the deeper part. So the advice to the students is, when they are saying muscle relaxant, this is a umbrella term. They should be clear between the norcuron, and it is commonly used by all the anesthetists. Scoline you cannot use for the long-term anesthesia, because
it's a short acting.
Yeah. So okay, so we go ahead.
Yeah, so I think that is the answer which you have to all of you should know, and that is what is the answer which is expected in the exam. I think Anisha has very rightly described that. Okay, so next is that you want to do scopy with examination under GA with the obturator block. Okay, so what things you want to check in scopy? Show the scopy findings if you have.
So urethra is normal, bladder, there is solitary papillary growth seen over the left lateral wall, both ureteric orifices seen and normal.
Okay, so Vishwanu, you tell me, are you happy with these findings, or you want to know something more than this?
Other areas of the bladder.
Other areas are normal.
Whether the tumor is resected, TURBT is done, whether tumor is resected fully or not.
No, before that, when you are doing scopy, they have written solitary papillary growth seen over the lateral wall. Both orifices normal. Now, are you happy with this this information, or you want to know some more information, or you find out some more things?
Sir, whether there is any reddish patches in the bladder, and whether what is the distance of the.
Okay, so you want to know whether there are any other suspicious patches. Okay, that is good. Orifices are away from the tumor, so that is good. Anything else you want to know? There is no other tumor anywhere, so that is that is already told. What more things you want to know?
So whether there is any blood,
it is important.
Whether the ureteric orifice, ureteric jet was like any bloody. Ureteric,
no. Anything else?
The prostatic urethra is normal, sir.
So
Normal,
the size
normal.
of the growth, sir, on cystoscopy.
Yes, so that is very important. Size of the growth, and what else of the growth is important. See, when you do cystoscopy, apart from the various other things,
so
you have to know the details of the growth. Now, what are those details?
So the papillary, the size of the stalk, sir, whether it is a broad-based stalk or whether it's a narrow.
Correct. Very good. So you want to know the base, even though it is papillary, how much is the base of the bladder? Whether it is freely pedunculated growth in the bladder, what is the size of the growth? So that is all important. Okay. Okay. So when will you do cystoscopy examination under GA? Will you do it before you start scopy or after you do scopy?
It is done both
we have to do both before and after the cystoscopy.
No, one by one. Tell Vishwanu, you tell me.
So we have to do both before and after this cystoscopy, sir.
Before and after cystoscopy?
TURBT.
TURBT.
Yes, sir.
Okay, before and after TURBT. So is it before cystoscopy or it is before TURBT?
Before cystoscopy, sir.
Before cystoscopy? No, that's not right. The sequence is that you must do cystoscopy. Why? Because you want to know where exactly you want to palpate. When you are doing palpation under GA, you want to know where exactly you want to palpate under anesthesia. So cystoscopy is necessary. You do cystoscopy, empty out the bladder, and then you do palpation under anesthesia. Okay. Okay. So tell me, what are the prerequisites for doing examination under anesthesia? Who want to take up that question? Bhargav? Bhargav is there?
Yes, sir.
So Bhargav, what are the prerequisites to do examination under GA. You have done cystoscopy. You have seen that there is a lateral wall tumor, and
Yes,
now
sir.
you want to do cystoscopy under GA.
Yes, sir. What is the indication for doing bimanual examination, sir? What is the question, sir?
Yeah. So no. Indication is definitely there. You want to do it, but what are the prerequisites which you will follow?
So, ideally, we should keep one hand in males, one hand in females, one hand in the vagina. Sorry. So ideally, patient should we should after doing cystoscopy, we should palpate whether the tumor is palpable or not, sir.
Yes.
And then we do the TURBT. Then we look whether
prerequisites in the sense that one prerequisite is that bladder should be empty.
Empty, sir.
Okay. Then if you are doing under anesthesia, then the relaxation should be complete, because sometimes if they give controlled anesthesia, if they keep the patient under superficial anesthesia, the muscle may remain tight and the muscles may not be completely relaxed. When you are doing under anesthesia, the complete relaxation should be there. If it is spinal anesthesia, it is already relaxed completely. So there is no need of doing anything. And prerequisite is that it is to be done after cystoscopy. So you know where exactly to palpate and where exactly to. If tumor on the right side, your more focus is on the left side, your more focus is on the left side. Okay. Anish, you want to add anything to that?
I think we have to move forward because it is almost 30 minutes.
Okay,
We
so
have to
go
quickly
ahead
wind
and
up.
show the TURBT findings.
the size of the tumor, sir.
No, TURBT, now forget that. TURBT finding.
HP report, sir.
Histopathology.
Histopathology, sir. As high-grade papillary urothelial carcinoma, lamina propria invasion is noted. Muzzle invasion is not seen. Muzzle is present and invasion is not seen.
Okay, so complete resection is done and this is the report.
Yes, sir.
So what will you do?
Sir, ideally, TURBT should be done at 2 weeks
TURBT
and
should be done, sir.
2
After
weeks.
4 weeks.
No, one by one. Let Bhargav answer.
Sir, TURBT should be done from 2 weeks to 4 weeks. Anytime we can do, sir.
So you want to do re-TURBT?
Yes, sir.
Okay, re-TURBT. Do you have any findings of re-TURBT?
No, sir.
Okay, restage TURBT done. Bladder normal. Resection done from the scarred area. No tumor
Muscle
found.
not-
No tumor
muscle not-
found.
Okay, sir. Okay, sir. Then we should start it since it's coming a G3 tumor, sir, and also T1. So it comes under high grade, sir, in EORTC classification. So it should be ideally, patient should be subjected to 3 years of BCG therapy, sir. After 2 weeks post resection, we should start induction BCG therapy, sir. Weekly induction for 6 weeks. Sir.
So you are using which classification?
Sir, this is
T1, G3 is
the EUA staging of the bladder.
EAU 2020 guidelines recently which have come. Yeah, so I will tell you these are the guidelines which
risk and high risk, sir. High risk has been added, sir.
So can I ask a question? When did the last AUA guideline come and what is the difference between the two? If you know the answer, otherwise I'll tell you.
Vishwanu, you tell the answer. Vishwanu, you tell the answer.
Sir, T1 G3 is high risk, sir.
In both,
first
in AUA, which was in 2016, and EAU 2020, in both T1 G3 is high risk.
High risk.
What is the difference between these two guidelines?
So in EAU 2020, highest risk has been added, sir. T1
Highest is one is a
highest
column of
risk
highest risk has been added, and
That
other
is
thing
G1,
is that T1 low grade is
now the
also
surveillance
is
Yes,
also
sir.
taken into the high risk in EAU, whereas in AUA it was in the intermediate risk. Okay, and yes, and then what are the other things, the variants which which they look for, where you say that it is the
lymphovascular invasion, sir.
Yes. What else?
So poor
Other urothelial
histological
carcinoma, sir.
variance, sir.
Lymphopithelial.
Micropapillary,
micropapillary, sir.
sarcomatoid. If you have
Sarcomatoid and micropapillary.
yeah, these have the worst prognosis. Therefore, they have been kept in the highest risk. So there can be many other things like nested variant and giant cell, signet ring, and all that. Lot of things are there, but you should remember that if you get a micropapillary comes under the highest risk, which has been now defined in the EAU 2020 guidelines. It was not there in the AUA guidelines. Okay, so with that, you have a T1, G3, and you were talking about the BCG. So which regimen?
Sir, we can counsel the patient, sir, because we counsel the patient regarding whether he wants a conservative protocol or whether he wants radical protocol, sir. If it's conservative, he can subject him to immunotherapy, sir. If he wants radical, that he doesn't want future surveillance, like he doesn't want to follow up continuously with BCG, then we can go for early cystectomy also, sir. Depends on what patient chooses, sir.
So this patient is having a lot of comorbidities, history of coronary artery disease, lot of comorbidities is there. So I will explain all about the
So
disease,
what
because
dose
there are a lot of these
what
factors
dose
are
you
there.
will give and what regime you will follow?
Sir, for induction, we use the Morales regime, and for maintenance, we use the SWAG or the LAM regime, sir. So Morales regime is
Dose.
40 milligrams, sir. 40 milligrams, sir. Induction phase, 40 milligram we give for 6 weeks. Then 3 weekly for at 3 months, 6 months.
Why 40 milligrams?
Hello,
What is the logic of 40? See, there is a lot of controversy and you must know it if you are answering like this. 40 milligrams, 60 milligrams, 80 milligrams. What are the differences?
Sir, there is a, according to the recent guideline, there is no difference between 120 milligram and 40 milligram. 1/3 dose, they have seen that 1/3 dose also, there is a low risk, low side effects, sir. So they are preferring 40 milligrams, sir, nowadays.
So the efficacy of BCG in various doses have been studied, sir. It has been equal in 80, 120, and 40, sir. But the tolerance is better with 40 milligrams than 80 and 120 milligrams, sir. So patients who have very low, low tolerance for BCG, we can subject them to 40 milligrams, sir. Or in our institute, we use 80 milligrams, sir, of BCG therapy.
Yeah, so I understand. Actually, most of us are using 80 milligram, and in SGPGI that study is also quoted and some other studies. And now there are many centers which are using 40 milligram as he says, and EAU 2020 guidelines. In exams, you should say what is your practice, because what I have seen, the students get confused suddenly during the exam whether they should be straight away talking guidelines or they should be talking the practice which is done in your center, right? So first you should say what you are doing, okay? And
most center will follow 80 milligrams,
yes,
and if they don't tolerate, then you reduce to 40 milligrams. That is a protocol where most centers will follow.
Exactly. So the students should not say suddenly about the guideline. You should say what you have been following. Now tell me, in your center, are they following this?
Yes, sir, 80 milligrams, sir.
80. So I caught you. So you said 40 because you read that last night. You read the EAU 2020 guidelines. Tomorrow AUA may come up with some other guideline. So your answer should not be based on that, but you should know. It's good to know, but say what is your practice. Okay.
How much time do we have, Dr. Chawla?
We have to wind
2 minutes. 2 minutes. 2 minutes.
2 minutes.
Okay.
So I think we can wind up. We just can summarize in a case like this. First of all, you must know the differential diagnosis in the order of priority, which Dr. Anand Kumar lightly pointed out, that you should not jump from here and there. Investigation should be with the justification, whatever investigation you want to do it. In the non-invasive bladder tumor, the technique of TURBT really asked question in the exam. The mitomycin we have not discussed, but the role of mitomycin, when it is to be done, how it acts, is the very frequent question which will be asked in exam. And of course, various things about the BCG. What is the regime which you follow? What is the dosage schedule you follow? Why 40 milligrams? Why 60 milligrams? What are the different publications which are there? What are the side effects? What is the BCG refraction? What is BCG failure? What are the side effects of BCG? What is the BCG septicemia? If that happens, what are the treatment protocols which you will follow? So these are the things which will be covered in the non-muscle invasive bladder tumor. Okay. And then lastly, the indications of cystectomy. What are the indications and when will you do cystectomy? Early cystectomy will be the question. So if you get a case like this, then these are the questions which are likely to come up, whosoever is the examiner. So you should be ready with these sort of answers of these questions. Okay, so I think we can stop at this point of time. Dr. Chawla, you can go ahead with the next case.
I just like to add one more thing.
Thank you, sir.
Hello.
Yes, please go ahead.
Please go ahead. Just to make a better answer, the boys did answer, but the one of the boys said that we are discussing a case. When it comes like the final diagnosis is proven that it's a high grade. Then he should say that you have to see that patient is 70 years, he has got the comorbidity, he has got the heart disease. You have to see that what is the risk of the ablative surgery and risk of giving the immunotherapy. Both the options should be discussed with the patient, and then he should be advised that probably looking all the comorbidities is a better thing. But at some stage, you might, the tumor may progress, and that you might need aggressive therapy if cystectomy will be possible or some other thing will be required. So this kind of communication should be explained to the patient, and that should also come into their answer, so that examiner will immediately come to know that this guy knows what is the way option and what is the best way to handle it.
Correct. Okay.
Thank you, sir. Thank you. Thank you, the three candidates. Navneet, we'll move on to the next three candidates. Can you invite them to have their mic on and video on?
Hello, sir.
Yeah. Can you introduce?
Candidates.
Yeah, three candidates. Please tell your names.
I'm Dr. Chirag.
I'm Dr. Bonisha.
And third one? Who's the third one? Navneet?
Otherwise, we can manage with two.
Yes, we'll go ahead. We'll make him join later. And
so don't waste time. Who is doctor?
Okay. Boni, Chirag, and Brijesh, over to examiners and the presenter.
Yeah, please start presentation.
38 years old female patient, sir, with complaints of increased frequency 12 to 15 times per day since 3 months. Urgency was also present. Fever since 1 month, which was low grade, intermittent, and not associated with chills and rigors. Loss of weight and appetite history was also present. No any other significant symptoms. No any significant past history. No history of pulmonary TB and no history of TB in the family members as well. On physical examination, everything was normal except pallor was present. No per abdomen soft, non-tender, no palpable mass.
Okay, so come back to the history page. Okay, so Dr. Boni, you want to add anything? You want to ask anything more than whatever is provided?
Whether what is the menstrual history of this patient? Whether she has any amenorrhea or any whitish discharge per vagina?
No, sir. Except for whatever is mentioned, everything was fine with the patient. No any significant positive history was present.
Why you want to ask menstrual details?
As looking at the history, my one of the differential diagnoses would be a genitourinary tuberculosis. she may have involvement of the.
Anything else you want to ask?
Any history of irregular periods, or what about the married life? Whether any obstetric history of the patient?
No significant obstetric history.
Were there any history of hematuria?
No.
No.
No hematuria. Okay.
No past history of surgery also. No intervention in the past.
No intervention done.
Okay.
Is there any history of constipation?
No, sir.
I think we should move further. So with that history, how will you proceed?
So examination is also told. So we can straight away go for DD.
How will you proceed? What is your possible diagnosis?
Since patient has a most lower urinating symptoms, first differential diagnosis can be urinary tract infection. Patient is having since last 3 months. Maybe it is a complicated UTI. Second diagnosis, it can be GU-TB, and we can't also rule out any upper tract like PUJ obstruction also. That can be the third differential diagnosis.
Why not overactive bladder?
Yes, sir. It can be. Sir, it can be.
Okay. So how will you proceed further?
No, in this kind of history of low grade intermittent fever and stuff like that, and only if they had frequency, then we could have added the differential diagnosis of overactive bladder and interstitial cystitis also. But here, since there is a history of fever going on for last 1 month, so probably that could be at the end of the tail end of the list. Okay, go ahead.
Sir, I would like to ask for routine investigation like urine routine microscopy, urine culture, and blood investigations, ESR, and for.
Let's see the urine report.
Urine report and all blood investigations are normal, sir. Only ESR is raised.
The urine report.
What does urine show?
Something in urine.
In urine only bacteria was present. Numerous pyuria was there.
Pyuria is there.
Bacteria is present.
So that's a very important report. Why? This report is very important. The report which is on the screen is a very important report. Why? Hello?
Yeah, Bonnie, Dr. Bonnie, you are answering.
Yes, sir. As the patient has bacteria present, there may be of infection.
No,
there.
see, this is very.
Let us go ahead. This is sterile pyuria.
Numerous WBC and culture is sterile. So we do not, there may be 1 or 2 bacteria present, but they are not significant. So it is a sterile pyuria. That is the most important finding in this. So what is next investigation?
I would like to do a urine AFB and ultrasound KUB of this patient with post-war testing.
What is the urine AFB report? Okay.
So which method do you use for urine AFB reporting?
ZN stain will do.
What is the sensitivity of this?
It has a sensitivity of around 20 to 30%.
No, it is 50%.
40 to 50%, specificity 80 to 90%, sir.
Okay, and then you do you subject the same samples for the culture also at the same time?
No, sir. For culture, we required a different sample. Overnight sample is required. 3 consecutive.
3 consecutive samples. Okay. So going ahead, do you have other reports? No. This is in the next.
Imaging.
No.
The right kidney was normal. Left kidney
is negative. They have already shown that TB PCR, urine TB PCR is negative. It sterile pyuria. So now you already have how will you proceed? These are the patient. This is the patient has this sort of a complaint. So how will you proceed now? Chirag, you can answer that.
So since renal function tests are normal, I can ask for a CT IVP, sir, to know about the
Whatever you want to ask, you ask. Whatever
Yes,
you
sir.
want to ask, you can ask.
CT IVP, sir. Imaging USI, since it suggests of left side thinning of renal parenchyma on the left side and upper pore collected disease, I want a CT IVP.
My question is why, if you have this kind of history and the pyuria and the urine showing the tuberculosis, then why ask ultrasound? Why not straightway ask for the imaging either IVP or CT IVP, CT urography?
Sir, ultrasound is a basic investigation. It can tell about the bladder, the capacity of the bladder.
No, it is not necessary all the time. Basic investigation has to be done because that also costs money. So when in this situation, straightway you can ask for the IVP or CT urography.
Yes, sir. Yes, sir. We can ask. Sir.
So show the CT IVP.
Yes, sir. Run the picture.
Show all the extra IVP.
Show all the plates. Okay, show the report if the plates are not there.
The right kidney appears to be normal, sir. Hypotension measuring 1.6 by 1.7 cm in the mid-pole right kidney, with irregularly condenses in the upper pole of the left kidney, and measuring 9.3 by 7 centimeters thinning of the renal cortex with thin internal septa measuring 1.6 mm and abrupt tapering of PUJ present, sir.
Okay, so what will you do? This is a picture. So
Okay,
what do you think? What does it suggest? Show this picture. Describe this picture.
So it is CT IVP showing the left side, which is a thinned out parenchyma with the possibility of a PUJ stricture. So it is a compromised system on the left side, and it might be the right side is the only functioning kidney. So
What is there in the left side lower pole?
Dilatation, sir. Dilatation of the calyces, sir.
No, what is the arrow which is there? Now, what is that? The lower pole, is it a parenchyma or it is a cyst or what it is?
Sir, lower pole functioning parenchyma seen, sir. It looks more like caliectasis of upper pole, sir.
Yes. So, what do you suggest with that? Lower pole, there is a functioning parenchyma which is quite okay, and the upper pole, middle, and this is completely dilated. It is a thin parenchyma. So, is it a duplex system? So, you have to see more plates. So, basically, when you do CT scan, CT IVP, it is the problem of the CT. Only few pictures which you are seeing. Few pictures in the CT IVP will always be misleading. And therefore, your answer should have been that you want to see all the plates to give exact idea what exactly the all the pictures are showing. Okay, so let us go to the report. Let's not waste time.
Yeah, sir, it is basically spiral caliectasis with the small intrarenal pelvis with the urothelial thickening, opposite kidney normal.
Okay.
Yeah, and the bladder was a good capacity. Yeah, just a normal adequate.
This is the finding.
So what will you do next?
What next?
Sir, I'll start the patient on ATT, sir, anti-tubercular treatment with a.
Before that, you should have some more information.
Sir, I want to do the renal function test and also the liver function test before starting ATT,
you
sir.
should know whether this kidney is salvageable or not salvageable at this stage. So DTPA scan is very important to know.
If the CT scan is showing thin out parenchyma, hydronephrosis, do you think that this kidney now is non-salvageable, or you give up this kidney and just start AKT and forget about it? You want to know further and you want to salvage this kidney.
know the functioning status, sir. We can do a DTP and know the function of the kidney.
So unless you know what exactly is the DTPA, EKT starting and all, it is perfectly okay. Nobody is quarreling with that. But we are side kidney, all right?
Yes, sir.
So you want to know the DTPA function. What exactly is the function? Is it done?
11%.
Okay, it is a 11% function. All right, so now what will you do? Everything has been done. You have sterile pyuria, TB PCR is positive, patient has frequency, low grade fever, CT IVP shows this, creatinine is normal. Now tell us how you want to manage, what is your plan of action in mind. You have done CT IVP, you have done the renogram, everything is available. Okay, so Brajesh, where is Brajesh? You tell.
Yes, sir. Yes, sir.
How will
Yes.
you manage this?
Sir, since patient came with the primary complaint of frequency, sir, so we didn't evaluate the bladder capacity for the patient. So I want to evaluate the bladder capacity by doing VCUG, sir. And later on for this kidneys,
how will you evaluate bladder capacity?
Why not just
either by doing, sir, VCUG, sir, or we can do by cystoscopy also we can, or
No, tell me, VCUG, is it VCUG which gives the capacity? Is it a good test to measure capacity?
Rajesh, we had the bladder diary. This patient was shown initially bladder diary. Go back and see there what is the function. And even CT urography will also tell you how is the bladder volume. You don't have to do another more test. You can see it here. What is the functional capacity?
yes, sir. It's around 250 ml, sir. Maximum wording
How much?
250 ml.
250 ml. So 250 is it a
Yes,
good
sir.
capacity or bad capacity?
Okay capacity, sir. Not
So
good, not
250 is
bad.
not at all bad.
The patient is voiding, if you see, sir, patient is voiding at less than 100 ml every time.
That is input.
The
Actually,
Less than 150, sir, we consider as a low volume, sir.
Yeah, he is telling the input 250. That is maximum.
Actually, you can't see the figures are very small. You can't really make out.
Yeah, output
problem is the input, sir.
Output is, sir,
How much is the maximum capacity? Can the
Yes, sir. 150 ml is the maximum
yes.
capacity of
So
the
it is a 150 ml, sir, maximum capacity.
all right. So what will you do now? Okay. So you have done this. Now what next you want to do?
Sir, since left renal function is only 11%, sir, so I'll counsel the patient for undergoing left side nephrectomy. But before that, we should start
now
ATT.
at this stage.
No, sir. First, we'll start ATT, sir,
So
and
tell
after
that
4
now,
to 6 weeks
when
of
we are
ATT,
asking you, so don't jump to nephrectomy. First, we want to know that you want to start AKT. Okay, you already done liver function. What reassessment you want to do? Which way you will call for follow up, and what things you want to see on the follow up, or you want to straight away start AKT and next day you take up for nephrectomy.
sir, after starting ATT, any destructive procedure we should plan after 4 to 6 weeks, sir. So meanwhile, in those 4 to 6 weeks, we should assess the renal function and liver function, because the ethambutol affects the main excretion is by kidney and other drugs by the liver. So we should
So all
seriously
those are
evaluate
normal. All those things are normal. Come to
We can ask for a IVP, sir.
what
We can for
urological
a
thing you want to follow.
We can ask for a
Yes, sir.
IVP after 2 to 4 weeks, sir.
You want
So
to
is it 2 weeks or 4 weeks?
So
4
two,
weeks, sir.
mostly sir 2 4.
And
2 weeks only.
what is your concern?
CT IVP you want to do at 2 weeks.
No. He says he wants to do IVP, but why does he want?
Why you
And
want
why
to do
4
IVP?
weeks?
Why you want to do IVP? I think that's the correct question. Who answered? Chirag, you answered that?
Yes, sir. Yes, sir.
So
Sir,
answer him why you want to do IVP at 2 weeks.
So post IVP after 4 weeks, at least I want to see whether the left side, the kidney, whether the excretion is good or not, and whether the
On the
patient
left
is.
side, already it is
So
a
from
compromise.
11%, you think that IVP will pick up the function.
So you should be
Isotope renogram is showing 11%. You think that Conventional IVP will give the
I think the candidate should know that doing 2 weeks is not important. Probably 4 to 6 weeks you should do it, because it takes time if it is normal and you are worried about the right side. And then this is a special IVP. You don't have to take the full films. You have to take just 130 give contrast and 30 minutes film, or and one more. That will give enough idea. Or you can do even a monitor with the ultrasound. If any dilatation appearing, then probably you might be worried. If no dilatation is appearing in ultrasound, you don't have to worry.
Yes, I think Chirag, you
Yes,
said
sir.
that you want to do IVP to see whether there is any improvement of the function.
On the right side, we are worried about right side, not left side.
Are you worried about right side or you are worried about left side?
Sir, I'm worried for the right side, sir. Sorry, right side.
Right side. Right side you are worried. Why you are worried
Yes,
about
sir.
right side? Why you think that right side will deteriorate?
So post ATT, there are chances of fibrosis, sir, and
Where?
also, sir, in the ureter.
So you think that there is a right side ureter which is affected and which is going to get stenosis?
Yes, sir. There is a lot of scarring and fibrosis that occurs post starting of ATT, sir.
No,
I don't think so. Now, Anish, do you agree with that? If IVP, CT IVP shows no hydronephrosis, ureter is completely normal, no thickening and nothing, then are you expecting the ureteric stricture in this case? Anish can throw some
it
light.
suggests some kind of ureteric disease. And with the other kidney already compromised, I think we should be on the guard for the right kidney. So the options could be either you put a stent, but that becomes invasive. So as we were discussing, as Dr. Anand suggested, keep an eye and do an ultrasound. And I think 6 weeks will be little late. So because the fibrosis can start actually after 2 weeks or 3 weeks also. So if there is some stricture which is there, which is not apparent right now, and then with ATT the fibrosis occurs, we should do it. I mean, little more quickly. Should not wait up to 6 weeks. But that is, I mean, the important point is that he should monitor for the right side.
I think what Dr. Anish has said, that if you want to follow up the right side, now left side, you know that this kidney is only 11% as good as non-functioning. Then the follow-up of the right side instead of conventional IVP can also be by the ultrasonography, which will pick up any hydronephrosis if you are going to do very serially. And in the solitary kidney, you also have to do a creatinine, which is going to give you some information. So combination of ultrasound and creatinine will give you adequate idea about the follow-up. So you can understand that this is what is the idea of following up. What is you want to follow up in the
ml before starting ATT, and ATT will cause more and more of fibrosis. So we'll see in the follow-up whether that capacity has been reduced or the same. That want to see.
So you want to see how is the frequency, whether frequency has increased, deteriorated, or it has improved. What do you think? Will it be improving or it will be deteriorating?
Most deteriorating, sir.
Not necessarily.
Will all frequency will deteriorate all the time? Which cases it will deteriorate and which cases it will improve?
If the bladder capacity is already compromised or it is a contracted bladder before starting ATD, it can deteriorate, sir. But if the capacity of the bladder is seen by in this case, it is normal. I don't think the frequency will deteriorate.
You cannot predict. You just follow the patient with the bladder
Symptoms.
and you will come to know whether the patient is improving or deteriorating.
See, it cannot be predicted like this. If the inflammation is restricted or tuberculous infection is restricted to the mucosa and it has not gone deep into the muscle and it has not severely infected, then with AKT just mucosal cystitis can actually improve and the muscle will not undergo much fibrosis. But if the muscle also is infected extensively by tuberculosis, then obviously it is going to replace with fibrosis, and that is how the capacity will go down. Okay. What else you want to see on follow-up?
Whether the patient is compliant on treatment, whether any complication happening, whether patient is responding to medical treatment.
No, first thing is that whether this fever is subsided or not, what is the general
symptoms.
condition, patient presented with loss of appetite, loss of weight, whether all that is improved or not. This will give you idea whether AKT is acting or not. If this is not happening and you have started AKT, the patient's condition is deteriorating, frequency is still there, fever is not going away. So what will you suspect?
Drug resistance of TB.
So all these things you have to check. You see, symptoms are improving. Because of fibrosis, there may be some deterioration. But if AKT is acting, this is the thing which you have to see in follow-up, whether it is acting or not. All right. Anand Kumar, you want to ask anything?
Yeah, one more thing you should always, once you start, maybe around 3 weeks time, you should get a liver function test also done to make sure that there is no drug-induced hepatotoxicity.
Very true, very true, very true. Okay, okay. So suppose patient has improved, this patient, you have put on AKT, patient has remarkably improved. The frequency is now reduced, he can hold now 250 cc. From 150 it has gone to 250. Creatinine is normal, there is no hydronephrosis on the right side. Now 6 weeks are over and she is extremely happy with you. No symptoms at all. She has gain the weight by 3 kg in 6 weeks of time. So what next you want?
Left side.
You want to do nephrectomy. Why you want to do nephrectomy?
Since the left side is a non-functioning kidney, it is a source of infections or bacillus on the left side. And since it is non-functioning, it is better to take out the kidneys on the left side.
So why you think that this AKT will not act on that left side kidney and it will take care of the remove the source of infection?
So ATT mostly functions on the rapidly multiplying bacteria and slowly multiplying bacteria. But in kidney, many dormant bacteria are also there, bacilli are also there. ATT doesn't work on them. So later on, if patient will go in some immunocompromised state, patient again will develop the symptom of TB or the kidney will affect and that can come in form of miliary TB. So better to remove that kidney and source of bacilli, dormant bacilli.
Okay.
Yeah, that way, one way you are right. There is a very good study from South Africa which has shown that even after 9 months of ATT, when the kidney was removed, around 36% of the kidney have evidence of active bacteria in the resected specimen. So that is the one of the strong indication of removal the non-functioning kidney.
All right. So Dr. Chawla, are we over?
Yeah, 3 minutes left, sir. Sorry. 3 minutes. You can conclude.
So Dr. Anand Kumar, you want to just summarize and tell them what things can be asked in exam?
Yeah, that case is a very good and it is like it might get was very suggestive of low nucleic symptoms with low grade fever. So in a young female, these two symptoms are there. Tuberculosis becomes one of the commonest possibilities. And then urine examination, trial pyuria is the biggest clue. And then luckily you have the positive thing. Sometimes even all the tests are negative. Even in a trial pyuria is there. Then you have to have that symptomatology and the sterile pyuria as well as radiological finding to make the diagnosis close, even if you have been able to isolate it. Together to make a diagnosis. Now another important thing is we know that left side kidney is gone, so it is very important to preserve the right side kidney. So right side kidney you have to keep an eye to make sure that it is not deteriorating and it is okay. So you have to three things you have to see.
Yeah, Dr. Anish.
Symptomatology, patient is improving, right side is affected or not affected, and that patient is symptomatology like his bladder symptoms has improved or not. They may even deteriorate and then you might have to do something. So these are the three things you have to watch and make sure that compliance is there, drug regime is there. You should know what drug regime patient should extrapulmonary organ involvement like tuberculosis, how many times, how much duration you give 4 drugs, how much duration you give 2 drugs, and when you will stop all this of the most commonly used, and you should also know that some of the times the patients are resistant to these tubercular drugs. So in that event, what vaccine you might have to give. So this much information you should have while discussing such cases.
Correct.
I
I think
just
that
want to
covers
add,
most of the aspects of what can be asked in exam.
So I just want to add two more comments.
Yes.
One is sometimes in early cases, because this was a very classical case, but sometimes in OPD you might get early cases where you are not very sure about the diagnosis, the urine becomes negative, and the culture report also sometimes may come negative, not because of the problem with the culture technique itself, but because this is a paucibacillary condition. So sometimes the sample which you collect, it may have very little bacteria, right? So therefore, the patient in early stages may be having tuberculosis, but because the Zil Nelson is negative, because the culture is negative, so you are in a fix. And that is where the students should know about the role of the newer techniques, the NAT-based techniques, the Jane expert, which is now also allowed in the urine, and the other tests. So that is one. And two, about the cystoscopy and cystoscopic biopsies. So actually it was done in this case. Even if you take biopsies sometimes, even from the red patches and all in this, the yield is very, very low. In this case, they have shown that bladder tissue was positive, but that is a rare occasion. So students should remember that cystoscopy and biopsy in a case like this is not required. And that's why we examiners also did not discuss about this.
I think when this TB-PCR is positive, the other modalities of gene expert and TB-PCR, they are all now very sensitive method, very specific methods, and all these things you must know. Okay, so we go ahead with the next three short cases, isn't it?
Yeah.
Sir,
Thank you.
can I
Thank
ask
you,
a question?
Chirag, Brajesh, and Puni. Navneet, can you invite the other three candidates?
So this short case is for 20 minutes each, right?
Yeah. Yes, sir. Over to presenter and over to the candidates can introduce themselves.
Hello, sir.
Hello. Yeah.
Hello.
Candidates name.
Are the candidates?
Good afternoon, sir.
Yeah.
Yes, Dr. Chirag Shah, sir, from BT Samani Kidney Hospital, Rajkot.
Chirag, who else?
Hello, sir. Good afternoon, sir. I am Dr.
Name?
Divan Banerjee from Aranteco, Kolkata.
Dr. Banerjee. And who is the third person? Dr. Deepak. Deepak is the third person, right?
Yeah.
Online, Dr. Deepak.
Okay, so we have Chirag, we have Banerjee, and we have Deepak, right? Okay, go ahead.
Yes.
So let's
over to
start with the
presenter
short
and over
case.
to examiner.
Short case, we have very less time. So let's finish the history examination, come straight away to diagnosis, and then we'll discuss.
Okay, sir.
Here to the left.
Here is a 80-year-old female child brought to the hospital by parents complaining of recurrent episodes of fever and dysuria since 1.5 years. 5 episodes since past 18 months, fever, dysuria with bilateral loin pain and suprapubic pain. Every episode lasting for about 5 to 6 days, relieved with medication by local pediatrician. Last episode 6 months ago. No history of other LERS, no history of hematuria, no history of constipation, no history of loss of appetite or loss of weight. Antenatal, perinatal history uneventful, no history of feeding difficulties, failure to thrive, immunized till date, no history of developmental milestone abnormalities. Past history, patient is a hypothyroid and treatments in 6 months. Family history, both the parents are hypothyroid. An examination, nothing specific, well-nourished child. Per abdomen soft, non-tender, no palpable lump. Back and spine are normal, no palpable bladder, external genitalium normal. Focused neurological examination is normal.
All right. Okay, so Dr. Banerjee, this is a 8-year-old girl with recurrent episodes of fever. So what comes comes in your what appetite?
So there's a chance of
So differential diagnosis straight away. What is your DD in mind?
So vesicoatric reflux, first differential diagnosis.
Okay, what else?
So it can maybe a case of bilateral duplication system with
Bilateral duplication is what? What do you mean by duplication? See, when you are asked about the DD, examination finding is nothing. The only finding is that there is an 8-year-old girl with recurrent episodes of UTI. So you have to enumerate all the causes of recurrent UTI in a 8-year-old girl. One is VUR. What else? There are so many causes. There are innumerable causes. There is no flank pain. There is no other positive history.
So ureterocele.
So tell everything, whatever comes in your mind.
Rather than you should very smartly say that, so there we will be looking for by imaging any urological congenital or anomalies which may be responsible for recurrent UTI, because there is a complicated UTI, number of times it has happened, and there could be anything. But these are that way you can say that simple answer.
So in a into details, we want to know what is your thinking. So if you say only VUR and stop at that point, that means you are stuck. We know that that means you are not thinking much. So as Dr. Anandkumar sir said, that every cause will come, whether it is obstruction, whether it is ureterocele, whether it is a PUJ, whether it is a stone, whether it is any congenital anomaly, ectopic ureter, everything is going to come in. So you have to just, this is the opportunity for you to impress the examiner. So keep on telling things so that they know, okay, stop. So then they will go ahead with the further question and answers. Okay. So in this case, everything will come as a differential diagnosis, starting from the congenital anomalies, obstructive anomalies, developmental anomalies, duplex system, ectopic ureter, reflux, stone, everything will come in. Okay. PUJ will come in, everything will come. Obstructive megaureter will come. So now tell us that how will you proceed? Let me ask Chirag.
Yes, sir. Sir,
Chirag, you have heard the differential diagnosis. How will you proceed? How you want to go ahead?
Sir, I would like to investigate the patient. I would like to do urine routine and microscopic examination, urine culture.
Keep showing whatever he asks. Keep showing. Yeah, urine routine microscopic is this.
Normal.
Yes, sir. Urine culture.
The urine exam is not showing any pus, will you ask for culture? There is no need for that. Okay, you can move on.
Yes, sir.
Okay.
Yes, sir. I would like a complete blood count.
Ten grams.
10 grams.
Total count is normal, creatinine is 0.5. So what next you want to do?
Sir, I want ultrasound of abdomen and pelvis.
Ultrasound. Show ultrasound.
Image not available, sir. Ultrasound. Both the kidneys are normal in size with grade 3 renal parenchymal changes, loss of cardiopulmonary differentiation, no evidence of calculus, hydronephrosis or focal lesion. Right kidney is 7.2 into 2.5 centimeters. Left kidney is 7.2 into 2.6 centimeters.
Okay. So impression is what? Mild hydronephrosis.
No, sir. Grade renal parenchymal changes.
Parenchymal changes.
Okay. So what next you want to do?
Yes, sir. I would like to get micturating cystourethrogram.
Want to have MCU?
Yes.
Okay. MCU. All right. So this is MCU. . So what do you think in the
Sir,
MCU?
reading the MCU, the visible bony landmarks appear to be normal. The bladder appears to be normal with smooth outline. There appear to be bilateral grade 4 vesico-ureteric reflux. The bladder neck appears to open normally. And I would like a post-wide film as well.
This is the post-wide. You got the post-wide also.
Yes, there is no post-wide residue. Sir.
Okay. So
sir,
so what? So what is your impression? What next you want to do?
My diagnosis is bilateral grade 4 vesico-ureteric reflux.
Yes.
I would like to get DMSS scan. Sir.
You want to get the DMSS scan. Okay.
Yes.
Why you want to go get this DMSS done?
Sir, I want to see the differential renal function on both the sides. I want which will help me for the further follow-up, sir.
All right. Okay. DMSS. Show the DMSS.
No, you missed that. When you ask for DMSS scan, apart from the differential function, you look for
yes, sir. I want to see the renal
parenchymal scarring.
DMSS. Show the report.
You could see there are the scarrings.
I'm not actually able to see it.
No, go to the report.
Left kidney normal in size, normal shape, position, shows mildly impaired cortical radiotracer excretion with multiple cortical breaks. Right kidney small in size, shape and position, shows impaired cortical radiotracer excretion with cortical breaks in the lower pole. Differential function left kidney 65%, right kidney 35%. Impression left kidney impaired functioning kidney with multiple cortical scars, right kidney impaired functioning kidney with lower zone cortical scar.
Okay.
What next?
What next you want to do?
Sir, with this, sir, I would explain the parents that the child is having a bilateral primary.
Wait a minute. One more investigation, very important investigation is missing, which has a very severe prognostic indication. All these patients, when they have vascular-ureteric reflux, now you know that they have scar. You know that
Yes,
even if creatinine is 0.5, you must get urinary microalbumin tested. That is
Yes,
a very good, that will tell about the development of any reflex nephropathy, which has a very good problem. So always ask for urinary microalbumin or even 24-hour urinary albumin report.
Right,
so that's very important.
Yes.
Okay. So what next?
Sir, with this, I would explain the parents that the child is having a bilateral primary high-grade vesico-ureteric reflux. The renal function has already been compromised on both the sides, sir. And there is a significant renal parenchymal changes, sir. I would explain that the child will require bilateral ureteric reimplantation.
So you want to do bilateral reimplantation. Deepak, you agree with him?
Yes, sir.
So your answer also is same, that this child will go ahead with the bilateral reimplant?
Yes, sir.
Now, I won't agree with your answer. Why?
What is the reason of bilateral reimplantation at this stage?
And I don't agree with your answers. Why?
Sir, I would do it because the child has bilateral high-grade reflux. Child is already more than 5 years of age, so we are not expecting a spontaneous spontaneous resolvement of the reflux anymore. And the child is already having a renal damage bilaterally, so we should have a lower tolerance to the further damage. So I would offer
The question why he is asking is that what is the purpose of doing surgery in this case?
No.
Until you know what is the purpose, what you are going to achieve.
Okay, my dear.
Justify the surgery.
Just
to prevent the prevent further renal damage.
Okay. Now the question is why I asked this question is two things. By giving answer to this vasculatory reflex, you at no stage have mentioned whether patient had long-term chemoprophylaxis with antibiotic and whether medical treatment was a failure. And in spite of medical treatment, this patient had episode or not, that was never discussed. Second thing, you said that it may prevent the renal failure. Yes, it may prevent the pyelonephritic episodes, upper tract infection episode, but it cannot prevent the progression of the renal failure. That's why urinary microalbumin and DMSA scar study is important. And anti-reflux surgery will not prevent renal deterioration if it has started. It may prevent the recurrent pyelonephritis.
Yes, sir.
These things you should be sure about it.
So unless you know what is the purpose of surgery, purpose of treatment in this case is to prevent the recurrent episodes of UTI. And when there is a history that there is no other previous medication which is done, then your answer should have been that first you will like to treat with the chemoprophylaxis. This is a grade 5 free reflux. It is completely empty. There is no post-void residue. There is no constipation. There is no suggestive of there is a dysfunctional voiding. There is no incontinence. There is no nocturnal enuresis. And so in this case, unless and until there is a failure of chemoprophylaxis, one should never jump for surgery. Chemoprophylaxis is there. Okay. So this patient definitely will go for the chemoprophylaxis.
So Chirag, can I ask you one question? What is the River study?
Sorry, sir.
What is the River study? RIVUR.
Sir, River study. It is a study that randomizes the patient with high-grade reflux to chemoprophylaxis versus placebo. It has shown that the chemoprophylaxis will reduce the chances of urinary tract infection, but it will not change the long-term renal function. Sir.
Yeah, and then it was
does
actually
not reduce the renal scarring, sir.
But these findings were controversial when they went back and saw. Then they found that most of the cases reported were actually low-grade reflux, and high-grade reflux of grade 4 and all were less. And they also found that there were other couple of controversial things coming. So Wang did further analysis, and some more have come up with this concept. So I think in this case, as all of us agree, the chemoprophylaxis should be given. But the question will come for how long. And in our scenario, you know, when the patients are like coming from suburbs, they are not so literate. So should we still think of doing?
Yeah. Already the child is more than 5 years of age. She is
and
8 years.
Yeah, she is more than 5 years of age.
Are we expecting a remodeling anymore?
Yeah, spontaneous resolution is very less likely. So you should know both the points. Both.
So you have to. That's why, unless until you justify your surgery, justify your things, it will not be acceptable. If you just say that I want to do surgery and then do not give a proper reason. The question is that suppose if you do, we want to ask you that suppose you have started chemoprophylaxis. Okay.
Yes.
So patient child has completely improved, no urinary tract infection. You have given chemoprophylaxis for say for 1 year, 2 years. Okay. Completely asymptomatic. She is taking the chemoprophylactic. Now the question comes that what is your further plan of action? Now that is where I want to ask Dr. Banerjee.
Yes,
that
sir.
this child is kept on chemoprophylaxis. 2 years are over. No episodes of UTI. What will you do? Will you stop? Will you continue? How long you will continue? What is your plan of action? Now the child is 10 years.
So if there is no breakthrough UTI and the patient is having is symptom free, we'll stop the chemoprophylaxis after 3 months of continuous chemoprophylaxis, and we'll do VCUG 1 year later to check whether there is any reflux, and if there is no persistent reflux, we'll continue with the observation.
No, not that way. What we want to know from you is that in a scenario like this, what is your long-term perspective? The child has improved with chemoprophylaxis, no breakthrough infection. Now child is 10 years old. Now, what is there in your mind as to what things you want to check?
So we want to check the renal scar formation. We want to check the
Scars are already there, no? Scars are already there. Why you
whether
expect
the
that there will be more scars?
whether there is any the renal growth and also the somatic growth of the child. These are the things we have to see.
Hmm.
And we have to check whether the patient is having prolonged symptom-free periods of infection. No breakthrough
We
infections.
see now coming back to this, let us not unnecessarily waste time because we don't have much time. What will you do? Will you stop chemoprophylaxis? After stopping, what things you will see, and what action is there in the what plan of action is there in your mind, and what is the justification for that plan of action? Yes, quickly, because now we have to stop this discussion.
Can I answer, sir?
Yes, please go ahead.
Sir, after stopping the chemoprophylaxis, we'll keep the patient on the regular follow-up to see whether the patient is having recurrent urinary tract, not having any urinary tract infection as the child is a female patient. We can there is always a concern about the complication during the further pregnancy. So the first thing after at the time of stopping the chemoprophylaxis will be to do a repeat VCUG to see whether the reflux is still there or not. If the reflux is still there, sir, we can offer the patient a reimplantation at the time of puberty, sir, when she might be expecting a pregnancy in the near future.
Yeah, Anish, you want to summarize and then we stop?
Yeah, yeah, exactly. I think he has given a reasonable answer. So let me summarize. So VUR is one of the very common cases which is kept in the examination. From the pediatric group, only PUVs, VURs, and maybe one or two other cases. Sometimes they put hypospadias. So the student should be very well versed with them, and you should also know according to the age. When you prepare about this, then infant 1 to 3 years, up to 5, and beyond 5. Now, in this girl who is 8 years old, we talked about the differential diagnosis, and it was very rightly mentioned with this history and all. As we already emphasized that you should tell the differential diagnosis in the order of priority. So we are come as a differential, and then you should mention other causes like the affected hydronephrosis, retrocele, so on and so forth. Then the other thing is MCU. If you go for the next, do an ultrasound first, because you still do not know whether you are dealing with a PUJ obstruction. So a quick ultrasound will give you an idea that there is no other thing. Other differential diagnosis is out. So now VUR is very strong possibility, and you go for MCU as was done in this case. Following MCU, when you have got the grade reflux and your diagnosis, then DMSA and looking for the urinary protein, as Dr. Anand said, is very important. And then you can decide, like we discussed, between the continuous antibiotic prophylaxis versus surgery. So the candidate should be clear about both the parts. If you say CAP or if you say surgery, we will not cut your points as long as you can justify, and we like to see that you know what all things are there. And you should also be aware about some more studies like Swedish reflux study and all, because some of the examiners are fond of asking. And then finally, you should also know the surgical technique. Of time, we could not discuss between the open surgery, and you should be all well versed with the steps of the reimplantation, because those are the things. Time was less. Otherwise, if we were given another 10 minutes, we would have definitely grilled you. But you should go back and read endoscopic thing, now robotic. So what are the results? So those are the things I think you should know. Okay,
Yeah,
so
I
we
think
go
let's go
for
ahead
the
with the next case. Start the next case. Are we going to change the candidates?
Good evening.
Arun.
Who are the next candidates?
Good evening, sir. My name is Dr. Dhaval Desai. I am from Delhi.
Okay.
Good evening, sir.
Who else?
Prateek Dhaval and the third one.
Okay.
Good evening, sir. Myself, Dr.
Okay,
Dipendra, sir.
okay.
Dipendra, Dhaval, and Prateek.
Yeah.
Yes, sir.
So we are ready with the next case, and before starting this case, let me thank Navneet. He has volunteered not to take any break in between, and he's continuing like a well-oiled machine. Over to presenter and over to examiners.
Yeah. So go ahead with the case.
This is a 40-year-old female, sir.
Yeah, go ahead. Go ahead.
Patient came with chief complaint of continuous urinary leaks since 3 months. There is no issue of any normal voiding episodes in between the leak. Patient is changing 6 to 7 pads per day. The present complaint started off a transabdominal ischemia, which was done 3 months back for dysfunctional uterine bleeding. Urine leak started on POD2 after Foley catheter removal. Patient is decatheterized, but leak persists catheter in situ. Hence, catheter was removed after 20 days. Histopathology report was suggested of a chronic non-specific cervicitis with squamous metaplasia. There is no history of fever, dysuria, no history of loin pain. Bowel habits are normal. She is a married female for 15 years, 2 children, full-term normal vaginal deliveries, nil comorbid. And coming to the examination, per abdomen surgical site was healthy. Per speculum, per vaginal examination, pooling of urine in vagina seen. Is adequate. No anything appreciated over the anterovaginal wall near to the what, and urine duration is felt.
Okay. All right. So, Dr. Dhaval, do you want to know anything more in the history and examination?
Sir,
Any particular point you want to know? Go back to the first page of history. Yeah.
Sir, is there
3 months are over.
3
There is a
months.
continuous leakage.
Yes, sir.
And leakage was there in spite of catheter. Quick. Do you want to know?
No, sir. No other point, sir. There is a normal. There is no history of normal voiding also present, sir. So it must be a very large fistula, sir. According to
So, what do you mean by no normal voiding? Have they given that there is no normal voiding?
sir, no history of normal voiding episodes in between the leaks.
Okay. So, suppose there was a normal voiding, then what you would have thought of?
Sir, it may be a ureterovaginal fistula. Can be there. Yes, there is a history of transabdominal hysterectomy.
Okay, so just tell the causes or
Sir, there can be a small supratrigeminal fistula or can be a uterovaginal fistula.
ureterovaginal fistula. What else you said?
Very small fistula, supratrigeminal.
Small fistula. Okay, small fistula and ureteric fistula, you can have normal voiding pattern. All right. So what do you want to do now?
Sir,
There is a induration and leakage induration felt in the near the wall.
So now I would like to do one cystoscopy examination.
Straight away do cystoscopy. Why you want to do straight away, Dr. Pratik? You agree that the next step is just to do cystoscopy?
Sir, we can MCU also, sir.
You want to do MCU?
After doing culture.
You want to do culture? Now, all these things are not correct.
Sir, excuse me, sir.
Yes.
Sir, we can go for a dye test, sir.
Dye test.
Yes, sir.
Dye test. How do you do that?
Sir, by intravaginal installation of any vital dye, and then
Why you want to do all this dye test and all?
Why do you want to do the test when already you have seen in a speculum examination there is a pooling of...
Now tell me, in your residency, have you done this dye test?
No, sir.
then why are you telling? See, this is the problem of the candidates. If anything which is not done in your residency, if you are not seen, why are you asking? That means it is not required. That your training, whatever you have done, the practical examination to assess what have you done. Now,
Okay.
the things which you have not done, it is unlikely that this is going to be right. So if you are not done in 3 years' time, and then why are you telling that now you want to do suddenly diet test? Because all your subsequent answers are not going to be correct. So when you get the case like this, where there is a suspected VVF, simple question is that what next you want to do? What is there in your mind? Cystoscopy is certainly not the immediate step which you want to do. There are many other things which you have to do. Certainly not the urine culture, what you have said, and certainly not the MC,
We'll
what
go
you have
for
said.
USG KUB.
Okay, why you want to do USG KUB?
Sir, we can check the upper tract dilatation so that if that is a suspicion of upper tract dilatation, associated UVF can be there, sir.
Okay, so there could be hydronephrosis because of the associated ureterovaginal fistula.
Yes, sir. Yes, sir.
All right, so okay, that is a correct
And
answer.
I want to see for any urinome also, say in the ultrasound cable. If any urinome is
So ultrasound, you want to see hydronephrosis, you want to see if there is any collection, if you want to see anything. Remember now it is a 3-month-old case of hysterectomy. Okay, so do we have ultrasound?
Yes, sir. The right kidney is normal size and echo texture, sir. PCS is compact. Left kidney normal size and echo texture. Mild hydroureteronephrosis is noted. There are no internal echoes for caliculi. Bladder was empty at the time of scan.
Okay, so this is what is the thing. Now what next you want to do?
So we will like to get.
Sir, I want to get a CT IVP, sir.
Yeah, so you see, you must go in a proper manner. CBC, then creatinine, all these things should come. It is not assumed in the exam. Okay, here we assume it is all right. But in exam, all these small things also matter. Okay, so creatinine is okay.
Yes,
so
sir. CBC.
CT IVP is there.
Yes, sir. CT IVP is there, sir.
Any other pictures? Any other pictures?
Sorry, sir. These are the available pictures.
Sir, in CT, sir, the left side ureter is dilated till the lower end.
Where have you seen dilatation?
Sir, in this coronal,
where is the dilatation? This is the contrast in the vagina.
Yes, sir. That is there, sir.
Anyway, show the report. Show the report.
Yes, sir. So the report says moderate left hydroureteronephrosis with distal portion of left ureter and left vesico-ureteric junction showing no contrast opacification on delayed images. Contrast within the vaginal vault with suspicious contrast-filled tract communicating with the distal ureter just proximal to vesico-ureteric junction, suggestive of a ureterovesical fistula, and the fistulous tract communicating to the posterior wall of the bladder and the vaginal vault.
Okay. So what does it suggest? That there is a possibility of ureterovaginal fistula with the VVF. What other things which you noted on the CT scan pictures which they have shown? Go back to CT plate.
Sir, there are dense fiber. In left side image, there is very dense fibrosis in the left side of the CT, sir.
What is more important is that the bladder. So what does it suggest?
So it's
a small vaginal fistula.
Fistula site is not large, sir.
Small.
Yeah.
Small
so if you put a catheter, if you block the catheter, and if the bladder is filled up like this, that means that VVF which is there is not going to be a very big fistula. So that information which you already have got. Plus there is a ureterovaginal fistula. Okay, what next you want to do now?
If the bladder is filling up, then it is usually higher up.
Okay, sir.
So what next you want to do?
So we would like to do a cystoscopy left side.
So at this juncture it is all right. So why you want to do scopy in this case? Your diagnosis is already made. CT scan has shown that there is a small fistula between the bladder and this, and there is a ureterovaginal fistula. So why you want to do scopy?
I want to do see the site of the fistula by doing RGB concomitant with the cystoscopy. If it is very high up or lower down the fistula.
No, RGP, what you want to do? RGP for what purpose?
Sir, to delineate the level of the fistula site, sir.
Okay, you want to do RGP to see at what level the ureter is having the fistula. Okay.
Yes,
Any other reason for doing cystoscopy?
Cystoscopy, we need to see where the exact site of the fistula is, the site location of the fistula. In this, we cannot make out exactly where the location and site of the fistula is, and the relation of the fistula with the ureteric colic. To know and we need to know the site of the fistula, how much distance from the bladder is.
All right. Okay. So that is acceptable. That you want to see the overall morphology of the bladder, see how if there is any other scarring present or not, where is the location, what is the size, whether it is oblique, whether it is straight, and of course to do RGP so that you want to see the whole thing. Okay.
So one thing more, sir. In RGP, we can also see the continuity of the ureter, sir, ureteric segment, so that at the same time we can stenting can be done, sir. If there is
not now, after 3 months it will be not.
So is it possible to do that at 3 months of
No,
this?
It's immediate, sir.
Yeah. So when it comes in acute stage, yes, you have to do all the efforts to make sure that it is done. But now it is an established fistula.
Okay, sir.
Basically, now it is an established fistula, and you want to treat that. So have you done cystoscopy?
Yes, sir. Cystoscopy, bladder has good capacity bladder occurring seen in the left posterolateral bladder wall. Fistulous opening is 1.5 centimeters, seen 2 centimeters above the medial to left ureteric orifice. And left BU, left ureteric orifice is narrow, deviated supramedially, and left BU showing complete cutoff in the distal ureter around 2 centimeters from BUJ, and guidewire could not be negotiated beyond the point. And these are the images.
Okay. So what next you want to do? Dr. Dhawal.
Sir, I will like to prepare the patient for the surgery. VVF repair along with need of ureteric implant because of ureterovaginal fistula, sir.
Okay. So what sort of surgery you will do?
Sir, modified O'Connell surgery can be done, sir, in these cases, sir.
What are the principles of doing surgery in a case of VVF plus UVF?
Sir,
whatever surgery you want to do, just tell the principles of doing surgery.
Sir, the closure, VVF closure should be, sir, multi-layered, watertight, tension-free, and should be an intervening layer to decrease the chance of recurrence. And the ureteric implant should be at the dome of the bladder.
Right. So anything else you want to add, Dr. Dipendra? You want to add anything? Whatever he has said.
Yes, sir. It's correct, sir. We should careful dissection and anatomical dissection should be there.
Don't repeat the things. Whatever he has said, it is acceptable. Anything more you want to add?
Sir, patient, we need to prepare the patient for adequate nutrition and eliminate infection. And then we need to plan for any interlying facial flaps also. We need to plan after closing the fistula sac in 2 layers, perpendicular to 2 layers.
Right. The preparation is okay. Okay, so I want to ask a question that will you take up once you do cystoscopy? Still want, in which cases you want to wait, and how do you decide that okay, now patient is ready for surgery? The patient has come at the end of 1 month. The patient has come. So is it only the time which decides when you want to do a final surgery, or what are the other things?
Sir, the findings of the cystoscopy, like if the mucosa is healthy or not healthy, sir, at the time of cystoscopy decides the timing of the.
Okay, cystoscopy, you want to see the mucosa which is healthy. Anything else? Any other thing?
If the infection or the collection in the CT, if there is CT scan, there is a collection, then we need to wait for the collection to resolve, because if with
anything else,
then the chances of recurrence are
anything else more important? When you do vaginal examination, you also have to see whether the whether there is any induration and is present or not. Quite often in the early stage, when the inflammation and induration is not subsided, that is not the correct timing for doing the repair of vaginal fistula. The area has to become supple. And over a period of time, the area will become supple, and that's the time when you want to do final surgery. If you do early, when there is a indurated and still it is not completely resolved, then there are chances that whatever sutures you will take, there is a possibility that sutures may give up. There can be a method that there is a adequate dissection of the both vaginal bladder part and the vaginal part. Apart from that is that tension-free suturing, adequate mobilization. That is the most important thing. Principle is that adequate mobilization. If you just do suturing just like that without much mobilization, that's not the principle of surgery. What are the tissues which are available when you do O'Connor's repair for the bridging the gap in between?
So we have some peritoneal flap, sir.
Which one you will prefer and why?
So omental flap we will prefer, sir.
Momentum flap.
Yes, sir. Because of its good vascularity, and it's also have lymphatic and it's very good epithelialization in this, and it can be taken up to the deep into the pelvis.
Okay, so omental flap. What else?
Peritoneal flap we can also use. Rectus abdominis flap we can also use.
What do you mean by peritoneal flap?
So the parietal peritoneum which is available at the abdominal wall, that can be mobilized and can be taken down to the pelvis.
So will you keep the omentum in continuity, or you will just cut the omentum and put it as a separate thing?
It's in continuity.
Why you want to put in continuity?
Because the vascularity will be preserved.
Suppose if you put it just like that, will it help or not help?
So it will not help.
Why it will not help?
So because vascularity has been detached from the omentum. That's
okay.
Why.
So the principle is that you must have some vascularized flap interposition. Yeah. So if you are doing abdominal surgery, you have all these flaps. If you are doing vaginal, there are different flaps which are vascularized and which can be interposed. Okay. So what are the other methods of doing the same surgery?
So laparoscopic, robotic, then vaginal, sir.
Can you do this case vaginally?
Sir, no, sir, there is concomitant ureterovaginal fistula, though, sir, ureteric implant will be not possible by vaginal. Sir.
All right. Okay. So, what are the reasons of failure of surgery? Suppose you have done VVF repair.
Yes, sir.
Enumerate the reasons of causes of failure of surgery.
So, if the patient is malnourished, if there is a not adequate time to time given to heal the inflamed tissue, if the infection is there, sir, then if the watertight closure or multi-layer closure is not done, if the closure is the layers of the closure is
intraoperative reasons. I can you have already told any other reasons.
So the
early removal of catheter, sir.
Any post-operative causes for failure?
Early removal of catheter, sir.
Early removal of catheter. What else?
Sir, any missed out foreign body might be missed out, or if any distal obstruction is not picked up.
Okay, what do you mean by missed VVF?
Yes, sir.
There might be a small VVF.
Yes, so that also we might have not. A reason for failure that you have missed one small VVF somewhere else, and that is not focused. So that also is one of the causes for failure. Infection is one of the causes for failure. If your suture line and if that gets infected, then it can cause failure. The blockage of catheter in the early post-operative period can increase the pressure in the bladder, can open up the suture line, and that can be the cause of failure. Overactivity of the bladder, recurrent spasms of the bladder can be one of the cause, because that also will cause the transient rise in the pressure, and that can cause the failure. So these are the causes of failure. Dr. Anand Kumar, you want to add anything, or else I will summarize the case?
Yeah, that's a very important thing, is that not missing the any other fistula. That could be one cause. Second thing is that adequate mobilization of the bladder and the vagina, so that when you put the sutures, then it should be tension free. Both the sutures should not be lying over each other, and interposition of the live tissue like momentum is the preferable one. And a catheter, the one thing which Dr. Sabnis was asking, you didn't reply, was that if in post-op, catheter should not get blocked. So that's why SPC and peritoneal catheter, most of the people keep it. Suppose one catheter get blocked, period, so that is the very important things, no. And when you do the put suture, they should be tension free and live tissue, like all the, if there is a scar or something, that should suture should not be going through the scar. You should take a tissue beyond that, so that you have a live tissue to take care of it.
Right. So to summarize, I think these are the things which we have covered. This will come as a short case quite often. And you must know the causes of the presentation and causes of the VVF. If you want to do surgery, at what stage you will consider for surgery? What are the reasons for early surgery? What are the reasons for delaying the surgery? Then how you should not miss the fistula, concomitant fistula. That is another important thing. As Dr. Anand Kumar pointed out, all the reasons intraoperatively which you have to take. Then you must know the various other methods of correcting VVF, laparoscopy, robotic, what are the pros and cons of each. Then if you want to do vaginal repair of VVF, what are the options, what are the positions, what are the different flaps which are available, what are the different tissues which are available for interposition from the from the vaginal route, that must be known. And of course, in the follow-up, how will you follow up this patient? What advice you will give, especially the if it is a obstetric fistula, about the intercourse, about the subsequent deliveries, about the subsequent management of delivery, how long you want to postpone the delivery, all those things will be asked in the exam. So I think this is the VVF or the UVF case like that. Okay.
So the most important thing is that, like what Sabnis, that you should know all the options. But in exam, when question is asked, you should give the answer which you are very confident in explaining, which you have seen, and which you can do it.
Yes.
Otherwise, suppose you say something you have read about it and you cannot explain and you have not seen it,
yes,
you will be in the problem.
I think that is a very, very important thing. In exam, whatever you are doing, whatever you have seen, to be told. Just because Dr. Anand Kumar is an examiner, don't tell I will do robotic surgery because he will do robotic surgery. That is not the thing. In fact, he will not be agreeing with you that robotic is the answer. If you have seen the open surgery, tell open surgery. Whatever you have seen, like for example, you said that you want to do 3 swab tests. Now, nobody does 3 swab tests. It is all given up. It was the previous era. Now you have not seen that, you have not done, and now first answer you are giving is that I want to do 3 swab tests. So that is not right. Whatever you have seen, you must tell in the exam. Okay. So Dr. Chawla, we can go ahead.
Yes, yes. Thank you, sir. Thanks, Dhawal, Dipender, and the other candidate. May I request Navneet to let the other 3 candidates in? And I can appreciate the patience of all the candidates who are still logged in. I know your hunger for knowledge is much more than the hunger of your stomach. Please bear with us, and you can understand the pageant of this is just to help you out and make your preparation sharper for your exams. Please stay logged in, and if you have something to munch, we put the video off, and you can take something to munch in to keep your brain active. Over to you, presenter Suresh.
The students are ready, sir. Shall I present, sir?
Yeah.
Navneet, are they ready? Introduce.
Yes, sir.
Yes, sir. Who are the 3 candidates?
So I'm Gaurav Bavadia, sir, from Kolkata.
Gaurav, okay. Who else?
Good afternoon, sir. I am Gaurav Sharma from Hyderabad, AINU Hyderabad.
So 2 Gauravs are there.
Yes, sir.
So I will tell 1 Gaurav and 1 Sharma.
Yes, sir.
Who else?
Gaurav and Bavadi.
And?
Who is the 3rd one? Yeah, please introduce yourself. Your video is not on. I'll try to make your video on, please. Yeah, please introduce yourself first.
Sir, I enter Gaurav Bavadia.
Gaurav, other Gaurav.
Bavadia, Gaurav Sharma.
Yes, sir.
And who's the third one?
Okay, we go ahead with 2 only. Okay, go ahead.
Okay.
So here is a 16-year-old male patient, Mr. RVT, is a farmer by occupation, resident of Telangana. He came with history of poor stream since 1 year, history of prolonged void of patient, no history of COPD and tuberculosis. Patient is a smoker, non-alcoholic, consumes mixed diet, bowel habits are normal. Patient is on anticoagulants and on hypertensive and diabetic medications. On examination, our abdomen there is nothing significant. External genitalia are normal, no PXO, no phimosis, bilateral test is normal, and distal rectal examination, sphincter tone is normal, grade 1 prostate with median sulcus felt, no nodule, no tenderness, rectum is empty.
Go back to the first history page. So he's a 69 years old male with poor flow, difficulty in passing urine. Next page. Okay, so frequency, urgency, poor stream in a 69 years old male. No previous instrumentation, nothing. Okay, so Dr. Gaurav Sharma.
Yes, sir. Looking at it, my first differential would be a benign enlargement of prostate.
Okay.
I would like to characterize lower urinary tract symptoms based on the IPSS score. And I would like to characterize that he's having a poor stream. Then how is the nature of the poor stream? Whether it is only the thinning of the stream or whether the force of the stream is decreased. Then
both
any episode of retention over last 1 year, and any medication.
No previous medication, no history of retention.
Okay. So a BPH. So that is we accept that BPH is one of the diagnoses. What else?
He can have a stricture urethra as well, sir.
Stricture urethra. Okay. What is the cause of stricture urethra? Any factor?
Sir, they have not mentioned about no history of instrumentation, but I would like to ask other history as well, whether there was any vitis discoloration in his near his glands, or whether he has any sexual transmitted infection in the past, or any urethritis episode in the past, any urethral discharge in the past.
He's not sexually active since 10 years.
Okay.
What is that?
He's not sexually active since 10 years, sir.
So nothing, no such history.
Any history of trauma? Any
trauma? All right. So BPH is one diagnosis. You have the stricture is another diagnosis. Any other diagnosis?
Sir, does he has any dysuria or any pain while passing urine?
Nothing. Apart from these symptoms, he doesn't have any other symptoms.
Can it be a bladder problem?
Pardon, sir?
Can it be a bladder problem?
Yes, sir. It can be. It can be a neurogenic bladder as well, and it can be a vesical stone. But he is not having any dysuria, so I'd like to keep vesical stone very in the surgery.
Why
And,
did you say vesical stone? He doesn't have any suprapubic pain or anything. Why should you unnecessarily say vesical stone? There is simple answers. At this 69 years, prostatic enlargement is the most common diagnosis. But any other outlet affection can give these symptoms, which could be stricture urethra, meatal stenosis, phimosis, anything might give. So that's why you should make it a very simple answer.
Okay, sir.
Okay, so how will you proceed?
I'd like to do a urine retention analysis and complete blood count and serum creatinine for this patient.
So what is it showing? Plenty of pus cells and RBCs. 13 hemoglobin, creatinine is 1.3. What else? Culture is no growth. Okay. What else?
Sir, I'd like to do an ultrasound KUB for this.
Ultrasound, KUB. Why you want to jump to ultrasound? What is the next logical step?
Sir, to confirm his obstructive lower urinary tract symptom, will have to give do a uroflowmetry. And
So uroflow is the first thing. No, once he has come 69 years old.
Excuse me, sir.
And residual
PVR is 113 ml, water volume is 401, Qmax is 4.7, average flow is 3.3.
Okay, so this is the flow.
Sir, the uroflowmetry pattern is also suggestive of a plateau type of pattern, which is more in favor of stricture disease. I like to do an ultrasound KUB and a retrograde urethrogram. This patient.
You want to do ultrasound KUB. Why you want to do ultrasound KUB?
He's having a chronic obstructive lower urinary tract symptoms since last 1 year. So I want to see the secondary changes in the bladder, like thickening, any vesicle stone, and upper tract changes as well. Whether there is any hydronephrosis. Or,
Excuse me, sir.
And post-void residue, the most.
Yeah, so he has got post-void residue. So okay, accept is there.
Yes, sir.
Hello.
Kidneys are normal, sir. This is bladder image.
Kidneys are normal and bladder is showing post-void residue. No stone, nothing. What else you want to see in the bladder? There are no divertical and no saculations which are present.
No intravesical enlargement of prostate also not seen.
Okay.
So, nothing like that.
So what next you want to do? The other Gaurav can answer. Yes. I think he has muted himself. So you go ahead.
Sir, I'd like to do a retrograde urethrogram in this
You have
patient.
missed it. He has got the post-void is 150 ml.
Dr. Chawla, you have to unmute Dr. Gaurav, the other Gaurav.
Navneet, you can unmute Dr. Gaurav.
Hello.
Okay, so now you answer. You can answer what next you want to do.
Sir, I missed the initial part. Is PSA has been done, sir? I missed it.
You want to
PSA?
do PSA?
Yes, sir.
Okay, you want to do PSA. What else?
And RGU and MCU, sir, I will go for.
RGU and MCU.
Yes, sir.
Okay. What is okay? So RGU, do we have RGU?
What was it?
So in this case, diabetic cystopathy is one of the differential.
Yeah, that the
Yeah,
same.
because it has a history of 10 years and along with BTH. And then if you look at his uroflow curve also, you cannot differentiate between the bladder
right,
problem
that they
and
said
the
the bladder is.
and then PVR is also high. So I would say that I would calibrate him with a 16 French rather than going for RGU MCU straight away because strictures are, of course, we see occasionally only. So instead of going for a more invasive investigation like RGU MCU, the more logical thing will be to just simply calibrate him with a 16 French or 14 French catheter in the clinic. If you find there is a problem, then you should go for RGU.
Okay, show the plates of RGU. Okay, so are you happy with this plate?
Yeah, keep this plate.
Yes, sir.
Go back.
Yes.
Go back. So are you happy with this plate, whatever is shown?
It might be stretched more.
What is the problem in this right side plate of the RGU?
So the stretch is not.
That is not correct answer.
Next plate. You can see the next plate.
Yeah, go to the next plate. Now, what is the difference between that and this? It cannot be a stretch with the AP view. That is not acceptable. Okay, so what do you think? What is the inference from this RGU?
There is narrowing in mid to distal bulbar urethra, and the penile urethra, the distension is the urethral margin is regular, and the lumen is good. So it most probably it is a mid to distal bulbar urethral streak.
Okay, so what next you want to do?
Sir, I also want to do a MCU, sir.
Now you want to do
MCU.
MCU. Why you want to do MCU?
I can see, sir, the proximal limit of the stricture, but just
You have all the information in this plate.
yes.
You have to justify whatever you ask for. You need to justify, because then it is, if you ask for something and if you are not able to justify, then you don't get marks. So Dr. Gaurav, the other Gaurav, what
Yes,
will you do? You want to do MCU or you are happy with it?
No, sir, I will not do MCS.
Sir, I'm happy with it.
I'm showing the.
So what is the justification for MCU? You may be right, you may be wrong, but you have to justify.
See any contrast distal to the narrowed segment, then MCU would have done MCU. But in this case, as we see, we can see that contrast is going into the bladder, and it is already, the narrowed segment is already delineated in retrograde urethral rump. So I don't think there is any need of MCU.
All right. Okay. So the answer is that whenever you have the visualization of a urethra which is proximal to the stricture, if you want to really visualize, then you have to have MCU, because you cannot visualize properly. But at the same time, when you look at the RGU, you quite often get the idea as rest of the thing are likely to be normal. But you are right that in case if you want to really delineate, then you have to have MCU. But from this plate, you can assume that proximal urethra is likely to be normal. There is a lot of contrast which is there in the proximal bulb. And membranous urethra, membranous and prostate, you are unlikely to get anything more than that. So both ways you can justify whatever answer you want to give. Okay, so what next you want to do?
Sir, shall I answer, sir? Yeah. As it is a
So assume that all rest of the urethra, proximal urethra is normal, and then what next you want to do?
Regarding the management options, as this is a primary, means no previous intervention has been done, and it is a distal mid and distal bulbar short segment stricture. I'd like to give him the option of an optical internal urethrotomy.
Okay. All right. You want other person, other doctor, you agree with him?
Sir, I will explain him about the need of self-calibration with respect to DVIU, and the chances of success rate not as good as the urethroplasty. And if he is ready to go for DVIU, we can go for DVIU. Otherwise, we will
Okay.
go for
So you want to do optical urethrotomy, and after optical urethrotomy, you want to teach the self-calibration. Okay. So so what is your philosophy that after every optical urethrotomy, would you tell patient to do self-calibration, or only in selected cases you will advise that?
It is only just the mucosal thing, possible stricture. Then we may not do. Otherwise,
this case we are discussing.
Yes, this case, sir. This case we will do, sir. I will rather counsel him more about uretroplasty, but because it seems like a longer stricture, sir. But if he still persists, because most of the patients are wants first endourological procedure. In this case, I will still want him I will.
Whether you want to tell him to do self-calibration for how long, and will you advise that in every case of stricture like this?
Yes, sir. In this long stricture, I will advise.
How long you will advise self-calibration?
Maybe, sir, 1 year, sir.
1 year.
Yes, sir.
Why 1 year?
In the difference, their interval will be decreasing, but I will advise, sir, for long.
So what is the basic concept of doing this self-calibration?
Sir,
CIC will cure his disease, or CIC will help you in finding something?
Sir, will CIC cell the whatever the structure will definitely reoccur, but the lumen will be wider.
No, CIC helps you in two things. When the stricture is coming back, at least it will tell you that now you will feeling weekends, and patient may have problem in next few weeks to months. That is the only thing you can get, and it is possible that CIC can warn you. It won't cure the stricture. Another question is that this stricture is, if I measure it, is 2 centimeter, and there are 2 strictures in between. You can see. So you still give the option to optical uretrectomy, or you'll give option for uteroplasty?
Sir, uteroplasty.
Oh, both of you said optical uretrectomy.
Why you have changed from optical to uteroplasty?
Sir, why you want to change? Once you
Sir,
why you want to
can I
change?
answer, sir?
Yeah.
Yes. Sir, still this patient is 69 years age and very high risk. He's a CAD patient and long-term diabetes with on anticoagulants. So he's very high risk for urethroplasty still. So I will counsel him for both options still. Even if he is having 2 strictures, still I can give him 1 attempt of VIU or urethroplasty also, but I'll counsel him in either way. Plus, he is also having an option of perineal urethrostomy because looking at the high risk of this patient.
Okay, I think that is acceptable, provided you are able to justify in view of his comorbidities and other things. Either way, you can justify. You can justify that he is a diabetic, he is likely to get infection with self-calibration and likely to have problems. So both ways you can justify. There is no quarrel on that. Now tell me that if you want to plan for urethroplasty in this case, what sort of urethroplasty you will plan?
Sir,
as you said that he is a 69 years old male, he is not sexually active, he has got hypertension, he is on both anticoagulant, double anticoagulants, hypertension, diabetes, everything is there. So now, which type of urethroplasty you want to?
Sir, I'll plan him for a dorsal, Barbaglie's dorsal. Only urethroplasty, sir. Or
so
yes,
what will happen if there is a lumen is very, very narrow? Suppose as Dr. Anandkumar was pointing out that there are 2 strictures and very likely that they could be a pinhole type of lumen. So in that case, what problems you anticipate in the dorsal onlay BMG?
Yes, sir. This I will be assessing just before the procedure by doing on-table urethroskopy. And if the lumen is less than 6 French, then I can plan for a double face urethroplasty or a floor strip anastomosis method. That is augmented anastomotic.
Okay. Anish, you want to ask anything? Okay, Dr. Gaurav,
yes.
What complications you anticipate when you do BMG urethroplasty in this case?
Sir, in immediate post-operative period, there may be bleeding from the oral side from where we have harvested the buccal mucosa. Or locally, with respect to urethra, there can be perineal hematoma, which may be due to the bleeding from the spongiosum. There may be infection, and there may be catheter discharge, which
what sort of perineal hematoma you are talking of? What?
Sir,
perineal hematoma you are talking of?
Sir, the scar, sir. which may be due to
No, near the scar means which
so the
scar?
perineal scar,
You are
sir,
talking
perineal scar.
post-operative?
Below the perineal scar.
Post-operative.
Yes, sir.
Okay.
And there can be, sir, discharge, periurethral discharge, which may indicate that there is a graft loss due to infection or necrosis.
Okay. So you can have infection. You can have,
yes, sir.
what else? What are the other complications?
In delayed complications, sir, there may be recurrence of stricture at the anastomotic sites.
Suppose this patient, you have done BMG urethroplasty, and immediately after catheter removal, how long you will keep a catheter?
Sir, 3 weeks, sir.
Why 3 weeks?
Sir, because the urothelium from the urethra has to grow and cover the graft. It usually takes 2 to 3 weeks, sir.
So graft is you want to cover the BMJ with urothelium. Is
The
that
growth of the urothelium, sir, will be there over this.
That's not the answer. You have already put the graph which has got the epithelium.
It is already the epithelial surface. It is not the raw area it is going to cover. It is already epithelium. It's a buccal mucosa. So you want that to be covered completely by the urothelium. Suppose if you have extensive full length, will it cover in 3 weeks' time? What is the logic of keeping a time? What happens in 3 weeks' time? What is the area which you want to cover with the urothelium, which are likely to happen? Yes, Dr. Gaurav, the other one.
Sir, the proper mucosal to mucosal healing, it will take at least 2 to 3 weeks, sir. So for that reason, and if early we remove the catheter because of the urine flow, that graft can just.
So your answer is that 3 weeks is a time where you have taken suture lines, you have taken the you have sutured with the other urethra, and the urothelium from that has to grow over the suture line and cover the areas which are the suture lines, and you don't want any urinary leakage from that, and that's the reason you want to keep the catheter for 3 weeks' time. Not that the suture line has to get covered, and that is by the surrounding urothelium which is going to get covered up. Okay.
Yes, sir.
Right. Any other complication?
Other reason is sometimes at the anastomotic site of two ends, some of the graft may slough off or may have not taken up. So there the catheter will help us if there is no extravasation. Some of the urothelium will grow and cover it.
Right. Correct. Okay. So BMG is your first choice of the surgery. Suppose this patient has very chronic smoker, and the buccal mucosa is not healthy. It is white, pigmented, and it is scarred. So what other options are there for him?
The labial skin or preauricular skin. Labial mucosa or preauricular skin.
So give the order in priority. What do you think are the next best choice after BMG?
Labial mucosa.
Huh?
No, but my question is why you guys are telling buccal mucosal urethroplasty is a 69-year male and his stricture is around 2 centimeters. Why not? Nobody is talking about anastomotic urethroplasty, end-to-end urethroplasty. That will give a very good result. Nobody is talking it. Rather that have a better success rate than buccal mucosal urethroplasty.
Will you do end-to-end urethroplasty in this case?
Sir, as this patient, the etiology of stricture is not clear. He's not having any history of trauma in this case.
Okay.
Plus, the stricture part is involving more in the distal bulbar and proximal penile area. So in that area, doing end-to-end anastomosis can lead to penile shortening, and that
It
can
is
be
not
a problem.
active for 10 years.
Pardon, sir?
It is not sexually active for 10 years. And it is not and if you mobilize 2 centimeter of the defect, it won't cause any shortening of the penis.
Okay, so Dr. Gaurav, in short, in a case like this, you have various options of treatment. You have optical ureterotomy, you have BMG urethroplasty, you have first stage urethroplasty. As you said, it could be perineal ureterostomy. As sir said that it could be end-to-end urethroplasty. In a case of stricture disease like this, you have to have various options, which you have to have pros and cons of each option. Examiner, moment you say one option, examiner is going to ask you the other option, and then you have to justify. So when you are presenting a case of stricture urethra, and especially the stricture like this, you have to have the advantages and disadvantages of all. For example, what are the benefits of end-to-end urethroplasty? What are the problems of end-to-end urethroplasty? What are the benefits of the problems of first stage urethroplasty? When will you do perineal ureterostomy? When will you do buccal because of urethroplasty? When will you take, what are the next options? When will you take from the lingual? When you will take the perineal, post-auricular? What are the pros and cons of each? So all that questions, all that answers have to be ready when you get case like that. Okay, and then of course the reasons of failure of urethroplasty, and once it fails, what are the options available? Those are the questions which are likely to come up. Dr. Anand Kumar, you want to add anything to that?
I think most of the things you have covered it, and one should see it. Actually, somebody said it is in the bulbar region. It is not. Maybe part of it is just in the distal bulb. It is still a bulbar structure.
Okay, Dr. Anish is there? You want to add anything?
Sir, he is coming online. Navneet, can you unmute Dr. Anish? He had a little disconnection because of internet issues.
He's doing it, sir. I just told him.
So after Anish's comments, I think we can stop
yes,
this and we can end this session.
Navneet, can you unmute Dr. Anish?
He's not online, sir.
No, he's online.
Anyway,
he's
I
online.
think Dr. Chawla, let us not waste time because already we have overshooted the time.
Okay.
So we can stop at this.
Anish wants to make some comments. Look, Anish just called me. He wants to make some comment.
Yeah,
Dr.
So
Anish.
Is he online?
Navneet?
No, I am taking him online.
Yeah.
Sir, he is online, but he has to start the audio at his end.
Dr. Anish, can you make your comments? Yeah, I am. Everybody is listening.
And it says host has start by you. Yeah.
Okay. Yeah.
Yes.
Please go ahead. From this phone only, you can go ahead.
Okay. No, actually, for last 10 minutes, actually, I have disconnected. So, I think probably it's okay to go ahead for the next session.
Anything special you want to mention? Anything special? Okay. Thank you very much. Thank you.
All right. Thank you. Thank
Yeah.
you, Dr. Chawla.
So, thank you, President USI, Dr. Anand Kumar, who has stayed for the whole session. Sir, please stay for the whole program, but have something to eat. Thank you, Dr. Sabnis. Thank you, Dr. Anish. Please stay logged in. Okay, Navneet, can we have the third session ready, and let us invite the next set of examiners. Dr. Videshwar Hota and Professor Dr. Sood and Surya Prakash. Dr. Rajiv is there? Dr. Rajiv Sood?
Yes.
Okay, sir. Okay. Sir, we'll have the next candidates. Next three candidates, please. Can you introduce yourself?
Good afternoon, sir.
Yeah.
Hello.
Your name?
Good afternoon, sir. Gaurav Kundu, sir.
Gaurav. Next one.
Sir, good afternoon, sir. Dr. Ghanshyam here, sir.
Okay, Ghanshyam. Next.
Shiv Kinkar Misra, sir, here.
Okay, okay. Now, welcome to you for the session. Over to presenter and over to the examiners.
Good afternoon, everyone.
Good afternoon, sir.
Yeah, please, please.
Good afternoon, sir.
Shall we start, sir?
Yeah, please start.
Okay, here is a 25-year-old male patient. He's a resident of Warangal, Telangana. He's a traffic police by occupation, presented with complaints of right loin pain since 2 months. So the right flank pain is dull aching, intermittent, non-radiating, not associated with vomiting and nausea, relieved by taking medications. There is no history of dysuria, hematuria, no history of fever, no history of previous urinary infections, no history of lithuria, no history of facial puffiness, pedal edema, or SOB, or decreased output, no history of weight loss, loss of appetite, and no history of jaundice, hemoptysis, bone pains. There is no history of similar complaints in the past. The examination moderately built, BMI is 25, performance status 0.5, ECOG, vitals normal, no failure. Systemic examination is normal. For abdomen, nothing remarkable.
Please stay here. Yeah, please stay here. Well, Dr. Ghanshyam.
Yes, sir.
Yeah. You can sum up the history and examination.
Sir, 25-year-old male with the on and off pain of right flank pain on and off other teeth, and without any other significant urinary or any past history, sir. So, without any examination findings, so most probably I would like to consider my differential diagnosis of first as a renal stone disease, and second one as a PUJ obstruction, and third one is, sir, also least likely, but polycystic kidney disease, sir. Polycystic kidney disease, sir. Would like.
Dr. Ghanshyam,
Yes,
why
sir.
do you think that it is a stone disease? Is the first? What is his age?
Sir, 25 years age, sir.
So 25 years age.
Yes, sir.
In fact, little bit of the discussion. He has only a right flank dull aching, intermittent, non-radiating. Could it also be a non-neurological cause?
Yes, sir. But most of the history they have
Yes, because
out like no any GI complaints is there, sir. They have ruled out a GI causes, and no any fever. So other causes mostly.
What is missing here? Can you point out, please? It is right flank dull aching, intermittent, non-radiating, not associated with vomiting, nausea, and relieved by not taking NSAIDs. What is still missing?
Sir, onset of the pain, whether it is a sudden onset or whether it's insidious, and other thing is whether it is affecting daily routine activity of the patient.
What is the duration? Would you like to know about that? No. If it is a very short duration,
Yes,
recently it has happened. Would you like to know the duration?
Yes, sir. Duration, mostly short duration, like it's, 2 months, sir. Yes.
Yeah, in this
Yes,
particular, see, this is what the very important. 2 months it is having dull intermittent pain without radiation. Anything
Yes,
else you would like to know more than what has been provided to you?
History of any trauma, sir.
There is no trauma. Any other thing?
The most of the things they have mentioned.
Yes, sir. So you don't require any further information on history. And examination is practically non-contributory, isn't it?
Yes, sir.
The physical examination and systemic disease as the first. What else you have kept in mind? Second thing?
PUJ obstruction, sir.
Why do you say PUJ obstruction?
Sir, means presentation of the PUJ is in like that in third or fourth decade, normally mostly seen in this age, and they also present with the same complaints of flank pain only or asymptomatic.
Well, PUJ is a diagnosis after you investigated. What would be more appropriate to say?
Sir, objective uropathy.
So any cause which can give rise to hydronephrosis
Hydatitis.
rather than pointing
Yes,
at a pathological diagnosis, isn't it?
Okay, sir. Yes, sir.
Yeah. And why not do hydronephrosis as fast and subsequently the stone disease? How do you rationalize?
Sir, most common means stone disease in our scenario, sir, is stone disease is more common comparatively to PUJ, and that are nowadays, sir, most.
Is young,
yes, sir.
and it is interferent disease and also could be a cause. Why not keep it that as fast? And second, there's the stone disease. That is one of the way you have to justify. You know,
Yes, sir.
whatever you say, you have to justify. And finally, what are other things you have in mind?
Sir, cystic disease of the kidney also we can keep as a third diagnosis, sir.
Yeah. Any cystic disease. Anything else?
Sir, I would like to put two more possibilities, sir, in this case. Sir,
right.
Possibility of geo tuberculosis also I want to keep in the mind, and also ureteric stricture also I want to keep in my mind.
See, that ureteric stricture is covered when you have talked about the hydronephrosis.
Yes,
sir.
So why at all you talk about GUTB at 25-year male and presenting only with the flank pain, no other ADUTS?
Yes, sir. So I just want to keep a possibility, and I want to ask questions regarding whether he has a previous history of contact with the tuberculosis or any long-term medications. Like
when you discuss, you discuss the differential diagnosis based on the presentation. So normally here we would not like to bring the GUTB because there is no urinary symptom and there is no constitutional symptom.
Sure.
So normally we would not like to bring, but the first thing, three things what we have said is the priority, the hydronephrosis for a different cause, or it could be a stone disease, or it's polycystic kidney. Now I think IR, Dr. IR is there, no? Hello,
sir.
Yeah,
no, sir.
Yeah, you have anything more to add to what has already been talked?
Yes, sir. I think it is very less possibility if ipsilateral viewer, and one history can be asked: is pain aggravate during the micturition or act of micturition? It may be possible, but very less likely, sir. In this case.
I think that should be the last thing to be taken into consideration. Looking at the age at 25, his presentation only for 2 months, and there is no history of UTI and fever. Right now, well, Gaurav,
sir,
how would you proceed with this case?
Sir, I would like to do basic investigations like complete blood count, urine routine, and microscopy, and blood urea, serum creatinine. And also, I would like to go for an ultrasound, abdomen and pelvis with a concentrating on KUB region with the PVR.
Yes. Yeah, can you show? Yeah, this is the examination finding, which is hardly any contributing. Now this is the urine finding.
So hemoglobin is 14.2, sir. Creatinine is 0.9.
Please show the urine finding. Yeah, please have a look at the urine finding. Dr. Ayer mentioned about the abnormality in the urine finding.
Sir, patient is having a protein on plus with plenty of pus cells with sir alkaline pH, and sir otherwise other parameters are within normal limits. Sir.
Well, this urine finding, can it contribute to your provisional diagnosis that you had made in order?
Yes, sir. Is suggestive of a UTI, so I still can keep the possibility of stone disease as well as PUJ both. and also cystic disease, if it is infected, also that can give rise to this kinds of urine routine findings, sir.
Dr. Ghanshyam.
Yes, sir.
Yeah. I think Dr. Gaurav has already mentioned about UTI. Do you agree with it?
Sir, we have to see the culture, sir. Maybe WBC may be there without the infection, sir, in the stone disease, sir, because of the inflammation, sir.
So you mean to say this is a pyuria, may be infective, no, maybe may not be infective?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Now, how do you proceed further from here?
Sir, I would look to.
Sir, I will.
Ultrasound.
I would like to. I would like to get a urine culture followed by ultrasound. KUB region.
Please show the culture. All the three residents at this point of time. I think ultrasound has already been shown.
Yes.
Can Dr. Iyer read the ultrasound?
Yes, sir.
Please read the ultrasound.
So this is ultrasound. However, it is not mentioning the side where whether it is right or left, sir. But it looks like, sir, right-sided ultrasound of kidney. That's showing multiple.
Tell me, what is the type of scan done here? Is it a trans scan or a long scan?
So it's a long scan.
Long scan. And what is the pathology seen in the long scan?
Sorry, sir.
Can I add? Can I add?
Can you see the pathology in the ultrasound?
Yes, sir. Yes, sir. Yes, sir. Yes. Here there is multiple haploic shadow along with mild dilated, very mild dilated PCS, and
there are two pictures
and
on
the
either
parenchyma
side.
appears normal, sir.
No, there are two pictures on
Yes.
either side. How do you read the sonographic finding of a kidney and mention about it here? Prakash, can you please show the pointer also, if it is possible? Yeah. Can you
Sir,
can
this
you
is
tell us?
yes, sir. Yes, sir. This is the haploic shadow with posterior acoustic shadow, sir. That might be maybe due to a stone, sir.
Yeah, can you read it in totality? Don't only focus on the pathology. There are two kidneys on both the sides. Can you read both? The right one and the left one?
The picture is not very clear, sir. However, in the left side, sir, there is mild dilatation of the PCS with normal thin parenchyma, and
no. Do we have?
So shall I show the report, sir? Because we don't have many.
This is not very.
No, do we have any other film of ultrasound, or these are only films?
Yeah, only one film. I think maybe we can show the report.
But briefly, any three of you, can you read the ultrasound report? There is a very significant finding on the right side.
So there are multiple hyperechoic shadows with a posterior acoustic shadows with a normal parenchymal thickness and with a maintained corticomedullary differentiation, sir, with a normal cortical echo.
Okay. Kindly give the report. Please give the report.
Right kidney normal in size and echo texture. Corticomedullary differentiation is made out. Few calculi noted, largest measuring 11 mm in upper pole with caliectasis. Left kidney normal.
Now, Dr. Ghanshyam, this is what the ultrasound reports. Right kidney, multiple calculi, largest being 11 millimeter in upper pole with caliectasis.
Sir, now I want to get a CT urography after the urine creatinine report of the patient, and simultaneously I will also go ahead with the X-ray KUB, plain X-ray KUB.
You want to do both?
Yes, sir, both.
What is the rationale?
Sir, X-ray KUB, actually it will give me a 2D image of the stone that will I will see in the OT on the C-arm, sir, that will I see, and next on follow-up, sir. I will follow with X-ray only, post-operative also. And another thing is with density also, we can roughly have an idea about the density of the stone if we can see on the X-ray, sir. So
yeah, once you are doing the CT, you are getting the achieve value in any case. Once you are doing the
yes,
CT, how this
yes, sir.
KUB, X-ray KUB is going to help you as regards the density is concerned. You will have a comparison with the bone, but here you are getting directly the achieve value.
Sir, post-operative also, sir, if we like patient, if any residual calculus will be there, sir, we will be following with the X-ray only, sir. So it will better have a pre-op.
What is your protocol in your institution?
Sir, we routinely get X-ray KUB done in all the cases, sir, of the stone disease before surgery, sir.
So initially you go for a X-ray KUB. Please show it. Dr. Surya Prakash.
No, we are showing the X-ray KUB.
Yeah.
Sir, X-ray KUB, it's shown here, exposed from the 11th rib to symphysis pubis with proper exposure is there, and bony shadows are normal, soft tissue shadows are normal, and there is no any ball shadows. And on right side in the kidney area, there are multiple radiopaque shadows are present. Most probably, most likely to renal stone.
Dr. Rajiv, also you can also come in and you can also explain.
Can you put the CT also so that they can see, candidates can see the CT?
Yeah. This is the plane and this is the contrast. This is Dr. Ghanshyam. This is a CT you asked me.
Yes, sir. CT urography film are seen here that are reconstructed images are shown here. Sir, I can see both the kidneys are well functioning with the right ureter contrast. Both the ureter also good contrast. It's seen excretion of contrast, and so my diagnosis after this CT scan will be the multiple right renal calculus with good functioning bilateral kidneys.
What will you do next?
Next, sir, after the further pre-anesthetic checkup, I will plan for a PCNL in this patient, sir. And before that surgery, I will explain to the patient for the multiple maybe the stage procedure. It may take 2 or 3 stage. Mostly it will be cleared in the stage procedure, and there may be chances of the bleeding. I have to explain to the patient more chances of the bleeding compared to normal. Sir.
Is it Ghanshyam? What you found as you got the reporting is concerned in ultrasound and CT scan, and what is very peculiar about this CT scan here?
Sir, ultrasound suggests you only to back stone, 2-3 stone there, but in here this stone there are multiple stones are there, sir. And
so the initial scout film of the KUB mentioned about the existence of multiple stones, isn't it?
Yes, sir.
Which
yes,
was
sir.
not found in the ultrasound,
yes,
and
sir.
CT scan delineated as regard their location is concerned very clearly vis-a-vis PCS. What do you find the location of the stone vis-a-vis PCS?
Sir, it's mostly are the calicial stones are, sir.
Yeah, exactly.
Many stones.
So it is more of calicial stone rather than
Yes,
it
sir.
is a pelvic stone, isn't it?
Yes.
The bulk
Yes,
is in the calicus rather in the pelvis.
Yes,
And
sir.
now what do you contemplate?
Sir,
What are the
most likely it will
options?
require.
Well, what are the options, Dr. Iyer? What are the options with you for this type of stones, which are quite a big in volume filling up all the calyces.
So the best option for this type of stone is the stage PCNL. It may be, it can be, sir, one time or preferably
Why
however the infundibulum is good, but
why do you bring
the stone.
ESWL to the discussion? I don't think at this juncture
Oh,
we
sir.
should bring ESWL.
So it is,
Right.
sir, either a single setting or a multi-stage piece is better.
Do you expect that in one setting all the stones from all the calyces can be clear, or you
No,
may
sir.
require more than one sitting?
More than one sitting. Definitely more than one sitting, sir.
So you have options of multiple sitting PCNL. Any other options?
Second will be, sir, open nephrolithotomy can be, sir.
Which one?
Anatrophic nephrolithotomy can be done.
Open nephrolectomy. Is there any term
Yes.
for that?
Yes, sir. Anatrophic nephrolithotomy.
Anatrophic. Do you think you'll prefer an anatopic nephrolectomy over a multi-sitting PCNL?
Sir, I will prefer multi-sitting PCNL, sir.
So it could be one or it could be a multi-stage PCNL. That is preferable.
Yes.
Anything you would like to do along with PCNL in this patient? What are the problem you
Yes, sir.
Sir, the arrangement of the location of the stone, the upper and the inferior calyceal stone can be taken in one sitting, but uh, mm, the involvement of interior and posterior calyces, all the poles, it might be difficult job, sir, in one time. But it can be, sir, the superior polar and inferior polar stone can be taken out in one, but the middle polar need multiple puncture, may take long hour, more bleeding. So that is the concern of multi-sitting.
Dr. Ghanshyam, look to the alignment of the stone. Alignment of the stone.
Yes,
it
sir.
is occupying both anterior and posterior calyx in each upper, mid, and lower.
Yes, sir.
So how many
Yes, sir.
punctures you are likely to do? If you look to the number of stone, how many punctures you may have to do?
Sir, most probably I will need a 3 puncture, sir.
3 puncture and you will tackle both.
2 to 3. Yes, sir. 2, mostly 2. Other if needed, 3 can be done. Sir, mostly 2 to 3, 2 maximum 3, sir.
2 to 3.
Yes, sir.
What are your institutional protocol? What do you do in such type of stone?
Sir, in this type of stone, sir, we do PCNL only, sir. Standard PCNL. With the only what I'm thinking is difficulty will be encountered because there is a less spaces there in between the calyxes. There is a space is very less. It will be.
The other part is that the chances of complications and what are the complications you are likely to encounter when you are dealing with this type of stone?
Sir,
Yeah, Gaurav.
Sir, this kind of calyceal loaded stone, when I'm planning for a PCNL, sir, main problem issues will be bleeding, sir. And bleeding can be due to excessive torque during the access to the other calyces. Also can be due to the stone manipulation, sir. And sir, another problem will be, sir, incomplete clearance of the stone burden. That can be cleared in the next stage. And sir, we may need to keep a nephrostome also for this patient, as we are anticipating bleeding as well as multi-stage surgery. And sir, another main problem will be guide wire placement, sir, because after puncturing, guide wire may not go through the pelvis. So that is another problem. So we have to overcome that problem also, sir. That's another issue.
Any other thing to be mentioned by other candidates and by also my fellow faculty, Dr. Rajiv Sood.
Yeah, what kind of stone you expect this is?
These are mostly true white stones, sir. We are expecting infectious stone mostly, sir.
Mostly composition?
Yes, sir. Calcium, ammonium, magnesium phosphate stones are mostly, sir.
What is the,
Sir, around 60,
I mean, amongst stone formers?
Around 40 to 60%, sir, cases.
And what is the cause? 40 to 60%. 40 to 60% is, and then
No, sir. It is a auxiliary stone which is very common. But in case of infection, persisting infection, the chances of stone is higher. So in presence of infection, it is 30 to 40%. Otherwise, it is 10 to 15%.
no, I have asked that amongst the stones, what is the percentage of oxalate stone? What is the percentage of white stones? What is
It
the
is 10 to
percentage?
15%.
So if this is, you feel because of the infection, what is the evidence in the history?
Sir, the pH of urine is 7, and one thing is and the presence of pus cell. These two is found in the examination, sir.
When WPCs are present in the urine, they are pus cells. They are pus cells or they are WBCs?
They are basically dead neutrophils,
They
sir.
are called pus cells, sir.
Now we are preferring to call them WBCs. You are right, but preferably also WBC pus cell. Earlier in the reporting, you were writing pus cells. So now you have not asked for the culture or anything before going for PCNL and all.
Culture is sterile, sir. They have given,
Yes, sir.
already, sir. We have asked.
Culture is sterile.
Yes, sir.
So these Stewart stones, they are bilateral or unilateral mostly?
Most of the time, it is bilateral because presence of infection. It is not in one side; it can be on both sides, sir.
So if it is because of no other anomaly, and why it is happening only on one side?
Probably because of disproportionate of the function. Then might be one cause, sir.
So function, you have told that it is normal bilaterally. Stresses, for that, what is the, have you defined where is the pelvis and what kind of pelvis is there?
It looks like
intradenal pelvis, sir.
Intradenal pelvis, sir.
So when you are, because these are important factors, when you are reading images, you should mention that also in your presentation, that what kind of pelvis is there. All right. And what are the other radiopaque stones?
Calcium monoxalate.
Calcium dihydrate, sir.
Dihydrate,
sir.
Which is the most radiopaque stone?
Calcium
monohydrate, sir.
What about cystine stones?
It is the strongest stone.
They are also radiopaque, sir.
They are also radiopaque. So other than steroid, any other diagnosis can be there?
It still can be uric acid stone also, sir.
Uric acid stone or big stone. Uric acid stones are radiopaque or?
Oh, sir, in this particular case, the chances of uric acid is less because the pH is 7, sir. So
what do you feel that what will happen to the function of the kidney? Usually, these stones are diagnosed when they are very small. So you have diagnosed this stone and they have filled all the calyces. So what can happen to the kidney? What type of function you expect in this kidney? To the other kidney?
If longer duration of obstruction and because of the infection, they may lead to the decrease of function of the kidney, sir.
So the function
But in this
can be
case,
compromised over the
yes, sir,
time.
but, yes,
Dr. Sood.
Yeah.
Dr. Sood,
Yeah.
can I just come in?
Yes, sir.
Go
Yes,
ahead,
sir.
Yeah, Dr.
Go ahead.
Nitin, welcome.
No,
Yes,
I've
yes,
been
Dr.
listening.
Nitin.
I thought I will just point out
Yeah.
few things which the students have not done properly because I think we might have to wrap up this case anyway. The first thing is the reading of ultrasound and CT, what they have done is pretty average. In fact, there are important findings missed, both on and they were using a term called acoustic shadow for the bright echogenic areas. The bright echogenic areas cause parenchymal reduced density. Though the ultrasonographer has reported it, look at the CT. The stone is going right up to the periphery of the cortex. Both at upper pole and lower pole, the stones are almost reaching the cortical edge, indicating a significant thinning of renal cortex, mostly at the polar waver. You look at the upper pole and lower pole, there is a very significant reduction of the cortical thickness. Can you see that?
Yes, sir.
And that should be noted. It is not equal. It is, and it is not a staghorn calculi. It is not a staghorn. So infection is very unlikely to be a cause of this stone. If suppose this kind of a stone would have been there on both sides, you would have been thinking of like a MSK kind of a picture, a nephrocalcinosis type of a picture. Because it is unilateral, but the whole distribution is on that corticomedullary junction and it destroying the renal parenchyma. It is quite a radio dense stone, so it is not very unlikely to be uric acid stone. So it's a multiple calyceal stone because of some abnormality like variations of MSK we get. And it's a very difficult stone to treat, as has been very rightly said. So the right side kidney is not normal. Just because it's excreting contrast doesn't mean that it is normal. It is significantly reduced in its function and cortical thickness. If you look around, only the cortex in the middle portion is probably slightly preserved, but both the polar region, there's a significant loss of the treatment options you have mentioned. Ultimately, it may require both. It may require multiple punctures, and in today's age, may also be you might put a stent during your first PCNL so that the ureter can dilate. So the next time when you go in, you may have to use both modalities to clear the stones. That is, may use a retrograde approach as well as a PCNL approach to clear the stones. It is a difficult stone to treat, and the patient must be counseled, as you rightly said, that it may require multiple sittings. Still, you may leave behind some stones. Is that clear? Yes.
Okay.
What are the chances of recurrence?
We should move on to the next step.
Okay.
I think we have raised the time limit of this case.
Okay. We should move on to the next case.
Okay.
Can we move on to the next case? Gaurav, before we go to the next case, would you like to do any metabolic workup for this patient? I think, are they unmuted, previous candidates? Okay.
Yes, sir.
Would you like to do a metabolic workup?
Yes, sir. You like
Namit, can you call the next three candidates? Are the students online? Dr. Kaushal, Dr. Krishnendu, Dr. Lakshman.
Yes, sir. Dr. Kaushal.
Introduce yourself. Who are there? Dr. Kaushal is there?
Yes, sir. Dr. Kaushal.
Krishnendu. Lakshman.
Yes, sir.
Okay, two people are there. Then we'll go ahead. Let's have the case details.
So here is a 55-year-old male patient. He's from Nizamabad, Telangana, complaining of frequency nocturia dysuria since 6 months. He has history of frequency of urine nocturia, daytime 15, nighttime 8. History of urgency, slow stream, intermittency, IPSS 24/35. No history of hematuria, lithuria. No history of prior urology instrumentation. No history of fever, flank pain, leg swelling, facial puffiness, nausea, vomiting. Backache, weight loss. No history of comorbidities. There is no significant surgical family personal history. The moderately built and moderate nourished, BMI is 28, performance state is 1/5, vitals normal, and systemic examination is normal, no failure. Nothing remarkable, external genitalia normal. DRA, sphincter is normal, grade 2 prostate, non-tender, no foam nodule, median surface is felt, upper border could reach, mucosa over the prostate is 50.
Dr. Krishnendu. Are you online? Dr. Kaushal, Dr. Krishnendu?
Yes, sir.
Hello. 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 Hello.
Yes.
Hello. Am I audible, sir?
Yes, yes, yes.
Yes, sir.
Differential diagnosis.
So who is presenting?
The presenter has finished. There are three candidates.
No, who is answering? That's what I'm asking.
Tell your name.
Hello,
So
sir.
there is
My
a-
name is.
Your doctor?
Hello, sir. My name is Dr. Krishnendu.
Yeah, okay. You present to Dr. Nick.
Okay, sir. 55-year male. The patient is primarily having frequency urgency. So these are signs of irritative symptoms. So both irritative.
Irritative
Hello.
symptom.
Hello.
Is that what you said?
Hello.
Yes,
Yes, sir. Both irritative and.
Is that a correct terminology to use?
Hello.
Storage symptoms.
I think there's some problem with the audio. Can't hear.
Krishnendu?
Yes, sir.
Yeah, are you able to hear sir's question?
Sir, I am able to hear, but probably sir is not able to hear me.
No, I can hear you.
Can you repeat
Okay,
what
sir.
you wanted to tell. Repeat.
Sir, patient is having frequency and nocturia 8 times. So these are irritative symptoms. Plus, the patient is also having slow urine stream and intermittency.
And
So
that's why I
patient
asked you that is it a right thing to word called irritative? Is it a right terminology to use?
storage symptoms.
Yeah, I think it is better never to use that term. It has been abandoned long time back.
Yes, sir. Both storage and obstructive symptoms.
Again.
I would like to know the duration of these symptoms, how long it has started, whether this is associated with this slow urine stream, whether on forcing there is an improvement in flow of urine, whether the patient is having, along with this, sense of incomplete voiding and any incontinence throughout this period, whether the patient is taking any medications or any treatment whatsoever patient has taken, any history of any retention during this period, and then I would like to take the history of patient is not having any hematuria, any history of recurrent UTI, any dysuria, any suprapubic discomfort, tenderness, any history of flank pain with fever. There is no history of prior urological instrumentation. There is no history now at this point. Any history of
All these things have been covered in the history.
What that has been mentioned, what you have to do is to interpret. You said very rightly that you would like to know the onset and the progress of these symptoms. What started first?
Yes,
And what is the situation?
Yes,
What you are got today is the situation today. And it's so important to know how it
Yes, sir.
started.
Initially, frequency and nocturia, sir. After that, he developed other symptoms.
Okay. So now we know that he started with storage symptoms, nocturia, and then slowly he's getting now into so-called voiding symptoms as well. So now what do you want to do?
Sir, can I mute the video because net is slow? I can only the audio.
Yeah, okay.
Yeah, sure. Go ahead.
Yes. So in the
There's a problem with the audio.
With training, the patient is having any improvement in flow of urine.
I think he
Hello?
wants to know that if a patient can hold urine longer, does it improve his flow? That's what he wants to know. Why you want to know that?
That means that there is no fixed obstruction. With straining, there is improvement in flow. Probably a clue that the patient is not having a fixed anatomical obstruction.
I don't think there is any scientific rationale behind what you are saying.
Okay, sir. So next thing, sir, I would like to know whether the patient arguments during this period and any history of retention during this period.
I think Dr. Kaushal, they have already told you that there is urgency. If they would have been incontinent, they would have mentioned it. He has no
Okay, sir.
radiological instrumentation history, so there is no question of asking for retention because then he would have been catheterized. So I think it is a waste of time when the information is given and you ask the questions which are probably not required. So we know there is no history of urological instrumentation, no retention has happened, otherwise they would have told you that.
Okay, sir. Any difficulty in walking and tingling and numbness of the lower limbs?
Why are you asking that? A patient presenting with lower urinary tract symptoms, storage and voiding with no other prior history, no other disease they have mentioned, why suddenly he should develop numbness and things like that?
Sir, this is a negative history to rule out whether the patient is having any neurological problem. 55-year-old age is the age where the patient may have some sleep disc-like problems which can aggravate over a period of 6 months, leading to urgency, frequency.
Would the patient will have a just presence with lower tract symptoms? How often it happens?
Yes, sir. It is likely that the patient will give a history of backache.
So
but
obviously,
severe
again,
trauma
they have
which
given
the
you
patient
no
may have
history of
missed.
backache. They have given you the history. We are unnecessarily wasting time.
I think all the positive findings they have given. Now you can tell us that what
you have to decide the main problem, as you already said, predominant storage symptoms along with some voiding symptoms. 55-year-old man. They have given you the retinal examination. Now you need to tell us what do you think and what you want to do.
No.
Hello.
Hello. Yeah, go ahead.
Sir, now I would like to take the whether the patient is having during this episode any history of uh, hematuria, any history of
Dr. Vishwas, all the history has been given. We don't, there is
Come
nothing
out of
hidden from
history.
you. You are just wasting time again and again on symptoms which are not there. We have already accepted that he has got storage and voiding symptoms. He's got no other problem. He's got predominantly storage symptoms, some voiding symptoms, and he has got no other disease. That is depression. And what do you want to do?
He probably suffering from bladder outlet obstruction secondary to bladder benign prostatic enlargement. So
how do you know that?
We further want to investigate. Hello.
Yeah, go ahead.
So first we want to urine microscopy and blood investigations and serum PSA.
Here it is. You never considered any other diagnosis at all. What is your thinking? Just prostate.
First diagnosis is bladder outlet obstruction due to benign prostatic enlargement. Secondly, it may be overactive bladder.
Dr. Kaushik, you asked the thing and they said his initial starting symptoms were storage symptoms.
Yes, predominantly storage.
What are the other issues where the person can have significant storage symptoms? Is there any else thing can be there? Dysuria he has.
Vesical calculus.
Can he have anything else? Stone, yes.
Apart from the benign prostatic enlargement,
GUTB.
it may be UTI. Urethra.
UTI is a possibility, along with a complicating factor.
Yes.
What else is? Suppose
Stricture disease can present with a similar.
Stricture presents like this.
It may be metal stenosis.
Do the patients have urethral stricture present with this kind of a storage symptom? I think it is very, very important not to be, a very simple case and you are telling meatal stenosis and stricture. They are all the causes of slow flow. The patient predominantly will complain of voiding symptoms. And his storage symptoms will always be, if at all, they are very mild or apparently not there.
It may be polyuria.
Polyuria. Okay.
Maybe.
So did you ask the most important question in the history? How do you differentiate that?
It is diet and fluid intake, about how much is daily take of fluid. Is it he is taking any anti-hypertensive medication like diuretics?
They have given the history is not. Anyway, so this is your urine examination. What is the interpretation? What does it rule out?
I am unable to see the slides.
Oh, the urine examination you are not able to see?
Yes, sir. I'm not.
Okay, basically, essentially normal. There is no some squamous cells, rest, everything is negative. 1+ protein, but apart from that, everything is normal. So essentially, the urine is non-contributory.
Then we advise him to pour at least 3 days voiding diary.
Okay, so you want avoiding diarrhea on him.
Yes, sir.
Okay.
Because he has predominantly nocturia.
Okay. Apart from that, anything you will ask?
Apart from serum creatinine. And then Euroflow PBRU.
Anything else?
serum PSA, and then USI.
Have you got a voiding diary for him?
No, sir.
We don't have voiding.
We don't. They don't have voiding diary. But
What
I
is
think
the-
I agree that this patient would need a voiding diary.
Serum creatinine is 0.7, hemoglobin 13.6, total count 6,300. Serum PSA is 2.6.
Then Euroflow and PVR. I am unable to see slides.
You are unable to see slide, so I'll read the flow for you. The 239 voided volume, it's an interrupt 7 to 8 ml. So it's a says 8 ml flow with a voided volume of 239. PVR is not mentioned.
There is 40 ml, sir.
How much?
40 ml, sir. 40 ml.
40 ml. So 40 ml is the post-void residue.
Is obstructed pattern and interrupted pattern. It may be with PVR of 40 ml.
So how do you interpret a flow? When you see a flow like this, what when the patient comes to you, what do you ask him?
What are some how it bother the flow?
Sorry?
But bothering. How it bothering?
Bothering?
Yes.
I didn't get you. What do you mean by bothering? The patient has done a flow rate and he comes to the OPD. You're looking at a flow. What question you want to ask the patient? When you see a
First
flow
we
like
asked
this.
him, then he routinely void like this pattern when he was tested for Euroflow.
Correct. So if it is whether it is representative or not.
Yes.
Because you cannot suddenly decide on one thing which is come to you, which is not looking usual. So you must ask him, because it's possible the next time he may do a continuous flow.
Yes. It is the obstructive.
What next?
This is the Qmax less than 10 with patient with have both storage symptoms with voided volume of 230 with PVR 40 ml with normal serum creatinine with severe bothersome LUTs. We should advise him first behavioral modification.
Behavioral modification.
In the
Why do you think he's got something wrong with his behaviors?
behavior, lifestyle and behavior modification.
No, but did you find anything wrong with his behavior?
Time of fluid intake, all things. Decrease full intake, especially in the nights. Decrease coffee and tea intake.
See, it is very, very important that when you voiding diary will give you a symptom, but most likely the patient themselves will cut down when they have such a problem. A guy who is getting down 8 times during the night, do you think he's going to drink more water? So the voiding diary is helpful, but there is something else in this guy. He's only 55, his prostate wasn't very big, and he's got severe storage symptoms. Don't you want to rule out something to make sure that the storage symptom may be because of something else as well?
X-ray pelvis.
Show him the X-ray.
Yes.
I'm not.
It is suggestive of sir, a large radiopaque density in the region of bladder. Suggestive of vesical calculus.
So what do you think is it a primary calculus or a secondary calculus?
As the calculus appears to be a very smooth by contour, so it could be secondary to enlarged prostate due to causing
Enlarged prostate produces stone, is it?
Sir, because of the significant post-void recurrent infection and stasis leads to formation of stone.
Mostly the combination of stasis and
obstruction.
Stasis because of obstruction, and sometimes infection because of stasis, that this could give rise to a stone formation, and which can in turn be responsible for significant storage symptoms. So what do you want to do now?
Sir, now we have to counsel patient that he will certainly require a surgical treatment for
Yes, sir. To see upper tract also.
What else? Why you need an ultrasound? Okay, choose.
You have an ultrasound, give it to him.
These are normal. This is
Dr. Kekere, am I audible?
Yeah, you're audible.
Yeah, that's what I wanted to confirm.
Go ahead, quick.
Come on, we don't have much time. This is the ultrasound report.
it is a normal bladder. Is distended irregular wall thickening noted. 3.4 centimeter vesicle calculus noted. 2.210 cc. PVR 50 cc. Washington 40 cc.
Yes, sir. Go ahead. Who is answering?
Sir, we can plan this patient for cystolithotripsy, and that time during the scope we can decide whether to go for a front. He needs a prostate also in the same setting, or can be managed with cystolithotripsy only.
So you think that the stone is not because of obstruction? Is that what the doubt is?
Yeah, at the time of scopy, we can see that lobes are obstructing the severity of obstruction can be assessed at the time of scopy only.
So you think that the diagnosis of bladder obstruction can be made by endoscopy only?
Sir, his symptoms started with storage symptoms. The development of stone. Stone might be the cause of developing obstructive symptoms. So once we are done.
What is the problem in patients' histories usually between the storage and voiding symptoms? What is the usual problem?
It is bias is generally seen on the patients.
What brings patients to the doctors usually? Voiding symptoms or storage symptoms?
Generally, voiding symptoms bring.
Voiding symptoms bring patients to doctors more? It is opposite, you know. It is always the storage symptoms which are more bothersome. People are quite happy to pass urine slowly. They don't get into trouble. That's why they may not even remember that their flow has been low for a long time. They start noticing the
Please
problem
note,
when
we have 10 minutes left. Please note.
Yeah. So it is very, very important to clear this. You know, people don't come for voiding symptoms very rarely. Mostly they come because of getting up at night. That's why nocturia, storage symptoms. Become more predominant. There's a stone and there is a problem. How do you prove that? If you have to prove.
At the time of scopy, sir, we can decide whether the lobes are falling into the lumen when irrigation or with the irrigation on.
So what treatment you have? Suppose let's assume that we agree that there is a bladder outlet obstruction and a secondary calculi. How are you going to select the treatment? What are you going to do?
For the stone of this size at 3.4, we can go for cystolithotripsy, and as the gland size is also not much around 40 cc, we can go for a cystolithodipsy and TURP in one setting. However, for stones larger than this size, is the if we find that prostate is also obstructing, there is a cause for a secondary stone. So we can go on two different settings.
You want to do two different settings for this condition?
No,
Two operations?
Now, this case, sir, we can go for a single sitting because gland is
No,
also.
in any case, when there is a stone and a prostate obstruction, is it usual to do the two-stage procedures today?
No, sir, single stage.
If the stone is quite large, 5-6 centimeters, so we will have to stage. It can be done, but
Are the other students agree with that?
No, sir, in the single setting.
Because the chances of stricture post-op stricture will be very high when contemplating two operations for a large stone and or prostate also.
So how can that be obviated?
That can be obviated by an open procedure, can be done. But if we are
that is one option. That is, the stone is very big. You do the TURP, open, make a small incision, take the whole stone out in one go.
Yes.
So that is one. But if somebody wants to do it endourologically,
endourologically, sir, that can be associated with some post-op increased rate of stricture.
no, I think you are not getting the. Can anybody other answer?
If it is a large stone, we can percutaneously remove the stone PCCLE, and then TURP can be done in single setting.
Yes. Yeah. So the options are, you can, if you want to do it endoscopically, you can do a PCCL along with TURP. You don't have to worry about stricture.
Yes.
Usually patients won't like to come for the same time again and again. So it's PCCL and TURP is possible even in a large stone. Or even if suppose it's a very large stone and you don't want to do PCL, I don't have any issue if somebody takes the stone out by small incision. So basically you have to that is what mostly suits.
Yeah,
Dr.
I
Ota.
think very interesting question you had asked Dr. Thekre. When you had looked at the uroflowmetry, you found an intermittency there. They didn't explain even after looking at the ultrasound and X-ray.
Yeah.
The students can tell now after you have seen all the pictures, ultrasound, X-ray, and the uroflowmetry. Can you correlate? Residents, any of the residents can answer?
Are they listening to us?
Yes, sir.
What Dr. Hota is asking, that when I read the flow, I said that there is an intermittency. The flow stopped completely and then restarted.
Because the
Vesicle
stone, the vesicle stone blocks the flow and then
Possible. Flow rate should be interpreted. It should be looked at carefully, interpreted carefully. Suppose this patient has no stone. Let's assume it's not no stone. Suppose it turned out there is no stone.
Yes.
All right, but his symptoms remain the same. His flow is he's about 7 to 8 ml. There is no PVR. What would you do?
Start with the
alpha block. Okay.
Start with the alpha block.
How do you decide that? Toss of a coin?
Sir,
no, if the prostatic volume is 40 ml, so we should start along with the 5-alpha reductase. It takes time, but in long term it has pull.
So what do you want to start? Do you want to start 5-alpha reductase because his volume is 40 cc, or you want to start alpha blocker?
You want to start combination.
You want to start combination. So what do you want to start him with?
Yes, sir. TAM solution plus dutasteride combination.
Okay, you started. Then how are you going to follow him up?
Higher for reductase take at least 3 months to work, and the TAM solution we follow after 2 weeks to 3 weeks.
Okay, so you called him after 6 weeks. He says no difference. He says, sir, I haven't got any benefit, 0. I'm still waking up 7 to 8 times at night. I'm going 10 to 12 times during the day, and my flow hasn't changed.
We can add up an antimuscarinic drug if predominantly storage symptoms. If or net PVR is not to more than 150 ml. As this case, the PVR is around 30-40 ml. We can add antimuscarinic.
So which one will you? Why solifenacin?
Sir, it has the least complication rate compared to tolterodine.
And what about the efficacy?
Efficacy is similar.
Mm-hmm. So you want to start him with solifenacin?
Yes.
Okay, but do you want to find out what's wrong with him?
Yes. If it is not at all improving, then sir, PVR pressure flow study can be done if it is at all not improving.
Mm-hmm. So one is if it doesn't improve with this, you will do a urodynamic evaluation to figure out what's going on.
Yes.
Would you also consider what about worrying about his lower tract? Is there any other pathology can be missed? Significant storage symptoms. Young man.
Infection.
You ruled out infection.
Yes, sir. Ruled out stone.
A few minutes left, sir. If you can quickly.
Because we do not take a lot of time, the history, same questions repeatedly.
Yeah, I think the thing is the history given was pretty complete in my opinion.
Sir.
And a lot of time was wasted on unnecessary things, interpreting the thing. What he should have asked was only one pertinent question was the progression of symptoms. One was important. Intake output history and the voided volume history. Very, very important to find out. That is how much volume he passes. The patient has a reasonable idea. They will tell you I pass small quantity. Many times the urgency history, because the patient is able to prevent incontinence by running to the loo. But that can be so important thing to understand is we want to know whether the storage symptoms can have a cause. It can be from infections, it can be a carcinoma situ, it can be sometimes C bladder also, and a commonly stone. And nocturia is he doesn't have fall into nocturia category. He's got a diurnal frequency. He's got both day and night equal frequency. So it's very, very important that he should have asked questions regarding that. And interpretation of investigation.
Yes.
And after seeing the stone in the bladder also, the upper tract evaluation was not asked. It's very, very important to make sure that the upper tracts are normal. I think there are a few very, very critical things which were should be done properly, especially in a very day-to-day. This is an everyday case. It's not something new. So these cases should be dealt very, very.
Okay, thank you. Can we move on to the next case, sir? Next case. Who are the candidates? Namit, can you call the next 3 candidates? Dr. Manas, Dr. Sarbarta, Dr. Mithul. Are you logged in, Dr. Manas?
Yes. Can you hear me, sir? I'm Dr. Manas here.
Yeah. Who else is there? Who else is there?
Hello.
Dr.
Hello. Hello.
Hello.
Who is this?
Hello, I am Dr. Shorbartho.
Okay. Okay.
Sir, I am Dr. Mithun.
Yeah, okay. All three are there. Then we move on to next case.
Here is a 14-year-old male child, Master D, is completing a course stream, straining and incontinence since 2 years, with regular bowel habits from 2 years. Patient has a history of fall from height in 2017. He sustained spinal injury with L1 fracture, underwent D2 and L1 laminectomy with spine fixation. Post fixation, after removal of the catheter, he failed to void and he was advised to do CAC. Now he complains of post-stream sense of incomplete emptying of the bladder and incontinence. He is using 2 pads per day. He has history of recurrent urinary tract infections for which he is using antibiotics from local doctor. No history of any other complaints. Built, BMI
Now, before we go on to examination, can we, who's answering?
Hello, sir.
Yes. Are you happy with the information or you want some more information?
Sir, I want to get information about the patient, more on the patient voiding, that how much urine he passes in each voids, and as he was put on CIC, whether he is having any incontinence in between the CIC after he is being put on CIC or not.
You didn't see the history. He was advised. He didn't do it.
Okay, sir. So how is whether he is doing? Okay, sir. He was advised CIC, but whether he is doing or not, how many times he is incontinent, how many times he is passing urine, and the amount of urine he is passing in each voids, and the number of breakthrough infection UTI episodes in the last 3 years, and
he's not
whether there is.
I think terminologies have to be very correct. If we are not breakthrough infections, is terminology used for which patient?
So these are for viewers, primary viewers.
Patient was on a regular prophylaxis with
antibiotic.
VUR.
Yes, sir.
So here we are not talking of that. Here is fine. So they advised him CIC.
Yes,
now complaints of poor stream means he is not doing CIC.
Yes, sir.
He is also saying incomplete. Do you want to know about incontinence?
Yes, sir. Whether he is having fecal incontinence or not, whether he is constipated or not, whether
Okay, so you want to know about the bowel symptoms.
Bowel habit, yes, sir.
Yeah.
And whether he is he has undergone any periurethral intervention during this period or not.
What intervention?
Any periurethral instrumentation or catheterization or any intervention, periurethral intervention.
He had an operation, and during which there was a catheter. The history has been given.
Sir. Sir.
Yes. Yeah, that's a good thing. You want to know what sort of incontinence it is. Does he know that he is leaking, or he's just dribbling? Is there a difference between that?
Yes, sir.
Yeah, so that is the thing, because just telling incontinence doesn't help me.
It can be overflow incontinence as well.
Maybe. So how would you figure that out? By asking a history.
Yeah. Yes, sir.
So you should ask what sort of incontinence it is. And of course, very important to know about the bowel symptoms.
Yes, sir.
Okay. Next. Is there irregular bowel habits, but that doesn't really answer. You want to know how do you ask a bowel history in a patient who is suspected to have a spinal cord injury? What do you want to know?
About the frequency of passing stools, about the consistency of the stools.
That's all. Is he able to pass motion with
control
normally, or does he need some help?
Okay.
Patient who has spinal cord injuries, do they have normal bowel habits?
No, sir.
So usually they require some of an additive things to make sure that the bowel moves. So they usually maybe
Enema.
very severe. Yeah, so you need to
Maybe
know how
they
it
may
does. It do digital evacuation?
digital evacuation,
He use
enema or
enemas?
laxative.
Does he use
Laxative.
anything mass reflex techniques? So all those things need to be asked because the bowel history is as important as
Urinary history.
as a urinary history. Okay, go ahead. Now there is a history of UTI mentioned. Are you happy with that history? Or you want to know something more about it?
Sir, I want to know more about this UTI history, that whether there was in this UTI period, there was any pain in the flank, whether there was fever and associated chills and rigor or not. How is this UTI episodes were treated, whether he required any hospital admission or intravenous antibiotic requirement or not, or any
So
culture sensitivity or not during this
yes,
period.
that's right. You want to know whether he's having pyelonephritis, which can
Yes,
be
sir.
a big problem. So I think you don't get marks or credit after I tell you to ask. All right.
Yes.
So when this history is given, and when we ask you that anything want to you ask, it means always would mean that the examiner has picked up certain shortcomings in the history, and you would like you to be asking that question. So you should have asked all those symptoms which I have pointed out. Okay.
Yes, sir.
What else? What else you want to know?
Examination findings.
Okay.
Examination, abdomen is soft, bladder is not palpable, no organomegaly. Spine post-laminectomy scar is present. External genitalia are normal, no phimosis. PRA anatone is normal, rectum is empty. Anatone is reduced, rectum is empty.
Yes, sir.
Anything else you want in examination, or is this enough for you?
Sir, focused neurological examination.
Yeah.
Superficial reflex, abdomen reflex intact, Tremash reflex present, BCR, bulbocavernous reflex present, sensations are intact, motor examination, upper limb and lower limb, tone is normal, power is 5/5, plantar reflex is flexion, ankle and knee normal.
So essentially normal.
Yes. Sir, next I would like to investigate the patient, and I will go for complete blood count, serum urea,
No,
creatinine.
what this examination has ruled out from the
Sir,
point
this
of
has,
view.
sir, this has ruled out that there is no lesion in the sacral level. That
Oh my
because
God. We don't worry about neurology. What has urologically ruled out?
sir, patient doesn't have distended bladder, so
Yeah, the
patient
most
is having
important.
not having overflow incontinence.
Because we were thinking whether he has a
Overflow
overflow
incontinence.
incontinence. So
Yes, sir.
this particular findings has ruled out a possibility of being a overflow
Yes, sir.
incontinence.
Incontinence.
Okay.
Sir, with this finding, I would next like to investigate the patient, and I will like to have complete blood count, serum urea, creatinine, routine urine analysis, and urine culture. Routine urine analysis shows almost normal except 4 to 6 WC per hypertrophy, which is almost normal. And next, urine culture sensitivity, it is also normal. Serum creatinine is 0.8 milligram per percent, which is also good kidney function by this serum creatinine. And then next, I would like to have a ultrasonography of KUBP with post-void residual urine and uroflowmetry.
This is ultrasound.
So,
Ultrasound is there. Can you interpret it?
So, ultrasound KUB. Yes.
Ultrasound KUB, right side kidney, normal size, normal echo, and CMD is preserved. Right side hydronephrosis is present. On left side also, it is normal size, normal echo and corticomedullary differentiation maintained. Again, left side hydronephrosis is present.
Okay.
Actually, ureter is also dilated. means upper part of ureter is also dilated.
So there is a bilateral hydroureteronephrosis.
Yes, nephrosis. Yes, sir.
Okay.
And bladder, that is distended bladder. Then
and also, sir, there is some circulations seen in the bladder wall. So probably bladder is trabeculated like that. There no in smooth outline, and also the muscle thickness is probably little bit raised, sir. Muscle is thickened, sir. Wall thickness is also.
Not little bit. It's a thickened irregular bladder wall. Is the normal bladder looks like that?
No, sir. It is irregular bladder, and also in the second plane, sir, the lower ureter is seen dilated, sir.
Yeah. So it's a very thick wall, irregular, sacculated, probably trabeculated bladder. With next.
Sir, I want to know the prevoid and postvoid residual.
They're coming. It's coming.
Yes.
Yeah.
Yes.
Diffuse wall thickening of the urinary bladder wall with mild mucosal irregularity, floating low-level internal echoes are noted. Prevoid is 160 cc, postvoid is 47 cc, and bilateral grade to renal parenchymal changes right more than left. Bilateral mild to moderate hydroureteronephrosis.
Okay.
Yes, sir.
So what do you interpret this?
There are back pressure changes due to the neurogenic component of the bladder. And hence, I would like to further investigate by doing a urodynamic study to characterize.
Just a minute. Is it Dr. Manas?
Yes, sir.
Yes. You saw the postvoid residual urine.
Yes, sir.
47 ml.
Yeah.
If PVR is 47 ml. Now, how do you explain the bilateral hydroureteronephrosis at this juncture? Sorry, Dr. Sekre, just I intervened. I'm sorry.
No. Go ahead. Let him answer that. The question being asked to you is bilateral hydroureteronephrosis and the relationship of a residual urine. Is the residual urine correlates with hydroureteronephrosis?
Sir, it might not always correlate, sir, because this is a single value of the postvoid residue. If suppose we repeat it at another time, we might see a larger residual volume in the bladder.
So how do you interpret residual volume? When you do ultrasound, suppose you do 3 ultrasounds and you get 3 readings. One you get 80 ml, another you get 60 ml, another you get 55 ml. So which is correct?
Sir, I would like to do take the account of both prevoid residual.
You have done 3 postvoid residues, all done properly. All of the time, the 3 values come differently. One comes 80, another comes 60, the third comes 55. So when we do this, which residual volume is considered the correct value?
So the lowest one should be considered as the correct value, sir.
So which is the best one then? It's 55.
50, yes, sir.
Yeah. So that won't change the relationship of hydroureteronephrosis to the residual urine.
Yes, sir.
Which residual? When do we talk of residual urine correlating with hydroureteronephrosis? Which conditions?
Sir, in lower tract obstructive condition, when there is secondary viewer, then we are talking about the postvoid residual urine causing back pressure changes causing bilateral hydroureteronephrosis.
Chronic obstruction, high pressure retention may correlate, but it is never a direct correlation.
Yeah.
Yes, sir.
So the Dr. Ghota is asking you, in this particular patient, there is no significant postvoid residual urine, but there is hydronephrosis.
Hydroureteronephrosis.
Hydroureteronephrosis. So he's asking you what can be the reasons
Sir, there may be reason is like that. There may be high pressure. The bladder compliance may be low after the injury. So after that, due to bilateral hydroureteronephrosis, there may be some secondary obstructive changes in the ureter. So
No. Your
this-
first question, first answer is right, that if the altered compliance is responsible for hydroureteronephrosis.
Yes, sir.
Okay, what other cause?
Sir, it is due to the increased storage pressure secondary to the decreased compliance.
No, he said that decreased compliance. We accept that. Yes.
Sir, there may be
Anything
low
else?
bladder capacity. Low bladder capacity.
Small bladder capacity. Ultimately, it also causes poor compliance. Same thing.
The Tusser overactivity.
No. What things can
Sir,
happen in a
So patient may be doing some assisted bladder maneuver like compressing the abdominal muscles to evacuate the urine. So so having the less post-birth residual urine.
No,
What is
that
that
I'm not.
called?
I'm not asking. We are not asking you the question of why the residue is high or low. What is the question is causes for hydroureteronephrosis in a neurogenic bladder. We agreed that the one is obstruction, second is altered compliance, combination of obstruction with altered compliance. Can anything else be there?
Sir,
any pathology at the VUJ or the detrusor?
But
sir,
can there be a reflux?
patient is having a recurrent.
Yes, sir.
Infection.
In recurrent infection, there may be VUJ stricture.
Stricture.
Can there be a reflux?
Yes, sir.
Can
Yes, sir.
there be
Reflux.
Yeah. So, VOR, secondary VOR is known to occur in neurogenic bladders.
Yes, sir.
Which will cause a mild dilatation of the upper tract and also be responsible for complicating acute pyelonephritis.
Yes, sir.
Very rarely, the detrusor muscle hypertrophy can impinge the ureteric orifice. Very, very rare. It is extremely rare.
Extremely rare, yeah, uncommon.
Okay, so you should
Yes,
not mention it, and it is a rather thing which is people believe, but it's very, very rare. So, but that for the mentioning, yes, it can be one of the reasons.
Yes.
So it is very clear. So that is what Dr. Hota was wanting to know from you. Okay.
Yes.
So next.
How do you proceed from here?
Sir, I would like to do uroflowmetry and urodynamics study, sir, in this patient.
Okay. Can you show the flow?
So sir, the voided volume is satisfactory like 230 ml, but the maximum flow rate is less, is 10.5 ml, and the patient is having intermittent pattern of flow.
What is the mistake? What is the mistake you did in reading the flow? You read the printed flow, correct?
Yes, sir.
Is it a correct reading?
No, so maximum flow rate is right, sir. The 10.5 ml per second, it is showing like that, sir. Maximum flow rate.
But when you have different peaks, do you take one peak?
No, sir. I will draw a line connecting the peaks.
Now, once I tell you when you connect, your flow would change, isn't it?
Yes, sir. Yes, sir.
So the same point I'm making that here is MCH level exam. You expect you to do this and tell me the corrected flow is this.
Yes, sir. The corrected flow would be less than the printed report, sir.
It will almost be half.
Yes, sir.
About 5 to 6 ml. Interrupted flow. So how do you interpret this? How do you interpret this in this particular patient?
Sir, patient flow is interrupting, So during voiding, there may be some obstruction in the urethral level. So patient may have the detrusor sphincter dyssynergia along with
Possible.
And
That is one.
other
Or-
may be patient have some urethral stricture disease associated with
Sorry,
it.
sir. Don't even say that. Don't even say that.
Sir, patient may having poor detrusor function. The patient is voiding with abdominal straining pattern.
I agree with that. So he can have a very poor detrusor, no detrusor contraction, acontractile bladder, young boy trying to strain and empty. Or
Yes,
he has
sir.
got an intermittent obstruction to his stream and the detrusor is functioning.
Yes, sir.
The most common way of looking at this problem.
Yes, sir.
So now what do you want to do?
So I want to do invasive urodynamic study and with if facility available, video urodynamic study.
Okay. So do we have a video aerodynamic or separate study? We have combined study, video aerodynamics, or separate video MCU and separate aerodynamics?
We have separate MCUG and urodynamics.
Okay.
Okay. Okay. So they don't have that. So they, you ask whatever you want, they'll show it.
You want an MCU or a urodynamic?
Sir, I want a
Urodynamic.
MCU and urodynamic study, sir. If separately, then I will have a MCU first. Yes, sir. Some the yes, sir. Lateral films. Any post-void films?
Examiners, please note we have 7 minutes left.
Yeah.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. So on the so on the MCU films, on the scout film, there is no obvious bony abnormality or no radiopaque shadow in the QB region. In the MCU films, we are seeing the bladder morphology is altered and it is oblong shaped.
Let me interrupt. You don't say no abnormality. You have a very clear abnormality of the
Fixation. Yes, sir. Pressure screws, sir, in the spinal vertebral level, sir.
Don't pass it.
And the yes, sir. So the bladder morphology is altered with trabeculation and seen, and the bladder is oblong shaped, and there is bilateral vesiculotic reflux in. There is opening of the bladder neck, but there is hypertrophy of the bladder neck with dilatation of the posterior urethra, and dye could not. So next film, and the dye could not be seen. So I can see the excretion of the dye in the anterior urethra, but the posterior urethra is still dilated.
See, very, very important to use English and terminology correctly. Is there any excretion of urine in MCU, of a contrast in MCU?
No.
Does the contrast excrete in an MCU?
No, sir. Contrast is voided, sir.
So why are you saying excretion? Excreted in urethra.
Yes.
Now put the whole picture together and tell me what are the key findings here.
So there is neurogenic change in the bladder with bilateral vesiculatory reflux, and there is posterior urethral dilatation. And
when did the reflux occur?
Go back to the first film.
First film, sir. Sir, in this film, the bladder neck is opened, sir. So during the initial, so during the installation of the dye.
Yeah, the reflux has started occurring during the filling of the bladder.
Filling of the bladder.
Without any voiding?
Without any voiding, initiation of voiding, sir.
Yeah. What does it indicate?
Sir, this is the more unsafe quality of for the upper urinary tract, sir.
Is it low pressure reflux or high pressure reflux?
So it is a low pressure reflux.
We think so. In neurogenic bladders, with a thick tuberculated bladder? How would you answer that question? Can you answer it on the basis of MCU?
No, sir. I will like to have urodynamic study, sir.
But what is the significance when in endogeneic patient you start seeing this when you're filling the bladder?
Sir,
what does it tell you about the future of the upper tract?
Sir, so the patient may not the patient may require more stringent follow-up than the usual patients, and patients more likely to have pyelonephritis than other similar type of patients, and patients may require ureteric implantation more sooner than the others. And
that don't go into that area. That's very first let's figure out what we are dealing with before we start operating on this space, which is very rarely done. So now next film. What is this picture?
So these are the right
It is a
oblique.
voiding film.
Yes,
This
a
is a
voiding
film.
Voiding films, and in the voiding films, I can see the during the voiding films, the dye is seen in the anterior urethra as well, and in that phase there is also reflux. And
are you happy with the way the stream is?
Because the posterior urethra is also dilated, and there is some narrow area is seen in the membranous urethra, prostromembranous junction, membranous urethra, site of membranous urethra.
So what you want to know? There is a sudden abrupt narrowing of the stream beyond the sphincter, correct?
Yes, sir.
We do not know whether this is a genuine dyssynergia or it is not. That's what we need to figure it out.
Yes, sir.
Yeah.
Yes, sir.
Next.
Show urodynamics.
Surya, can you put urodynamics?
Yeah.
Oh my God.
EMG tracing could not be.
No, forget about EMG. I'm never a great fan of EMG. It's a useless investigation. But there is a problem with this CMG trace. Yeah, tell me let the students tell me.
Come on. We don't have much time.
Yeah. Sir, during the filling phase, sir, I can see the detrusor pressure is going much more than it is going at approximately to 80 centimeter of water, and during and after the initiation of voiding,
how do you read a CMG? What are the essential things you want to know when you interpret a CMG?
The filling rate. What was the filling rate?
What is the usual filling rate used for neurogenic
We will
patients?
start with a normal saline, which is at a room temperature, and would be started from 20 ml filling rate, and then
we are dealing with whom?
Neurogenic.
We are dealing with
neurogenic.
We are dealing with an adult. We are dealing with a child.
Child. In this case, is a child. So we have to calculate the expected bladder capacity, and the expected capacity by 10 would be the ideal filling rate for this case.
So that is what, sir. Once I tell you, you don't lose marks, isn't it? Correct?
Yes.
No. But anyway, we have to hurry up. So
yes.
Fine. Go ahead.
And then we have
then
to.
What are the? Just tell me what is the problem with this stress.
So there are uninhibited detrusor contractions during.
No, I'm not asking abnormality. I'm saying there is an issue with this CMG trace. Quality wise, are you happy with the quality?
Pressure, zeroing of pressure.
One is that the pressure has been zeroed to bladder.
Bladder.
So that's the one thing. What next? What is the next issue? Because it's so important, because the subtraction is not proper, the whole CMG becomes meaningless. How do you decide whether the subtraction is happening correctly?
By asking the patient to cough during the study.
So when do you cough, what are you seeing here? Is it matching?
No, sir. The matching is not proper.
So why does it happen in these neurogenic bladder patients? Anyway, so you go and read about it. So now the question is, let's assume that this place is correct, and now interpret. Go ahead.
So there are unlimited retrosal contractions during the filling phase.
Where did you see those contractions? Is there any contractions you saw?
No, so actually there is loss of compliance. The pressures are rising.
At each increment, whenever they have the pressure has started rising.
Yes.
So what volume the pressure has gone? Which volume? What pressure?
So at it's not very clear. 51.
Volume. Is 54 here. 140 ml.
Sir, around 160 ml volume, it has gone to 54, sir.
So very quickly.
Yes, sir.
Very small amount of fluid has gone in, and the pressure has gone about 30, 20, 30, 40 centimeters of water. And
Yes, sir.
we do not know whether because there is no flow tracing here properly, that whether there was any leak, the leak occurred or did not occur. So it's a very, very poorly compliant bladder.
Yes, sir.
And then
Yes,
what happened during the voiding? I think they have probably given a command for voiding, and then what happened? The detrusor line had just plummeted down, isn't it?
Yes, sir.
And there is just a straining seen on the abdominal and the PV cycle. And the lines are not matching because they were never matched before. So that is why the subtraction is a problem, and the line has come off. When the green line goes down, the rectal line has been pushed out. See that there where he's putting the arrow?
Yes, sir.
The line has come off.
Yeah, the abdominal catheter is slipped out here.
Has come off, and so there is now both the top and the bottom are same. So that's the reason. Anyway, I don't want you to. So basically, let's say it's a poorly compliant bladder, and he's not generating any voiding contraction. That's what probably we can interpret. Now, what do you want to do? Hello? Quick.
Sir, we have very few minutes left.
Yeah, that's what I'm asking. They're not answering.
It's a difficult case. Neurogenic bladder
Okay,
usually not.
fine. So now what we have shown here is, with whatever information we have, that this child is at a very severe risk of upper tract dilatation and losing his renal function, because he's got very poor compliance and he's got a very high leak point pressure, very quick, the volume specific relation, the safe period is very short. So obviously this child would need a CIC with full dose of anticholinergics, very close monitoring to make sure that the pressures come down. If the pressures don't come down, he will require treatment, additional treatment to bring his pressures down. Don't get fooled by his creatinine. 0.8 is not normal for this child. You know, if you calculate his body mass, you will find his creatinine is high. So this patient needs to be very, very properly treated, and still there is a chance that we may be able to salvage him. So go ahead next.
But his bowel care also has to be taken care of.
Bowel, bladder, No neurogenic bladder patient is managed by single person. It is always a multidisciplinary approach. He will have a gait issues. If the gait is fine, otherwise, multidisciplinary treatment is always required. And very close follow-up. He'll require close follow-up with repeat urodynamic studies. Okay, right.
Thank you, all the candidates. May we have the next set of candidates, which is going to be the last case for the day. Navneet, if you can tell the name of the candidates, or the candidates can introduce themselves. Who are the candidates?
Hello, sir. Dr. Monish here.
Dr. Monish, keep your video on. Who's the next?
Yes, sir. Good evening, sir. I'm Rajshekhar.
Okay, video on, please.
I'm Dr. Naveen, sir.
Okay. Monish, Rajshekhar, and Naveen.
We'll start the case details.
Yeah, over to you, sir.
Here is a 68-year-old male patient, resident of Hyderabad. He's a businessman, presented with chief complaint of nocturia in daytime frequency since 1 month. The patient apparently symptomatic. He developed nocturia for 4 to 5 times, daytime frequency 8 to 9 times, associated with this 1 month or not 3 months, associated with frequent episodes of urgency. He is on cylinder since 1 month. No history of hematuria, lithuria, dysuria, fever, or pain abdomen. No history of loss of appetite, loss of weight, and no history of backache, bone pains, hemoptysis. He's a diabetic, hypertensive, no other comorbids. He underwent lab polycystic 10 years ago. No history of allergies. The vegetarian, sleep disturbed, bowel habits regular, occasional alcoholic. General examination.
Occasional alcoholic.
Yes, sir. Occasional alcoholic. Sir.
That cannot be a term, no? You are not alcoholic if you take occasional alcohol. So don't call it
social drinkers.
Alcoholic.
Social drinkers.
Social drinkers.
Wrong.
Is no failure. ECOG performance is 1. BMI is 27. Abdomen is flat. Nothing remarkable. External genitalia normal. Rectal examination. Sphincter tone is normal. Rectum is empty. Grade 3 prostatomegaly with rectal mucosa freely mobile. Left lobe there is a nodule present. Median sulcus is felt.
Yeah. Okay, what is your differential diagnosis, students?
Let Dr. Sood take over this.
With hard nodule in the prostate, sir. My first differential diagnosis would be CA prostate.
So, with the hard nodules in the prostate, CA prostate, your one diagnosis is there. Anything else, or the grade 3 prostate? And
it can be granulomatous prostatitis.
That can be. Now, what you will do?
With the hard nodule, I would like to evaluate the patient with the serum PSS, sir.
Okay. Serum PSA. You will straight go for serum PSA, or you will in any presentation you will start with serum PSA, or only
urine
focused. So that is important. Patient
Doctor.
Rajek. Yes, sir.
Frequency nocturia. You picked up a small nodule.
Yes.
All right. He definitely needs workup for that, but you've forgotten about this frequency and nocturia completely.
Yeah.
I ask you a question. What is the specificity and sensitivity of a rectal finding in detecting CA prostate?
The sensitivity will be around 30 to 40%.
And specificity? And specificity, if suppose I feel a hard nodule, what are the chances that it will turn out to be CA prostate? Anyway, proceed. Find out the answer.
I think there is a word called suspicious nodule. If you have a nodule, DRE, you find a nodule, you can suspect.
So, okay. Now tell what you will do?
Urine microscopy, sir, with culture sensitivity and complete blood picture and RFT.
Okay, so this is the urine microscopy routine, and
RBC,
there are RBCs. That
RBCs of 8 to 10. Urine culture, I would like to send.
culture has been, yeah.
Culture is
PSA is.
one serum PSA.
Yes, sir.
PSA next.
3.04.
Yeah.
The serum PSA is raised. I would like to confirm his diagnosis.
You will go for it now.
I'd like to check his coagulation profile.
Coagulation profile. Anything else
Sir, I'd
nowadays
also
you do?
like to have a sonography of the abdomen pelvis and a uroflowmetry.
And the voiding diary also, sir. And I would like to get an MRI prostate pelvis before.
Yeah,
going to
that.
bed.
So how many of you three are in favor of MRI before?
Me, sir.
So since there is a
Before
palpable nodule, so we can directly go ahead with the transdermal biopsy.
What is the role of MRI before biopsy
If the
or
initial
after biopsy?
if the initial biopsy comes as negative, then we can go for MPMRI, sir, before going for second biopsy.
So you think that first you do the biopsy and then go for MRI?
If
Same
the
case
person,
of same case nodule is not palpable. So then in that case we can do a MPMRI so that we can do a systematic 12-core biopsy and also extended targeted biopsy of that nodule. But if in this case the nodule is palpable, then we can straight away go with transguided biopsy.
So in the case when nodule is palpable, you don't do MRI before biopsy.
So we can do, but
what all information MRI will give and what MRI you will do?
multiparametric MRI.
Multiparametric MRI. Okay. If you have 1.5 Tesla?
1.5 Tesla is sufficient, sir. If we have 3 Tesla, it will be very good.
What is
But
the
even
difference?
1.5 Tesla is sufficient.
The MRI for CA prostate is sufficient with 1.5 or you add something?
Endorectal coil should be there.
And what is the role of endorectal coils in 3 Tesla?
Even
They
with
are not required. So even without endorectal coil, the sensitivity is
Yes, that is right. It is not required. So if you have 3 Tesla, you don't require endorectal coils. So what you will see in the MRI? We have just bypassed
in this
other
case,
things.
sir, I will do MRI for local staging, not yes, sir. For local staging, I will do MRI. So I will look for any means any mass in the prostate, any suspicious mass in the prostate, its extent in which lobe it is present. Is there any extracapsular extension? Is there any seminal vesicle invasion? Is there any neurovascular bundle involvement?
Also, the pirate scoring is important in MPMR.
Yeah, pirate scoring. Which is the pirate scoring?
So it takes into account the T2 weighted images and the diffusion weighted MRI. And based on the probability of a malignant nodule,
Not confirmed.
What is okay? So multi-parametric and which are the bimetric important in that? Two parameters are important. One is not considered that important now.
so T2 weighted is important and diffusion coefficient.
Yeah, and spectrum is not important.
Yes.
So in this, how the versions have changed of pirate?
So now there is a Pirates version V2. So it is more objective. So they have given a specific score to the specific sequence. So previously it was more subjective. So now with the new version, it is more objective, the 2.1 version.
2.1%. Now, what is the position of Pirate 3 in that?
So Pirate 3 is suspicious of malignancy and it warrants a biopsy.
Pirate 3, you go for biopsy, and what is the chance of picking up malignancy if Pirate 3 is coming?
Pirate 3.
Now, latest is even if in Pirate 3, the chances of getting malignancy are very, very low. Okay.
Unmute Dr. Rajsekhar. Navneet.
Yeah. Hello. Oh.
Thank you.
Yeah,
Okay.
Yeah, participants
now
are requested not to mute themselves.
And
No,
now,
my connection had gone, Navneet.
now with this information, else you see in MRI?
So we also see the size of the nodule, volume of the tumor if it is present, and
So you are talking only about the prostate.
So also the periprostatic extension, the extension
So
into the
those
subanal
things.
vesicles.
And also, what is the chances of metastasis in the axial and in the skeleton in the pelvis? You pick up the malignancies, the metastasis also local.
Yes,
Advanced prostate also you can diagnose.
Yes, sir. The
Okay,
PSA
you
is 30,
tell me
so
in
there are more chances.
biopsy. In biopsy, you tell me what is the difference in the Gleason scoring now. What is the advancement?
So nowadays, sir.
Gleason scoring now it is according to the ISUP scoring system. They have classified into 5 types. One is 3+3. The two being 3+4. 3 is ISUP. 3 is 4+3, and then it is 4+4, and 5 is
there is a different Gleason score to be given for every. So there is difference in the Gleason score given for needle biopsy and for radical prostatectomy specimens.
What is tertiary Gleason score?
So tertiary is the third common pattern which is seen in the biopsy specimen.
Okay. Other than now you were asking about ultrasound and uroflowmetry. Can we get those reports? Yes. So you were asking this.
Yes.
Anything you want to say? Yeah,
Euroflow seems to be normal. The wadded volume is 340 ml. Maximum flow is 24. Average
this is
40.
very clear. Bell
Yes.
shape curve is already okay.
Normal bell shape
volume.
curve.
Next. Okay. What is ultrasound? Yes. Ultrasound. You give the report quickly.
So it's a prostate is 45 cc prostate, grade 2 prostatomegaly, and he is having some simple left renal cortical cyst of 3.5.
That is fine. Now you wanted MRI also, or biopsy first. What you want now?
Post-void residue.
Post-void residue. You expect that post-void residue will be large?
30.
No.
How much is it? It is not much. Next. Now tell me what you want to do. Now after this you will go for?
Cross-guided biopsy.
Biopsy you will go, not MRI. Still not convinced. Okay. Give them biopsy report. Yeah. So it is
3 cores on the right side, left side 4 cores. Core length is 0.3 centimeter to 1.2 centimeters on the right side. Lesion 4 plus 3, which is 3 cores positive on the right side. 40% cores are positive, no PNL. On the left side 4 cores, core length is 0.6 to 1 centimeter. Lesion 3 plus 4, ISUP2, 3/4 cores are positive, 75% cores are positive, no PNA.
Okay, so now you know that 4 plus 3, they have reported 7 cores. 7 cores. So 6 out of 7 cores are positive. Okay.
According to risk stratification, he will come into high risk group, sir. According to DMECO classification. So he requires further metastatic workup with MPMRI and bone scan.
So now you will do MRI. So what was the advantage? I was MRI should be done anyway. You are going to do MRI and you are going. They are asking. Yes. Yeah. These are the T2 weighted images and okay. Now show the image to them. Yes. What do you want to see?
Even weighted images, mostly they are used to know if there is any bleeding post biopsy to rule out that. In T2, we have to see if there is any hypointense lesions in the peripheral zone. But here there is some lesion in the central zones in the T2 weighted images, which is hypointense.
So anything else you are seeing? No. Any lymph nodes you are seeing? Where you see the lymph node? Where you see the seminal vesicles? How are they?
Seminal vesicles towards the base of the bladder we have to see. Here the lesion is from the seminal.
Okay, give them the report.
Prostate is enlarged with heterogeneous predominant T2 hypointense nodular lesion in the central zone with
that you saw.
And contour bulge left to more than right lobe, mild haziness along the capsule in the anterior-inferior aspect of the prostate on the left side, no significant enhancement of the lesions. Even hypointensities within the right lobe represent hemorrhagic foci. No evidence of pelvic lymphadenopathy.
You will do now. You see there are hemorrhagic foci also, and if you had done this MRI before, these were not going to be there most probably. So now what you will do?
So bone scan will be required for the metastatic work.
So now the question is, after MRI, you want bone scan. That is fine, bone scan. And anything else also you can do?
CCT abdomen and pelvis, chest X-ray, LFT.
Why CCT abdomen?
So to look for the non-regional lymph nodes can also be there, or any other liver metastasis, visceral mets.
So that you will not know if you are putting the patient in machine for MRI.
This
can,
MRI is only of pelvis.
So that depends on you. You have ordered only for pelvis. You ask for pelvis. So if you are doing any other investigation you can do nowadays.
So the PSMA PET scan we can do. So it will be a single investigation. It will give idea about the bone mets as well as the visceral.
So after MRI, you do biopsy, and after that biopsy, when indicated, you go for PET CT, PSMA. That is if asking once can give them one. Are you satisfied? There are multiple nodules were there. PSA, how much was there?
30.
30. It was more than at least 20. No? It is 30. And Gleason is also
4 plus 3 highest.
4 plus 3 you will consider the high side. Okay. So are you satisfied with this? This is what kind of disease is this?
This is a high risk disease.
High risk localized disease.
Localized. And I say at this stage, the patient has lymph nodes, lymph node, maybe the lesion in the visceral lesion can be there or not?
So maybe there because
PSA is 30, it is a
false
high risk.
negativity rate of MRIs.
So that is why nowadays, if available, you have to say if available, PET PSMA can be done. That will find out you the skeletal as well as visceral mets. That is one advantage of that. Okay. So according to this is coming in high risk, and now what you will do?
Sir, also
has been done. Okay, next. Tell.
Looking after his life
Assess the
expectancy.
performance status and life expectancy of the patient.
So what is the age?
67.
67. And patient has comorbidities?
Diabetic and hypertension.
Okay. And patient is already for 4 years on treatment for diabetes and hypertension. Okay.
Yes.
So no other comorbidity is there. So tell me, there is not much you can control diabetes, you can control hypertension. Patient is in the right age. What you will do?
So I counsel the patient about
life
the
expectancy.
Pardon?
So if patient's life expectancy is more than 5 years, we can do either radical prostatectomy with pelvic lymph node dissection.
5
we
years.
will give him the option. We will tell him the pros and cons of either surgery or radiotherapy with hormonal therapy.
You see the life expectancy 5 years?
Why did you say 5 years?
So for in NCCN, sir, for high risk disease, if it is more than 5 years life expectancy, then
For what age?
it is divided. Yes, sir.
What age? What age group?
So for any age group, the life expectancy, if it is
No,
more
it is
than
not
5 years
any
or
age group. It is not
Why?
any age group.
Why do we consider life expectancy when we are treating prostate cancer? We don't
Well, sir,
consider that for many other cancers.
So because it is an indolent disease. So
indolent disease
even
will
for
kill
after active. So sir, even after 10 years of active surveillance, the survival benefit is same compared to surgery or radiotherapy.
Yeah,
So
doctor.
that is why it is a long term.
But in this patient at this age, is this patient for active surveillance?
No, sir. In high risk disease,
Those
there is no
those criteria, are we going to apply those criteria on that? This is high. You yourself told this is a high risk.
Yes, sir. In high risk, there is no role of active surveillance.
So the
Yeah,
patient
we
is
agree with that. A high risk disease need treatment.
treatment.
Yes,
So life.
Hello, am I audible?
Yes.
Hello. Yeah. He mentioned about one thing, that is indolent nature of the disease, looking at the lifespan. How do you make a prediction that the disease is indolent from the histology? Gleason 7, can you predict this is an indolent disease?
No, sir. This is a high risk disease.
High risk disease, we do not utilize the term indolent.
Yes.
That's the impression I wanted to give. Please go ahead, Raju.
So I think the right sequencing, you should understand how to present. This is definitely a case which needs treatment, can be controlled. Comorbidities are under control, and patient is in the right age to get treatment. Now, what you are planning?
So I will counsel the patient about the various treatment options, and he will counsel that he would require a multimodality treatment because it's a high risk disease. So we tell him the advantages and disadvantages of both surgery and radiotherapy.
What is your preference?
So radical prostatectomy will be the first preference, and if required, then salvage radiotherapy, or if required in the postoperative.
When it is required. Yes.
It is in that your interest or patient's interest?
So patient's good interest.
How do you
You should have a shared decision making.
How did you come to this conclusion that this patient will be better served by radical prostatectomy? On what basis?
Generally, it has to be shared decisions. We have to give the patient.
Yes, sir. I'll counsel the patient for the same.
No,
I'll
no,
give the advantages and disadvantages of both.
I am trying to find out, is there any objective way of figuring that out? What are the issues with offering a radical prostatectomy in a so-called high-risk disease?
Sir, there are more chances of requirement of the adjuvant therapy in the form of radiotherapy.
So you've done a disservice to the patient by offering him radical prostatectomy. If you didn't figure it out before, then what are the chances of him having 1, 2, 3, 4? What are the chances of having extracapsular disease? What are the chances of him having lymph node metastasis? All this thing can be predicted.
So I'll counsel the patient that he require multimodality therapy, and most probably he might require adjuvant therapy after.
How can you counsel when you don't know yourself that he will ask me, tell me what are my chances that the treatment, that you will do my operation and my all things will come negative.
Lymph node
will be negative, my lymph nodes will be negative. How would I know?
So prognosis, we can calculate the prognosis using some nomograms.
So that is, you need to be very clear about it, isn't it? You can't just say I'll counsel all. It has to be very proper that how I counsel, what data I have. You have no PSMA PET here. You know, you have had some investigation. Based on that, you will be able to predict to some extent what the prognosis and what you are going to have, so that you can counsel the patient. Okay, go ahead.
To predict the risk of lymph nodes, sir, we use the Briganti nomograms, and the Roche nomograms are available.
So you will go for radical prostatectomy. Now radical prostatectomy you do with the lymph node dissection, and what is the extent?
So lymph node dissection will do, the superior extent will be till the bifurcation of the iliac vessel, and inferiorly till the pubic bone. And since this is a high-risk disease, we'll do extended lymph node dissection in this case, in which case we'll go 2 centimeters above the bifurcation of the iliac artery, and laterally till the genitofemoral nerve, and medially till the bladder.
Now you operated and your lymph nodes are negative and the margins are positive.
If the margins are positive, then we have to advise radiotherapy for the patient.
So we'll see that whether it's a microscopically positive margin or it's just a focal margin is positive.
And after this biopsy report, you will follow with PSA also?
Yes, after the radical prostatectomy, we'll be doing a serum PSA at 3 months.
After 4 to 6 weeks, we have to get first initial PSA, sir, after radical prostatectomy.
So now, just show the PSA. This is the biopsy report. So biopsy is margins are free of tumor. Okay.
Margins are free. No PNI, no lymph node image.
And PSA also. Next slide, they are showing. Yeah. PSA is at 1 month as well as 3 months, 0.01. How you follow this patient?
We have to follow the patient first initially after radical prostatectomy at 1 month with PSA, sir. After that one, 3 months, followed by 6 months, and every 6 monthly for the next 3 years with serum PSA and history and examinations.
The PSA becomes 0.1.
Then we have to find out whether
we will again repeat the PSA, sir, after 1 week.
Okay, after 1 week.
Yes, sir.
Okay, when it becomes significant?
So if there are 2 consecutive rise in PSA.
And any value also?
So it becomes detectable. Yes, sir.
Detectable means what is the value? 0.
Biochemical recurrence is defined as more than 0.2 after radical prostatectomy, and two consecutive readings more than 2 weeks apart.
Yeah. So PSA is rising. What you will do now?
Then we have to know what is the cause of the rising PSA, whether there is any local recurrence or whether there is any micrometastasis. So with such a low PSA, only diagnostic test which can find out the lesion is PSMA at the present times.
Yes,
Is it early recurrence or the late recurrence? When did the PSA rise? That is very important.
So which PSMA PET you will be doing?
Gallium.
Local recurrence, and which you will be preferring for skeletal metastasis?
For local recurrence, gallium PSMA PET will be used. So for skeletal, choline
PSMA PET will be.
fluoride.
So actually, these are the things which you have to read, and suddenly some questions can come in this direction. And what is the treatment if PSA is local recurrence?
So if there is a proved local recurrence, then we can go for a salvage radiotherapy along with androgen deprivation therapy.
For how long you will give androgen deprivation?
So since this is a high risk disease, we'll give for 3 years.
There are 3 values: 6 months, 1 year, 3 years. You will follow after radiotherapy.
So since this is a high risk disease, then we'll give it for 3 years.
There is no metastasis. So 6 months to 1 year is sufficient for this. The local disease, local recurrence is there, and if it is metastatic.
If it is metastatic, then patient requires lifelong ADTs, along with
Which one you will prefer?
Dr. Rajiv, a few minutes left.
Okay, which one you will prefer? Final, we are at the final stages.
So we'll talk with the patient and explain both surgical castration as well as medical castration.
What is the advantage and what is the harm of surgical castration?
So surgical castration advantage is it immediately the hormone control is there. Secondly, it is the cheapest method to achieve the androgen deprivation therapy. And,
okay, immediate hormone control is there. Advantage is there is no surge of in the androgens, but where that is important.
More important in case of impending cord compression or.
And what is the disadvantage?
It is irreversible.
Disadvantage is irreversible.
And it
so
gives
we cannot
irreversible, psychological, and one more new thing has come, because you are talking nowadays about antagonists also.
So more cardiovascular risk as compared to the LHRH.
More cardiovascular risk. Nowadays, new study has come that it increases FSH like other agonists.
Yes.
So, like we were thinking that it will decrease the FSH, but in surgical castration, FSH goes high. So, if that theory is correct, which has been put forward, then bilateral orchidectomy, the cardiovascular risk will be more, and the risk long series has come of thousands of cases where they have found that cardiovascular risk is increased. So that is also nowadays considered. So anybody else wants to ask anything?
No, I have only one small opinion from all 3 candidates. I want to know their view. This is a localized prostate cancer. All of you will agree. Yeah. What are the other options available, and how do you have a sad decision making for other options?
So other option will be
besides medical prostatectomy. Definitely, there is a preferred options by all of us as urologists. What other options we can offer, and what sort of counseling we can give with each option? This is the final question we'll have.
In high risk disease, sir, the other option is radiotherapy, along with androgen deprivation therapy for 2 to 3 years. So, sir, I will counsel. Sir, first I will tell him the benefits and harm surgery, and then the pros and cons of radiotherapy. So mainly, So surgery is a one-time procedure if there is no high-risk features.
Did you
Final
see here
histopathology.
the final pathology report?
Yes, sir. If there is no high-risk feature in final pathology
No.
report.
The final pathology report reported what?
Yes. So margins are negative. Then
No.
PSA is undetectable.
What was the Gleason score?
3+4.
Gleason
So
3
did
plus
it
4,
remain a high risk?
no PNI.
Did it remain high risk? It is.
So it was T2. So
No, the only reason why you went on a high risk because the PSA was more
Yes,
than
I was
20.
not.
Yes.
All right.
yes.
And the PSA was not repeated.
It was repeated, so it was 0.01.
No. Initial PSC.
No, initial PSA was not reported.
It was not repeated. So the entire decision of high risk went on the basis of
30 PSA.
single PSA report, which is never accepted. Very, very important to consider all this.
Also, it was a high volume disease, and
How
That
it is
is only-
higher volume?
so all the cores were involved, and
But they are
based on
all
the MRI.
Even less than 50% cores, and they are not done even a full core biopsy. There
Seven
will be
core.
7 core biopsies available. So the staging was not complete, and to call it a high risk disease was only on the basis of a single reading of PSA. The final pathology consider the unfortunately the radical prostatectomy. That's a different ballgame altogether. The question is, never forget, till today, not a single study has shown a benefit in survival over long term, overall, either cancer specific or overall survival. So you want to be very careful in making this decision. Then I would say that the candidates completely forgot. Now it's fine, you done a radical prostatectomy. We had a microscopic hematuria. We didn't evaluate it that time at all. So you can't forget a patient. The patient has to be looked in complete totality. So that is one thing. And I think thank you very much.
Thank you, sir. Thank you. Thank you, candidates. Yeah, thank you.
Thank you, sir.
Yeah. Now almost we are coming towards the conclusion of today's webinar. I'll just request first President USI, Dr. Anant Kumar, then Honorary Secretary USI, Dr. Rajiv, and then Chair ISU USI, Dr. Rajiv Sood, to give their comments. And then I'll request Dr. Surya Prakash to propose vote of thanks. Anant Kumar, sir. Yes, sir. You are unmuted, sir.
It's not audible.
Anyway, thank you very much.
Sir, stay for a while, sir. Yes. Sir.
Yeah. So
Yes, sir.
I would like to that it was not as good as it could be possible in physical way, but looking at such a situation in pandemic era, still it is a good exercise. There was some deficiency, and I think it will be covered up. But I must say that it was an excellent job done by the ISU, Dr. Sood, Dr. Chawla, Dr. Sood Prakash. Dr. Sood Prakash collection of cases were excellent. They had all the practical cases which are invariably are in the exam, and with all the reports were available. So I would like to say something to my students. One thing is that in exam, it is very important when question is asked, don't start replying immediately. Just give 30 seconds thought. Examiner is watching you. He won't be impatient. And just think what is asked and give the precise answer. Just to give you example, if I ask what is your name, just think over and give your name. Don't say that, oh, my father kept the name, I didn't like it, so I put this name, I changed my name. There is no need to start explaining the answer. If the examiner is not happy, he will ask the explanation examination. Because when you start giving explanation from very beginning, you get caught and you open other options to catch your leg. So don't do that. And second thing is, you have read, you have knowledge, you have to see the practical things. Exam is just to know that how you all the theory and all the experience in that to give answer to that. And exactly, it is not wrong to give the answer what you have seen in your center, what you are confident in telling it. What if examiner asks, you can do that. You should know other options, but you should give the options which you think you can defend and which you have seen and which you know about it. And it is very important to be very precise. Do not give any other answer which is not asked, because then you open yourself to some more questions where you may falter. So very precise, think over, give the precise answers, and you'll be all right. And then it is very important to say, when patient is asked, how will you evaluate? It is not necessary you have to do all investigation. You should only tell what are the relevant investigations. These are the relevant investigation which, it is MCH exam, it is not MBBS exam. You have to tell everything, but those which are relevant should go one by one. And it is not necessary to do ultrasound first and this. If CT is required, then CT will be finally required. So straight away you can go for CT with your possible diagnosis and you will get the answer. And that is not that you are doing an exam. We do in our everyday things also, and that will be accepted by the examiners. So this, I'm very sure you will do well in exam. And I know all the candidates were not accommodated, but we will do similar exercise after some time, and rest all will be given a chance to listen to such kind of practical exam, listen to all the examiners. End of that, all the examiners have summarized the things and what you are supposed to do. So it is very important to develop your communication skill, understand the whole problem, and then give a very precise answer. So with that, I would like to thank again the ISU team for doing an excellent job, and Dr. Surya Prakash for collecting such a wonderful cases with all the investigation, and as well as Dr. Chawla for coordinating it very well. As well as I'll wish all the best to all my DNB and MCJS students who are preparing for the exam for their great future and success in their upcoming exams. Thank you very much.
Thank you, sir. Thank you for your encouraging words to all the postgraduates. And Dr. Rajiv TP, Honorary Secretary USI.
So I was, in fact, watching through the whole program, and I could find out that around there were more than 200 viewers for this practical examination. I think apart from the residents, some teachers, their own teachers has also chipped in to view the performance of their candidates. But anyway, to my
Voice.
Can you hear me?
Yes, yes.
The thing is that even though this was not a physical practical examination, but it was the first time that USI is conducting such a virtual practical examination for the residents. But I appeared to be really an exam only. It didn't have any way, but always when you hold a virtual meeting, there is always some difference with a physical one that one has to take into account. But the hiccups, because this is absolutely conducted by the USI on its own platform, but the hiccups were very little, because such hiccups I have found even in international webinars also, which is happening nowadays. The hiccups are much more than what we are having. And I hope that most of the examinees were benefited. Some registrants were left out, but definitely they will be given a chance. I assure you, in August itself, we will hold one such version of the practical examination, so that the other final year students who have left out, who could not appear this time. My heartfelt thanks to Dr. Surya Prakash, my friend, and Dr. Arun Chawla, who were constantly discussing the things with me for the last few days, even last night also. So, video call on WhatsApp. students, and we finalized quite late, and it was after that only it was circulated to all the faculties and the students. And a lot of work was done by Arun Chawla, Surya Prakash, under the guidance of Dr. Rajiv Sood, and they were always coordinating with the day in and out. I really extend my thanks to, on behalf of the Council of USI, to the convener and the co-convener, and my thanks to all the panel of examiners who were here for having spared their valuable time. Today is a Sunday, they have spared the whole day for being with us. Again, I thank them on behalf of the Council of USI, and I hope they will also come forward for sparing their time in future to help USI. Thank you all once again.
Thank you, sir. Thank you very much. Thank you for your nice and kind words. Dr. Rajiv Sood?
First of all, I congratulate all the residents who got engaged, and they made this program successful under the able guidance of Dr. Anant Kumar and Rajiv DP as President and Secretary. The work done by Dr. Arun Chawla is to be appreciated from core of my heart, because it was his baby, basically totally controlling the whole program in collaboration with our secretary, and the way, the flow chart, the instructions, residents, and through Mr. Navneet's team, which has helped from USI office, commendable. We don't have any special software. People are selling their software for this. But what USI has done, it is exemplary, and many people are going to follow, and USI is also going to follow this. And this may become the norm. About the residents, this exercise has given one insight as a whole, because when we go to the examination center and they conduct our exams, then only 2-3 examiners are there and students are there. But here, from all corners of the country, everybody is saying, the residents are also saying the performance of fellow residents, and that the way it was conducted, it was looking like a real exam. It is just short of that, and we are going to improve on this in future. What is important is sequencing. My message is that all residents, whether they are taking the history, when you take the history in the real exam, you write on the paper, and it is not necessary, as Dr. Anant Kumar was also mentioning, to speak everything, because you just see that you are seeing the patient in the hospital, in the clinical situation, and then don't waste time of half an hour or 1 hour in just history. So you have presented and if asked, you can show that you have already taken this history. The second is sequencing of the investigation. I'll say that always remember that basic examination and non-invasive, at least ultrasound or whatever is there, or whatever is non-invasive, that is must. And after that, you go for the specialized investigation, as Dr. Whichever is the best investigation, you can straight away also mention. So with this, we are having many webinars. We started already webinar, which was great success. These exams have started, and e-assignments and e-assessments are going to be the norm for Indian School of Urology. We are going to give the rewards and rewards accordingly, and this will be the future. And all the best to all the faculty and all the residents and Urology Society for future. Thank you. Thank you, especially Dr. Chawla.
Thank you, sir. Thank you for your very encouraging words. Before I give the mic to Dr. Surya Prakash, a few words. First of all, I appreciate all the postgraduates sitting through the whole day for the sessions. I think your presence for the whole day is a big motivation for us. You have to understand that USA is striving very hard to for the exams, but make you coherent in your thinking, make you coherent in your approach to the patient, make you use a proper urological language. What we have decided is along with USI is that you are very expressive when you go to the conference. You make your presence feel to others by good questioning, intelligent questioning, and probably you are at par with the international urology residents. So when you are appearing for your fellowship exam, or when you are going abroad to attend your conferences, this is the way we have to go periodically with these exams. You improve your communication skill, you gain from the knowledge of the various faculty, you express yourself in a proper, very coherent urological language. That is the basic aim. But at the same time, we are aware of the fact there were few technical glitches. We are cognizant of the fact that all candidates could not be accommodated, but Dr. Rajiv TP has already showed there's going to be in August, and probably he is thinking of planning is a periodic affair, so that you don't lose your exam feeling touch. So you are all the times made to remember the terms, the proper terminology, the urological language by facing again and again different faculty 3 to 4 times in a year. That is basically the what Dr. Rajiv TP and Dr. Rajiv Sud have already decided. So I thank you from the bottom of the heart. For official vote of thanks, may I request Dr. Surya Prakash to let you know has gone to the hospital to get the angiography done, but still has stayed for the whole session after coming back from the angiography suite. So I appreciate from the bottom of the heart staying for the whole session. Thank you very much. Over to you, Surya Prakash.
Thank you very much. At the outset, I thank he has been there since morning, and with all his vast experience, he has given valuable advice to the postgraduates, and I think postgraduates are very lucky to have the president of USI be in the whole session and giving valuable advice. Thank you very much, sir. And I also thank our young and dynamic secretary, Rajiv Tepe, sir. When I asked him last year, without any hesitation, he immediately obliged and said that, okay, you will be doing this program in Hyderabad next year. Of course, because of this adversary situation, we could not do this physically, but he has been always encouraging. I think the USI has seen a new era under his secretaryship. He has been very aggressive, very dynamic, and thank you very much, sir, for giving us the opportunity to do this exam online. I also thank Rajiv sir. He's always in the forefront for academics. His brainchild is ISU and Euromed. I've seen him. He always encourages anybody who wants to do academics and exams like this. Thank you very much, sir, for your presence and for giving valuable advice. And I also thank all the faculty who have spared their valuable time. Dr. P.V.L. Murthy, sir, Dr. Keshav Murthy, Dr. Hemant Patak, Dr. Ravindra Sabnis, Dr. Dateshwar Hota, Dr. Anish Srivatsava, Dr. Shravan K. Singh, and Dr. Nitin Kekre. And my utmost thanks and sincere gratitude to Dr. Arun Chawla, sir. If at all this program is successful, it is only because of him. My presence was very little. I did not do anything. He gave me valuable advice. He was always there whenever I called him. All webinars, he spared his valuable time, and he guided me how to go about. My only collection was I just collected the case material. Thank you, Arun Chawla, sir, for your guidance and valuable advice. And I think we can do much more programs like this in the future. I also thank my colleague here in Yashoda Hospital, Dr. Seshu Mohan, and my postgraduates who have helped me in preparing the case material. And I thank all the postgraduates. I think there were some hiccups when you presented the case. I think you can improve, because in the presence of a senior faculty like this, maybe you have some kind of fear, but I think all this is very important when you rehearse, when you practice. This will help you to in your final exam to do better. So for those who did not get a chance, who have been patiently listening, I thank all of you. And regarding, there were some doubts about questions in the chat box. I think from Rajiv T. sir will send us the questions to the faculty, and we can always answer them by email, and we can clear the doubts. And maybe if I miss anybody, I thank everybody. Yes, sir, Rajiv sir. Yes.
Yeah, Navneet.
I
Main man.
I forgot. Navneet has been very instrumental in his doing this. He has created the groups and he managed the show very well. Zoom. I'm sorry, Navneet. Thank you very much. All
And
the
in lighter vein, I'll add in the chat section, the postgraduates have given the MCH degree to Navneet. Seeing his if you see the chat section, they have given MCH degree to Navneet.
I thank our President-elect Mallikarjun sir for being there, and he has been a valuable asset for his giving valuable advice to all of us.
I have forgotten. I have thanked on behalf of the Council of USI and Navneet and Kiran. They were the backbone of all these shows for the tremendous work they have done to make this program successful. So they were working behind the screen to make this program and the platform, everything perfect without any problem. And apart from some minor glitches, which is unavoidable, they have done an excellent work. I once again extend thanks on behalf of the Council of USI. And one more thing to the residents, as we have, Dr. Arun Chawla has collected all the questions put forward in the chat box, and each and every question will be answered, and the answers will be emailed to all the registered residents within a few days' time.
Thank you, sir. Thank you. Thank you very much, sir.
Thank you.
Shall we leave the for the meeting for the day?
Sir, we can have Jan Gan Man, sir. A national anthem before.
Yeah.
Yes, yes, yes.
Gujarat, Maratha, Dravida, Utkala, Vanga, Vindhya, Himachala, Yamuna, Ganga, Uchala, Jaladhi, Taranga. तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा। जन गण मंगल दायक जय भारत भाग्य विधाता। जय जय जय
Thank you.
Yeah, thank you very much. Jai Hind. Stay safe, stay healthy.
Thank you.
Thank you. Thank you, everyone. Thank you.